will ask them questions. Or I will be here. I'll be asking you guys questions, giving you a lot of case scenarios. So, a lot of anecdotes, stories, humor. That's it. Method mirror. Right. I'll use this. Srinivas garu. Done? లోపల పెట్టి పడిపోతారు లేకపోతే all the slides are in a sequence. We don't have to change anything. Everything is in sequence. A very good morning to everyone here in the real life platform as well as the virtual platform over there. Subhodayam, Namaskaram. As you know, this is the first and benchmark insulin masterclass that ACE has envisioned and has taken up. I hope we will be able to fulfill what we wanted to when we dreamt of this. Without any further ado, we'll start with the program, and I request Dr. Mithun Bhartia, who has been conveniently sitting downstairs, who is one of the faculty members, to come and sit on the dais. Please. We do have other esteemed faculty members in the form of Dr. Murali, so my good friend, and also Dr. Kalyan, another good friend of mine, who are on the dais. Would you mind showing their elegant faces to the audience? Thank you. Dr. Mithun Bhartia happens to work in the Northeast, Dr. Murali in Hyderabad and Vijayawada primarily, and Dr. Kalyan at Hyderabad, and myself from Hyderabad. So this is going to be the program today. We're going to start with context setting. We're running about 10 minutes late, but we'll catch up fairly soon. We're going to have a pre-curriculum poll/survey as the next thing. And we do have introduction to insulins by myself, classification of insulins and insulin regimes by Dr. Murali. We do have a tea break, simplifying insulin initiation in the context of Indian realities by Dr. Mithun, insulin dose titration and optimization by Dr. Kalyan, hands-on demonstration of insulin injection technique, storage, addressing pitfalls in usage, and we're going to divide into groups here, and we want to make it as practical as possible so that people can go home and tomorrow if they were to see a patient who needs insulin, would be able to start insulin on their own and feel very comfortable. That's the idea of it. If somebody has been doing this already, the idea is to improvise their skills and improvise their confidence in dealing with slightly tricky and difficult scenarios as well. Hence the reason why we want to make it as pragmatic and as realistic as possible. Next, we do have a session on barriers for insulin initiation, titration and strategies for overcoming those barriers in, again, our real life settings, which will be dealt by me. And next would be hypoglycemia, the most dreaded thing that we all have in our day-to-day lives while dealing with our patients who need insulin or for that matter even oral agents. that will be dealt by Dr. Murali. Insulins in the hyperglycemic setting of the elderly by Dr. Mithun. And steroid-related inpatient hyperglycemia, a very important thing, especially in the current COVID scenario, by Dr. Kalyan. We do have insulin usage in special populations, be it renal impairment, hepatic impairment. We'll touch base on pregnancy and also kids as well to a certain extent, although we plan to do this as special cases another day, by Dr. K.D. Modi, who is not here yet, but will join us this afternoon. Then we do have, again, case-based discussions to see how much we learned and how we can implement that in our practice from tomorrow. So we do have 2 cases. Then we do have an open session wherein we all would discuss about various cases, questions, etc. So this is me. I'm a CCT in diabetes and endocrinology from UK. I've been practicing here in Hyderabad for the past decade, and I wish to continue the same. This is Dr. Murali, as I previously mentioned. Again, trained with me in UK. He's been practicing in Vijayawada, in the Manipal hospitals in the past, and currently working in his own setup, the lead clinics. This is Mithun Bhatia, who is an endocrinologist and sexologist. Yes, you heard it right. And he trained in UK, and he's been practicing in Northeast, Guwahati to be precise. Then we do have Dr. Gurjada Kalyan Chakravarti, who I have to say a big thanks to, because he stepped in the last minute, despite his busy schedules, to replace another faculty who dropped out. And I really mean it, Kalyan. He is a consultant endocrinologist who trained just like all of us in UK. He's a CCT holder and a consultant at Citizens Hospitals and also at Idea Clinics, Hyderabad. This is Dr. K.D. Modi, who you will see this afternoon. Is a very senior consultant endocrinologist whom you all know very well. He's a super specialist trained in India. He's a DNB and also DM. Works at Care Hospitals, Nampally. So firstly, to begin with, we do have the pre-curriculum survey. The survey questions are put there. And I will read out, for the sake of the Zoom participants, the questions. So you can try to think about the answers meanwhile. What is the HbA1c value above which we consider somebody as having diabetes according to ADA guidelines? Is it more than or equal to 6.5, more than or equal to 7, more than or equal to 5.5, or is it more than or equal to 6? I won't repeat this question because this is not Kaun Banega Crorepati. This is simple, straightforward stuff that we are all supposed to know, right? So moving on from there, what is the target A1C for optimal glycemic control in type 2 diabetic patients, say aged 50 years with no comorbidities, according to ADA guidelines? So I would like to repeat this question because I think it is important. What is the A1C target for optimal glucose control to prevent complications of diabetes in a type 2 diabetic who is aged 50 years and who doesn't have any comorbidities such as heart problems or kidney problems as yet, according to ADA guidelines? Is it less than 7, less than 7.5, less than 6.5, or less than 8? Can people there please tick on their questionnaires, please? Yeah, you're all supposed to please kindly tick and give. Thank you. What is the target fasting plasma glucose for patients with diabetes in general? 80 to 130, 70 to 100, 100 to 150, 140 to 180. I hope you got it right. When is insulin indicated? Type 2 diabetic patients uncontrolled on oral agents, type 1 diabetics, diabetes in pregnancy, all of the above. What is the gold standard insulin regime? Basal plus oral agents, basal plus insulin regime, basal bolus regime, premix insulin regime. We're asking the gold standard insulin regime. Below what blood glucose control do we consider it as hypoglycemia? Is it less than 70 milligrams per deciliter, less than 80, less than 90, or less than 100? I know these are all pretty basics. no intention to humiliate anyone, but we need to get the basics right if we really want to do what we are supposed to do. What is severe level 3 hypoglycemia? Is it less than 70 milligrams per deciliter, but still more than 54 milligrams per deciliter? Is it less than 54 milligrams per deciliter? Or if a severe event characterized by altered mental and/or physical status requiring assistance for treatment of hypoglycemia has occurred. So which of these is right? Or if you want to say none of the above, that's also fine. What is the maximum dose of insulin that can be injected? Maximum dosage of insulin that can be injected. Is it 20, 40, 60, or is there no maximum dose? We're speaking about subcutaneous injection here. What is the target A1C for optimal glycemic control in pregnancy as per ADA guidelines? We're speaking about ADA guidelines. We're speaking about optimal glycemic control. We're speaking about A1C in pregnancy. Less than 5.5, less than 6, less than 6.5, less than 7. What is CKD category 4 based on EGFR, of course? Is it 45 to 59? Is it 30 to 44? Is it 15 to 29? Is it less than 15? So I hope you got it all right. Let us come back to this again after the end of the day, after all sessions have happened. Hope you all get it right now. If you haven't, I think we should be able to get all these right by the end of the day. So, introduction to insulins. Who needs insulin and why is what I'm going to deal over the next 20 minutes. We are almost on time and we'll stick to time. Trust you, me. So what is insulin? We all know that insulin is a hormone that is produced in the pancreas by the islets of Langerhans, which regulates the amount of glucose in the body. I won't dwell too much on amino acids, mice, models, research here. It's going to be pragmatic all through. This is the structure of human insulin. We all know about it. We learned it in our biochemistry and physiology days again. What are the various phases of insulin secretion? We know that there are 2 phases usually. Okay, when we eat a meal, for instance, if you had your breakfast, there is that immediate first phase, then there is that second phase, which is rather slow. And there is always that basal insulin as well that keeps us away from diabetic ketoacidosis, which unfortunately type 1 diabetics are predisposed to because they do not have that basal insulin in them. Whereas that basal insulin exists in all of us and most of our type 2 diabetic patients. Mechanism of action of insulin, it is supposed to do what it is supposed to, which is act on the specific receptors on the membrane of almost each and every cell in our body. And it is supposed to let these receptors allow glucose into them. All right. So what it does is it allows glucose from the blood to go into your cells. I know it's an oversimplification, but that's what it does. Actions of insulin. We do have anabolic effects here and the catabolic effects that it prevents on to the other side towards that of Dr. Kalyan and Dr. Murli there. If you look at the carbohydrate related anabolic effects, we do have glycogenesis, glycolysis, glucose transport. If you look at the catabolic effects that it prevents, glycogenolysis, that means breakdown of glycogen, be it from your muscle or from your liver. Gluconeogenesis, formation of glucose from other substrates. Coming to lipid metabolism, glycerol and triglyceride synthesis. So it does promote, it's after all an anabolic hormone. It does prevent ketosis and lipolysis for obvious reasons. Coming to protein metabolism, it does promote protein synthesis and amino acid uptake, prevents protein degradation. Look at metabolism of insulin. I think this is a very important slide. Not that the others aren't, but this is important for obvious reasons. What happens to insulin after it acts? What it is supposed to do? The half-life is somewhere around 5 minutes. You might have already known this. But what happens to the insulin, be it the exogenous insulin that we give in the form of injections or the endogenous insulin that is secreted from our pancreases? So if you look at the down below stuff there, primarily for endogenous insulin, that is the insulin that is secreted in our body, it is the liver that metabolizes. If you look at the exogenous insulin, that means the insulin that is given in the form of synthetic insulin, this is primarily excreted through the kidneys, right? This is very important because this would have some bearing about the various duration of actions, the way insulin is metabolized, and how we need to take that into consideration when we prescribe insulins. But why insulins? Because if you look at type 2 diabetes, all medications do fail after a certain period of time. We've heard this enough, and we don't have a choice but to deal with this problem by giving insulin from outside, in most of the patients at least. So rationale for timely insulin therapy, we all know that if we do not give insulin, there are a lot of complications that can happen, be it the micro or the macrovascular complications that we all know well enough. And what is important is that every 1% reduction in A1C does translate into better clinical outcomes, especially microvascular complications, but also macrovascular complications. Again, look at UKPedia's study, and that's what it says. And if you look at the efficacy of various agents that we use, be it the good old metformin, sulfonylureas, TZDs, or the newer agents such as your SGLT2 inhibitors, GLP-1 receptor agonists, alpha-glucosidase inhibitors, and D4 inhibitors, they all can reduce blood glucose levels to a good extent. But there's a limit to which they can reduce your blood glucose levels. Fortunately, that's not the case with insulin. You can bring down your A1C or blood glucose levels to a great extent, and irrespective of the duration of diabetes. That's the beauty of insulin. So irrespective of whether you started early or towards the later stages, insulin is very much effective, unlike most other agents. Also, there is no dose restriction, which all other agents do have. Also, do remember, there is no limit to which it can bring down. It can bring down A1C from 16% to 7% as well. Not many agents can do, except lifestyle and diet to a certain extent. So that's insulin there for you compared with all other agents. Unlike insulin, addition of subsequent oral anti-diabetes agents doesn't benefit when you're using 2 or 3 agents. So you don't have a choice but to embrace insulin if you really want A1C to get better, if you really want to prevent all the micro and macrovascular complications that we have already discussed about. Benefits of insulin initiation, other than A1C reduction, does it have any other benefits? Yes, it does. In terms of its anti-inflammatory, antioxidant, anti-thrombotic beneficial effects, in terms of it being cardioprotective, neuroprotective, anti-apoptotic, and not to forget, perhaps, vasodilatation and also platelet inhibition as well. Not to forget the fact that it rests the beta cells and prevents glucotoxicity. Let those beta cells last for a little longer duration than they would otherwise. A lot of animations there, thanks to Dr. Shushil. So who all needs insulin? That's the biggest question, isn't it? That lady who's nodding her head there. So can we pass on the mic to that lady, please? You don't need, that's even better. You're like me. So can you give the list of indications for starting insulin?
All those type 2 diabetes who are, who are going to very failure. The patients who are recently diagnosed but have osmotic symptoms.
Who are very much symptomatic, say A1C 14, and you want to rest their beta cells. Okay. Yeah. Anything else? Somebody has got anything else? Okay, yeah, that's a very valid point. In fact, if somebody is planning pregnancy, and if you say their A1C is good, 7% or 6.3 or whatever it is, but if they were to be on oral medications which can't be continued during pregnancy, I think it's a good idea to stop those oral agents and put them on insulin. That's what you're supposed to do proactively rather than reactively after they become pregnant. This is a very practical and valid point. Yeah, great. Anything else? Of course, it's almost like type 1 diabetes when it comes to management, but yeah, but well picked up. Yeah. Anything else? Yeah, I think you should be here and I should be there. Anyway, well done. Yeah. So anything else that anybody else wants to add? She covered almost all of them. Some young guy there. Yeah. Make yourself feel young. Yeah. The gentleman there. See, I'm going to pick people. Okay. The idea is to learn. The idea is to interact. Okay. It's not going to be a didactic talk wherein you would have a chance to check your WhatsApp or emails. Sorry. Yep. Yourself.
Yeah, madam told most of the points. I have nothing left to say.
Great. Anything else you want to add?
Insulin, I mean to say.
You're speaking about indications for insulin, and she listed almost all the things that are there in this slide. The slide is here today. You want to come back? Yeah, you missed something.
Any hospitalized patients?
Exactly. I'm glad So I'm glad you brought it up. Thank you very much. So any patient who is hospitalized, usually we do stop oral medications unless they got admitted for reasons such as they want to get their usual master health checkup because of insurance reasons or whatever. But unless it is such a scenario, yes, the textbook saying is stop oral medications, go to insulin. Yeah, well said. Great. Anything else?
Patients on prolonged OADs, oral hypoglycemics, who have exhausted their beta cell mass.
Ma'am did cover that. Anything else?
That's all.
Any infections, food ulcers? Yeah.
Yeah.
For instance, okay.
Yes.
Or somebody who develops a pneumonia or has COVID. Sorry, I'm adding up. Or needed steroids.
Yeah, steroids. Okay. Steroid-induced hyperglycemia.
Yep. Anything else? Right. Let's look at global and
Indian.
Indian.
With CKD also.
Yeah. And liver problems. Give some respect to liver as well. Anything else? Yeah, you almost filled up everything. Right. Great. So if you look at the global and Indian recommendations, we do have ADA 2020 and we do have our own Indian RSSDI ESI 2020 recommendations. Remember, AC is going to come up with its own recommendations fairly soon. AC is Association for Clinical Endocrinologists, formed by doctors who are trained abroad in UK, US, just like all the doctors you're seeing as faculty. They're going to come up with their own recommendations. Very practical for patients and for clinicians, be it GPs, be it physicians. So these are going to come out fairly soon. But for the time being, we do have ADA guidelines there and RSSDI and ESI guidelines there. As you can clearly say, ADA guidelines say that HbA1c above target despite dual or triple therapy. Go to this. Insulin. Consider insulin as first injectable if A1c is very high, more than 10%, as ma'am has already said. And symptoms or evidence of catabolism exist. Again, ma'am covered that as well. Somebody is very cachectic, passing too much urine. Remember, it's not only type 1 diabetics who lose weight when they're present, even type 2 diabetics who have A1Cs of 14 and 16. I just saw a patient yesterday who lost 10 kilos of weight in the last few months just because of A1C of 15%. Right? In such a scenario, you might want to rest the beta cells, start insulin. Could be temporary. Just counsel the patient. Then we do have our RSSDI and ESI 2020 guidelines. Insulin therapy should be considered in all patients failing to achieve glycemic targets on 3 oral agents, more or less the same. Consider initiating insulin in type 2 diabetic patients with severe symptomatic hyperglycemia or unstable state. Fair enough. So RSSDI recommends insulin after 3 oral agents, as we already discussed. And this is almost a complete list of all the indications that we have covered so far, be it uncontrolled type 2 diabetics, for that matter, even newly presenting type 2 diabetics that we have discussed. So we'll add that for the next set of slides. Type 1 diabetes, in-hospital management of hyperglycemia, as that gentleman rightly pointed, infection/sepsis, DKA/HONG, pregnancy, CKD 4 or 5, for that matter, liver problems as well. We need to add that. when oral antidiabetic agents are contraindicated or not tolerated, not to forget steroid-induced hyperglycemia, which can't be handled by oral agents. On that note, thank you for your patient listening. And now it's time for interaction and questions and discussion. We're on time, don't worry. So, firstly, I think we need to take from the audience if they have any questions. So if one can coordinate and make sure that the mic is passed on. The way we're going to work is a few housekeeping rules. Not going to walk in the middle because we got about 3,500 Zoom registrations so far. And some of them, at least few hundreds of them, would be logging in and trying to see what we are doing today. So we don't want anybody to be walking in the middle so that everything is clearly seen by them. That's the first thing. The second thing is, if you raise your hand, that chap would come to you with the mic and you can ask your question. Please don't feel shy, okay? Nothing is simple, nothing is silly. We all need to start somewhere, okay? We all did at some point. So any questions from the audience? So usually when people don't raise their hands, it means one of the two, or probably three. They're too shy. Two, everything is lucid, clear. They're good to go to practice all this. Three, they didn't understand a damn thing what I said. Okay. I usually like to believe the first two. The people are too shy. I don't think you guys are. Otherwise, you wouldn't be here where you are. The second thing is everything is lucid. I'm an optimist. Yeah, there is a question there. Good.
Sir, I would like to ask your practical experience about how would you insulin in preconception?
Right. Okay. We're going to cover that, but because you asked a very valid point, because you'd be seeing me and listening to me a lot of time, I would like you to listen to our expert panel here. Dr. Mithun, please, this way.
That can be used, but the evidence is a little weak on that side. So metformin is good, and if that is not controlled, traditionally the thought process is NPH is a good insulin and a bolus insulin if required. However, there is a view of thought that if you don't rock a boat if it is going fine, if roads are fine, you don't try to break it and revamp it. So if somebody who is on well controlled on Lantus or on any other insulin, be it whatever, I would not rock their boat and let them be on, because what you want is good HbA1c control. And metformin helps. And on top of that, you can ask them to monitor. This is the only time you will find the ideal diabetic patient with you who's ready to do everything you want to do. And that is that 9 minutes of your time in which they're going to do everything by the T and the dot the T and the dot the I. So I think get them to under control. But very often patients come back to us and say, sir, ho gaya pregnancy. Ab ho gaya nahi hota hai, wo ho gaya. Theek hai. So now when the pregnancy is done, insulin, you have to get the insulin straight in. As Ravi has already pointed, it's the agent which will actually get it you faster under control. And basal bolus would be the most practical way of doing it rather than anything else. If
Sir,
anybody wants to add.
in your experience, how many women do take basal bolus, sir? Because for me, I really find it very difficult for them to sort of persuade them. I think that's the right word. Persuade them to go on basal bolus.
What do you prefer? What do they prefer?
As least injections as possible.
Yeah. So I think the goal is not the number of injections. The goal is glycemic control. So if you can get the sugar under control with a mixture, with a
That's
premix, that's fine.
That's
But
what-
they should monitor 4 times a day. And if that's not happening, we can always, there's not one way of, peeling the onion. You can peel it various ways. So the goal is more important. The path that we come to that goal may vary. And that may vary because of the phenotype and the genotype of the patient.
Thank you, sir.
Right. Dr. Mithun, if your other half would be really watching, she would be wondering when was the last time Dr. Mithun Bhartia peeled an onion. Never mind. So, moving away from peeling onions to using insulins, Dr. Murli.
Hello, can you hear me? Yeah. Okay, so another indication I would like to add for using insulin is secondary diabetes, pancreas,
Right.
post-pancreatectomy.
Yeah.
And now coming back to...
Whenever the oral agents are not effective, or whenever you think that there is hardly any insulin left over in the body, and how are you going to tease that out? Can you explain that?
It all depends how the patient glycemic control is behaving. So you're using maximum amount of sulfonylureas because not every pancreatitis patient for that matter have insulin resistance. In fact, some of them actually are poorly nourished if you actually look at them. So again, LADA also falls into the same category. And so once they you use maximum amount of glucose lowering agents and the glucose is going really, really high, then you know that there is not enough insulin in the body. Then that could be an indication to consider insulin. But pancreatitis cases are a little bit tricky because they also have malabsorption. Sometimes they have dumping. And also glucose absorption is not always linear. I think in the next few sessions, you'll be seeing why some of these ultra rapid acting insulins would be very useful in those patients. But coming back to the pregnancy.
Mm-hmm.
So when you say pre-pregnancy management, somebody who has very well-managed type 2 diabetes before the pregnancy, you may just get away with metformin and diet. So that would be one good motivation for the patient. Okay, if you don't do diet well, you may have to go on insulin. So I think this may be a perfect opportunity for them to take up the diet very seriously. So that is first and foremost important thing I would address for any patient going for pregnancy. And giving folic acid would be very, very useful. And also explaining them the risk of congenital malformations with the baseline HbA1c at the time of conception. So somebody with 6.2 and below, the baseline risk is 2%, and anything between 6.2 to 7.7, the percentage is 4%, and once it is above 10, the risk is 25%. So I don't think if that doesn't motivate the patient, what will?
Great. On that note, Dr. Kalyan. So let me be very specific about few questions which have come up from that. Do you think in your real life practice, if you were to really tell your patients, look, insulin is the only thing that would be the safest option for you whilst you're planning your pregnancy, for you and your baby, okay, for optimal maternal-fetal outcomes, do you think patients would really embrace? Because she brought up that question, not many patients would be happy for basal bolus. I have a different opinion about it, but before I tell my opinion, can you please tell what your experience has been when you explain all this to your patient?
So the explanation will go as we discussed that, we have to have the better maternal outcomes and fetal outcomes. So on that background, we tell the patient that, look, the ways to control the sugars the best way to control is to add insulin. You will definitely be on insulin. Be prepared for that. So we give them a heads up saying that in pregnancy, you have to use basal bolus. I personally use basal bolus in all my patients in gestational diabetes, and they do take it. They do accept it. So what I do is I give them a teaser before. So in preconception, I'll say, okay, let's add in a basal insulin and give them a feel of what it feels. Because a patient who has no idea of insulin, for them, an injection may be something that they think that it is like some worst case scenario. So once they use an insulin for at least once daily, I continue them on the OADs I stop it when they get pregnant. So I tell them I am going to continue these OADs. They may not be licensed in your pregnancy, but as soon as you conceive, I will stop it. Please continue the insulin. We will continue that further. I may continue metformin and add in some bolus insulin. So that way they are actually a little prepared before pregnancy. So that's how my approach is.
See, unfortunately, during pregnancy, we don't have we don't have much of a choice, and we can't go with the carrot and stick approach. Okay. See, you have to just go with the carrot approach only. Okay. The stick approach has to happen even before the conception, because after somebody conceives and say, look, now you're pregnant, things might happen not according to plan. You might not have a healthy baby. Okay. You might have problems with the baby. Your baby might have problems with his or her heart. And, waiting for it to happen would not help. So I think all this need to happen during pre-pregnancy counseling only. And as Dr. Murali rightly said, if this does not convince a person, what else will? So I think you need to actually get the patient on board, do it beforehand, before pregnancy. Okay, get the patient on board. There's no other option there. Of course, folic acid. Okay, so now keeping on time, we'll move on to the next talk: classification of insulins and insulin regimes, which, when, and why. Over to Dr. Murali.
Thank you very much. So I'll be discussing about classification of insulin and regimens, which, when, and why. Okay. So the case scenario, just to give some baseline information. So 54-year-old lady, diabetes for 8 years, and triple agents metformin, glimepiride, and sitagliptin, comes for routine checkup. PPG 233 and FPG 233 and PPG 265, A1C 9.3, and you plan to initiate her on insulin. What insulin do you start? Well, technically you can use any insulin, but obviously we have to discuss with the patient what kind of choices they have, what they prefer, and also coexisting comorbidities, how rapidly you want to achieve. So there are lots of different things, renal function. So lots of different things. Good thing is that this patient is on glimepiride, which is a secretagogue. So for example, metformin and sitagliptin are not secretagogues, so they do not let you secrete insulin after the food. So if you are adding any basal insulin, you have to ensure that the patient is on a medication that helps with the endogenous insulin secretion post-meal. So I have seen some patients using sitagliptin metformin combination or any DPP-4 inhibitor and metformin combination with basal insulin. So how are they going to have this post-meal sugar managed with just basal insulin and no secretagogue? So if you want to consider a basal insulin, ensure the patient is already on some kind of secretagogue. Anyway, we'll go and get into the insulins now. So I will not spend too much time on academics. I will spend more time on practical aspects. So insulins, broadly, you can divide them into human insulins and insulin analogs. Human insulin is nothing but our own insulin, endogenous insulin, and they have taken the basically being produced outside the body in yeast and bacteria. Whereas analog insulins, it is the same human insulin, but some of the amino acids are replaced by our Novo Nordisk company or Lilly or any of Sanofi, and they have made analog, and because of this, the way it works has changed. So, and they have their own advantages, which we'll be discussing. So human insulin, it is basically a regular human insulin, short acting. It is not rapid acting, short acting. And then you have NPH insulin, which is intermediate acting, somewhere around 12 to 16 hours maybe. And then you have this mixed insulin, where you have mixed regular human insulin along with isofen insulin. So if you look at the onset of action, most of the regular insulin, although they have put it as 30 to 60, in my experience, minimum it takes is 45 to 60 before it actually starts to work. So it has impact on how you use it and when you use it. For example, in pregnancy, where you have to achieve 2 hours target and you're giving insulin, and which is going to start working after 1 hour and peaks in 3 hours, you're not going to achieve 2 hour target. So intermediate insulin, again, it takes 2 hours to start working and peaks around 6 to 10 hours. And duration of action is 10 to 16 hours. In my experience, most of them, it tails off around 10 to 12 hours. And I have some cases where type 2 started behaving like type 1 and they missed one insulin and they ended up in DKA because it only works for really 12 hours. So the premixed insulin, something like Mixtard, where you have 30% of regular insulin and 70% of intermediate acting insulin. And it starts onset again around 60 minutes and peaks around 1.5 hours. And again, duration is around 12 hours. So that these are the human insulins. And there are various premixed insulin and various regular insulins. So I think most of these companies are making some of these insulins. So regular, again, I'm not going to spend too much time on this. So as you could see, it's very self-explanatory. Onset 30 to 60 minutes, maximum effect is around 3 hours, 2 to 3 hours. And then action of duration is 7 to 8 hours. So this duration is also has some impact because we really want any short-acting insulin to be used with the meal and deal with the post-meal sugar, and does it work and get out of the system within 3-4 hours. But if it is going to work for 7 to 8 hours, there is a risk of hypoglycemia. So that is the reason why these are not very ideal insulins, but they have saved millions of lives in the past, and they're still there because they're cheap and not everybody can afford analog insulin. We'll come to the analog insulin's advantages. So intermediate insulin, as you could see, within 1 to 2 hours, and maximum peak is around 4 to 12 hours. This has impact on elderly people or any person. For example, you're giving insulin in the evening and it peaks around midnight, and that's when they're at the highest risk of hypoglycemia. And it may not be, and also the effect goes down at the morning when they wake up. So this is not very ideal when in terms of controlling fasting glucose. So human premix insulin 30/70, as you could see that they have mixed regular insulin as well as 70% of NPH insulin. So I think these insulins have a bit of a shoulder effect where the rapid acting insulin peak shifts towards the right. So they may peak a little bit later than usual. This has again impact on hypoglycemia and how rapidly you're going to control. It may not matter much for type 2s, but it does to type 1s. So limitations of soluble human insulin, slowly absorbed, and they have longer duration of action, as I mentioned earlier. So that causes increased hypoglycemic risk, and injections and meals should be planned. So for example, if you have a kid going to school and have lunch around 1 o'clock and they finish their school class around, say, 1 o'clock. So when are they going to inject their insulin and wait for half an hour to have their meal? So this is a bit of a difficulty. And I'm sure most of you agree that most of the patients, in spite of us advising them to use 30 to 45 minutes before their meal, I'm sure 90%, even more than 90%, actually take insulin and just eat it. As simple as that. That's what usually happens. So whereas insulin analogs, they have some advantages there. So the rapid acting, so particularly rapid acting insulin, so usually they start to work within 15 minutes. I think we even have faster rapid acting insulins like Fiasp even works around 5 minutes, 6 minutes, I think, as soon as. So they have some advantage even to be used after the meal, particularly when you have a kid who doesn't know, who you don't know how much they're going to eat or whether they're going to eat at all. So these insulins can be given even after 15 minutes, even first trimester pregnant women where they have some, hyperemesis. Again, in those patients, sometimes you take insulin half an hour ago and you vomited and you end up in hypoglycemia. So in those patients, if you ask them to wait for 15 minutes, and if they keep their food down and then take the insulin, and you can still achieve the 2-hour target. So they have certain advantages, certainly over short-acting insulins. And then you have long-acting insulins like Glargine, Detamere, and then you have this ultra-long-acting insulin, Degludec and Glargine U300. And then you have premixed and co-formulations, as we have Aspart and NPH and Lispro with NPH and, Degludec with Aspart. I think this is a co-formulation. So rapid-acting analogs. So analogs are target postprandial glucose levels, a general structural modification. I'm not going to go in detail about that. One thing you need to know is that they act really fast and achieve the peak really quickly and do their work and get out of the system within 4 to 5 hours. So that's what you need to understand. So the time of action profiles, rapid onset, high peak, shorter duration of action. That's exactly what I was saying. So this will help a lot of kids, particularly pregnant women, even older people. For example, Parkinson's disease patients where they have problem with swallowing difficulties. Those patients, they may not actually keep in, and sometimes they don't eat. In stroke patients, for that matter. So when you're not sure, even patients who are admitted to hospital with gastroenteritis, all those patients, I think these are the insulins are very, very useful because you don't know whether they're going to keep it or not. You give insulin and they don't eat and they end up in hypoglycemia. So rapid-acting analogs, insulin aspart replacement of, I'm not going to go in. I think you can read that. So basically, they have replaced amino acids with aspartic acid at proline at B28 for aspart. That's why it's called aspart. And then you have Lispro, where lysine B28 is replaced by proline at B29. Replacement of asparagine at position B3 by lysine and lysine in position B29 by glutamic acid. So that's why asparagine with the glutamic, that's why they got this glulysine. So let's get into long and ultra long acting insulin. So the long acting analogs target fasting glucose levels. So how they work, it's a very, very good insulins. They don't have peak, as I mentioned about NPH earlier. So NPH insulins have peak around 6 to 10 hours. So for example, if somebody is on, say, the same patient that we discussed earlier, who's taking glimepiride maximum dose, metformin maximum dose, and sitagliptin maximum dose, their fasting glucose is 230. So you decided to give them NPH insulin, say around 6 o'clock or 7 o'clock. So it is going to peak exactly in the midnight where they have already had their meal 4 or 5 hours down the line, and that there is a risk of hypoglycemia. And their action is not that high in the morning. For example, around 5 o'clock, 6 o'clock, sometimes people have dawn effect. So this is not again covered by this particular insulin. And also the most important thing is this suppresses the glucagon. So most of the patients who have high fasting glucose, particularly type 2 diabetes, who have failed on 3 agents, are the patients who don't have too much of postprandial glucose. These are the patients who don't have fasting control. So if you give insulin, glucagon is suppressed, and then by doing that, you're reducing the hepatic glucose output as well as reducing the glucose down. So it is acting multiple effects. The problem with NPH is it doesn't last 24 hours. So you will clearly see that you give insulin in the evening. So you may achieve the fasting target. In some patients, it may address for some patients, but for some patients, it will not work because it will tail off by next day morning, and then they will start having higher readings by evening. So whereas this long and ultra long acting insulins, for example, degludec and glargine U300, it can last anywhere between 36 hours to degludec 42 hours. And and after a couple of doses, they will achieve a steady state where there is no much peak. So the risk of hypoglycemia is very less. And also the fasting glucose is very high. Some of these patients, you fix the fasting glucose, the job is done. But once they start losing more and more beta cells, I think they will require more and more insulin. That's when you start adding premixed insulin or even basal plus insulin. Another advantage with the massive advantage these insulins have for type 1s in particular. So type 1 patients, even if they miss one basal insulin, they may end up with the DKA, particularly kids. Who are going to college and they're not living with their parents who may remind them regularly to take their basal insulin. If they're taking something like degludec, even if they miss one insulin, I don't think they will end up in DKA. It's not uncommon to see, some of these kids go to parties in the evening and they forget about taking their basal insulin and end up with the DKA next day in the morning. And you don't see that with degludec and glargine U300. So they have massive advantages, those for type 1 diabetes patients. So again, insulin glargine, a very good insulin, still my go-to insulin at the first instance, unless there is a problem. For majority of the type 2 diabetes who fail on oral agents. And then we have this detamere, glargine, and then degludec and Glogin U300. So comparing basal analogs, you could see there, NPH basal long-acting analogs, Glogin, Detamir, Glogin U300, and degludec. So if you see the last two insulins, if I am diabetic, if I have to see a basal insulin, I would prefer any day degludec or Glogin U300, simply because, I can afford, I can take it, but not everybody is able to afford that insulin. And you have to look at the patient financials as well as the patient needs. I think we have to put the patient needs and financials above all, and then find the right insulin for them that fits their pocket. And that is the best way, because even if you give them an expensive insulin, but if they cannot afford for a long time, they will take for a 1 month or 2 months and then they'll stop it. So it's no point. So you're not achieving anything. So, but if you offer patients who is affordable, okay, this is the best insulin, but it may cost you more. But if he's affordable, he doesn't care. But if he doesn't know about it, why would he take it? You just end up with NPH. So I've seen a lot of patients who are very, very affordable patients end up on these nonsense insulins. Nonsense in the sense, when there is the best that is affordable for the patient is available, why should take something like NPH for those patients, put them at the risk? So you individualize these insulins, you offer the patient, you explain the benefits and risks of each of these insulins, and then let the patient decide what he wants. So that's what we need to do rather than we putting our decision onto the patient. So insulin types based on combinations, premix co-formulations. Again, they cover a prandial and basal insulin requirement and insulin, single insulin injection, and may be administered as once or twice or thrice a day. So again, for this patient, for example, if we gave a premixed human insulin, it will be a difficult choice to give once a day. I think you may get away in some patients, but as the diabetes and beta cell destruction progresses, once a day may not work. The reason is the basal component does not last 24 hours. Whereas you have something like Ryzodeg, for example, which has 30% of rapid acting insulin, and then the basal lasts nearly 42 hours, I think, in these patients. This particular insulin is very, very good in the sense that the basal component lasts more than 24 hours. I think this is the only preparation that is currently available in the market which has the basal component in a mixed preparation that has more than 24 hours action. And I think last few months, I would say, since the COVID, I think that is my go-to insulin, mainly because in majority of the patients, you just get away with just one insulin a day as long as they can afford the insulin. So if you are choosing premixed insulin, for example, Mixtard 30/70 or 50/50 or something like that, you may have to give twice a day. In some patients, you may get away with just once a day insulin. And if you're achieving the HbA1c target because they have a lot of endogenous insulin, that's fine. But eventually that will not be enough, and you may have to end up with twice a day or thrice a day. So if you're giving thrice a day, I would ask you to go for 50/50. Don't give 30/70 thrice a day. If you're giving thrice a day, go for 50/50 rather than 30/70. So insulin types and combinations, premix co-formulations, as I discussed earlier, you could see the biphasic aspart up to 24 hours. I think most of these insulins, biphasic aspart, biphasic lispro, they're all cloudy. It's very, very important you explain this to patient, extremely important that you need to shake them. You need to shake, and it has to be mixed nicely before you administer the insulin. Whereas you don't need to do that with Ryzodeg, that is Ideg and aspart combination. So various insulin regimens. So basal insulin regimen, again, it has its own advantages. That is, you give just once a day. And somebody who's type 2 diabetic who's going on insulin for the first time, this would be the first choice to consider. So it suppresses glucagon, normalizes fasting glucose. And because it normalizes the fasting glucose, for example, if somebody has, for example, in this patient, 230 fasting, 330 postprandial, and if their fasting is 100, obviously postprandial will come down by the same. So instead of 330, it will come down to 230. And if you achieve the HbA1c target of, say, 7 just with once a day insulin, I think that should be enough. But once the diabetes progresses, once a day basal insulin may not be enough, and then you may have to consider other things. So it's a simple, easy, once a day, potentially less weight gain, less risk of hypoglycemia. and the individuals may not achieve glycemic targets. Regimen does not offer optimum control postprandial hyperglycemia, and some individuals may require a more intensified insulin regime. So once daily premixed insulin, I think we've already discussed it, and it may be useful in some patients, and it influences 1 ppg, only 1 ppg, and then fasting glucose. That may be enough for some patients, but eventually they will require twice a day or thrice a day. So again, we discussed this. So the basal bolus regime. So this is a gold standard. So for type 1s, this is what I usually follow. You give the basal insulin, look at the midnight reading and look at the fasting reading. And the midnight reading and fasting reading should be the same. That's when you know that the basal insulin is perfect. But unfortunately, some people have dawn effect, so that needs to be found out. I think CGMS may help. And then you titrate the bolus insulin with each meal, and I think you need to advise them carbohydrate counting and everything. And another thing I forgot to mention about the premixed insulin is when you're titrating, it becomes really difficult simply because you want to increase the short-acting insulin component, but you will also end up increasing 70% of the long-acting component. So that is one biggest disadvantage with premixed insulin. So that's why I would recommend try to titrate to the pre-meal reading rather than postprandial readings, because otherwise you will end up causing more hypoglycemia to these patients. So coming back to basal bolus regime, it is gold standard. You titrate individually based on the meals, their carbohydrate intake, and this is very useful. And type 1s by default, and also pregnant women, this is my default choice. Even in pregnant, I don't use NPH, I use Glargine. It is safe insulin. I know it is not there in the recommendations, but I use by default Glargine. So thank you. Any questions, please? So anybody have any questions? I'm very happy to discuss. And we have Ravi, Midun, and Kalyan who would be able to help with any of your queries.
So let me ask you a question. Murali. Just trying to address some of the questions given in the questionnaire. What's your gold standard favorite insulin regime?
Basal bolus.
Okay. I would like to modify that question now. What's the most practical insulin regime? Be honest. Yeah.
So the practical insulin regime would be to give a short-acting morning and afternoon, and give a mixed preparation at night. So that will reduce the insulin burden by 1 injection a day. I use this regime quite a lot.
What is it? Can you repeat it?
So TID insulin, short-acting at before breakfast, short-acting and analog insulins, not humans, because human insulins is a lot of problem. You have to take it 20-30 minutes prior. The onset of action is delayed. Short-acting is very simple. The analog insulin is very simple. You can just take it after meal also if somebody forgets it, especially with the newer ultra short-acting FIASP like insulins. So you give a analog short, rapid acting in the morning, rapid acting in the afternoon, and give a mixed insulin in the evening. That is actually giving me a good result. I've checked it personally with using continuous.
So there is no insulin at lunch?
No, short acting before breakfast before lunch,
and a premix at dinner time.
So that is a more practical approach, and a lot of patients are actually. So what I do is I start them on basal bolus, and they ask for a discount. I give them TID instead of QID. That's how it works.
That's good music as ringtone, but I think it won't work very well in a meeting. So that's a gentle reminder to everyone to please put your phones in vibrate mode. Thank you. Right. Yeah, well, you cut short by 1 insulin prick. That's all you could do. Okay. Fair enough. What if somebody says, I want only twice a day?
There's one more regime like Basal Plus, where you give a basal insulin and you just give a short acting or a rapid acting insulin in the morning. It doesn't work well for a lot of people, but if you combine it with like a acarbose, something like acarbose in the afternoon and dinner, you can get away with just a Basal Plus regime, where because a lot of the hyperglycemia is actually driven by the hormone responses in the morning. So if you cut down that that immediate spike after breakfast, you can get away with afternoon and dinner. Not in every patient, but in some patients.
Well, personally, if you ask me, I'm not a big fan of alpha glucosidase inhibitors. I used to use them liberally when I came, believing that, because we eat a lot of carbs in India, blah, 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 but they hardly bring down any A1C. We tried to, do some evaluation in our clinic, and we thought, look, the numbers are not matching. It's not doing much. So I stopped believing in alpha glucosidase inhibitors because they're not that efficacious. Next to Dr. Mithun. One question. So let me take that question, which... Yeah,
so let's take the audience.
So audience first. Oh, there are many. Sorry. Yeah, good. Yeah.
So can I ask one question regarding the Basal Plus, sir? So when you compare Basal Plus to premix twice a day,
Yeah.
which do you
That
think
was my question.
you would go for, sir? Why not premix twice a day? Why Basal Plus? I mean, morning breakfast, bolus, and a premix.
So premix contains 30%. Unfortunately, we don't have a premix which contains more than 50% short acting. And the rise that we see, the postprandial spike that we see after breakfast is huge. And I have seen this personally because I use a lot of sensors. I personally see the huge spike that happens after breakfast, and premix does not address it. If ideally we would have had a mix of 70-30, maybe 70% short acting and 30% short long acting, that would have actually addressed that. But unfortunately, 30% does not address it. So a Basal Plus will be 100% analog insulin, short acting, rapid acting insulin in the morning, which will bring down this spike. So what happens is the spike that just gets carried over up with lunch and dinner, just the sugar just stays high. So with a premix insulin, you are not giving a rapid acting insulin in the right proportion at that time. And that is the problem with it.
Yeah, it's always nice to have two different opinions, okay, so that you can really see two different perspectives. Let me beg to differ with my good friend and colleague Kalyan on this. The reason why I favor premix insulin twice a day rather than Basal Plus is for all these reasons. One, only single type of insulin, so no confusion whatsoever. That's the biggest. Second, you're not addressing the postprandial blood glucose surges when you give just basal and only one bolus. Let's give me an example. I'm somebody who eats a sumptuous breakfast and good dinner, right? Imagine me taking only a basal and a bolus in the morning. Who is tackling my postprandial blood glucose surges post-dinner? Nobody is. So I would be having 300s and 400s post my dinner. On the contrary, if at all I were to use premix insulin or a co-formulation, okay, then that would handle my postprandial blood glucose surges at breakfast time as well as at dinner time, as well as address the basal insulin. That's my take on it. Two reasons, okay? So
I have a different approach. I would prefer a basal insulin because it has no peak, so very less risk of hypoglycemia. So that is one insulin, and plus using two premixed insulin will cause 2 peaks of insulins. Insulin peaks will be 2. So the risk of hypoglycemia is much higher compared to Basal Plus, and you can individually target each meal according to your patients. So there are patients who have very big lunch, not that much with the breakfast, and not that much with the dinner, or some people may have very big lunch and very big dinner. So you can individually target the meal. For example, they're going for a marriage party tonight, and usually they take with the lunch, but they can take for the dinner. You don't have that kind of flexibility with the premixed insulin. But having said that, that approach also works for some patients. This also, so every insulin regime that is there works for. You just have to tailor it to the patient, as simple as that.
yeah,
See, the advantage of this question is that I don't have to speak in my next session. So everything would be covered here, so I can reduce the time of my session. I do a lot of CGMS like Kalyan. I do around 200 CGMSs a month. And in bank, there's something nowadays, PAN card mein bhi aata hai, KYC, know your customer. So know your customer, know him, and then use all the insulin or her insulin. I think that is what I would say.
Excuse me.
Somebody is trying to get into politics, they would answer the question this way. I have no intentions as yet, so let me be blunt. In the Indian scenario, I any day would prefer a premix insulin or a co-formulation twice a day. Okay. I've been paid by this company as well as the basal bolus manufacturers, all other companies at different scenarios for my professional work. So I have no prejudices or biases here. Let me be as clear as it is. We all have our different viewpoints. That's the idea of having four people here rather than one Dr. Ravishankar or one Dr. Kalyan or one Dr. Mithun to give a talk. Okay. I personally prefer premix insulin twice a day, or for that matter, even thrice a day, rather than something like, a combination of two different insulins. I'll give one example as to why. Patient had CABG, needing 60 units of basal. Okay, you heard it right. 30 units of bolus 3 times a day, roughly. Okay, patient went home. Okay, basal was given in the morning. Okay, because that's what the patient has been taking at hospital. Patient comes back saying significant hypos around 11 o'clock, doctor. As usual, me being slightly naive, I asked, are you taking breakfast? Patient says, yes, I'm having my breakfast. Are you taking the right insulin at the right time? Yes, doctor. Goes back. After 4 days, comes back. Same scenario. Still having hypos, despite me cutting down the bolus insulin given at breakfast time. Comes back again. Then I said, show me which one you're taking, how much. Person says, yes, doctor, I'm taking the short-acting one 3 times and the basal insulin once, right? Again, I cut down the morning breakfast bolus and also asked him to take a snack around 10:30 to prevent that hypo around 11ish. Again, the patient comes back after 4 days and still the patient was having hypos around 11 o'clock. I said, I can't believe you. Get all your pens, demonstrate to me, this is breakfast, what insulin are you taking, how much? The patient was taking long-acting insulin 30 units, okay, and the short-acting insulin or the bolus insulin 60 units. No wonder that patient was having hypos. So always go for which is very easy to use. I'm not saying about this scenario in general. This is despite proper education, despite checking with the patient a number of times. So mistakes can happen. This is not the only patient. I'm sure you all would have come across such patients as well. So I believe in keeping insulin regimes as simple as possible, as easy to use as possible. Of course, this is one way of doing it. There's definitely the other way of doing it as well. And one shoe doesn't fit size, all sizes. Okay. So last question for this scenario. We all have a lot of time to interact. Don't worry. All questions will be addressed. You won't go home without any of your questions tried to be answered. I use that word carefully. Try to be answered by the panel here, because we're not any gods or messiahs here. We also do learn on a daily basis. We also commit mistakes. So we all should learn from each other. Yeah, go ahead.
What about using premix in morning and using basal in night? I mean to say, to reduce the peaks and all those things. And other question is about Degludec. What is the dosing and what should be the ideal dosing to reduce the hypoglycemic attack?
I think we can take some of these questions after this particular talk, because that would actually address a lot of these questions in itself. But as to whether you can mix a premix in the morning and a basal, I would say no. But Dr. Mithun would try to answer this. I think people would be longing for a tea break, wouldn't they? My attention span is usually pretty short, and I think I would
Recording in progress.
Hello, ladies and gentlemen. We are back of the tea break, right on time as ever. Dr. Mithun Bhartia is going to speak about simplifying insulin initiation in the context of Indian realities. He's going to use a flip chart for all of you. So please try to focus on the flip chart rather than the screen. You can also try to use the slides as well. Thank you.
Thanks, Ravi, and thank you for inviting me to Hyderabad. I'm going to try to do something different so that I have all your attention. And before I start that, do I have a caller mic, Srinivas? We have a. Can I have? Okay. So before we start that, can I have a? I'll use the slides at the end. We're just gonna talk. I like talking. So, can I have a show of hands? How many people are married here? Okay. And how many people out here have marriage with no complications or with complications? Everybody has some complications. So that's what I'm going to talk about. And then I'm going to talk about insulin in Indian realities and then what we can do. A lot has been covered. There are no right and wrong answer. Because in MCQ, everything is possible, but nothing is 100% right. Nothing is 100% wrong until proven otherwise, which never happens in medicine. So, can I have, do we have mics on both sides, one at each side? Okay. So, can we start at the end? I like people who are at the end because they're very intelligent. I used to be a backbencher all my life. So, I'll start right at the end and ask, how are we, can you name one way in which we are different to that of the Europeans? Do you have a mic? Do you want to pass around? Yes, at the right at the end. Yes, sir. Yes, sir. Where are you? What's your name? Where are you from? And what do you think?
Dr. Abdul Aziz. I'm from Mirpet, Challa Hospital.
Yes, sir.
So we are different, very different from Europeans in many ways.
Yes, sir.
Number one is the amount of carbohydrates we take every day.
Mm-hmm.
And number two is the lifestyle, the sedentary lifestyle. I was the last one to go to the tea break. You know how lazy I am.
Fine.
And
Okay, that makes it two of us. Okay. The next person, how anything else? Pass on the mic, sir. Yes.
I'm Dr. Jaypal Reddy, sir. I'm from Omni Hospital. Even BMI also, compared to Europeans, we have a high BMI.
Okay. Fine. Thank you. Ma'am, please.
The protein intake is very low in case of Indians.
Protein intake. Okay. Next slide. Next person. And then we're going to change that question.
Sir, maybe the timings of food that we take are different from the.
How are we different?
We generally go late nights eating.
Late nights. Okay. How many meals, right from this side now, how many meals does your patient have in one day?
3 meals.
3 meals. और बीच में वो चाय बिस्किट नहीं होता है क्या?
Yeah, 6, nearly 6, sir.
Huh?
Nearly 6.
Yeah, nearly 6. Okay. Let's move forward. So what does your patient profile, what's your name, sir?
Dr. Nitin, sir.
So Dr. Nitin, your patient profile in your clinic, what is that typical life? How do they go to the clinic, in the daytime? What meals is their preponderance meeting? What time do they eat?
So my patient, most of them, sir, they usually skip breakfast.
Okay.
So they straight away have lunch and heavy lunch and maybe the dinner.
Heavy lunch and dinner.
Yes.
Okay. Anybody has a different patient population to them? Anybody has a different patient population who takes a heavier breakfast? Right? Okay. So ma'am has a different population. Mixed.
Yeah, some of them have a very heavy breakfast, a very light lunch, or no lunch.
Okay.
Some of them skip, especially all the business people or artisan people like that. Or they have a heavy lunch.
They have heavy lunch.
So
Oh.
it's very, very heavy.
Okay, so now let's talk about complications. So we have various complications that happen. So I want to know whether you think we have a higher rate of these complications than to our European counterparts. So in terms of retinopathy, do you think we have higher or lower as compared to Western population? Yes, sir.
Higher comparative.
Higher comparative, fair enough. And what about nephropathy?
Nephropathy is also on the higher side.
Nephropathy is it because people are worried about kidney and they go and keep to the kidney doctor, he keeps calling them every month?
Sugar control won't be on the request.
Sugar control won't be on a good side. So sugar is not on the good side in India, and that's why the rate of complications are higher. What about neuropathy? Anybody thinks neuropathy is higher or is not higher?
Probably because of neuropathy directly links with metabolic syndrome. Probably it might be high in Indians.
Okay, fine. Anybody disagrees to that? Yes, ma'am.
My understanding about the retinopathy is, I haven't seen many patients coming with retinopathy. The nephropathy and the neuropathy, I see. They hardly go and get the right test. Whereas abroad, you have the retinal screening. So they pick up. Even the initial cases here, the initial cases they don't pick up. That's what I see.
What about neuropathy?
Yes, sir, that is pretty
Higher?
high, sir.
Okay. So there is a school of thought, I'm going to go back to the slide, which says the nerves are there to a certain extent only, and Western counterparts are longer than us. So they have, wo nas wahan khatam ho jata hai, if you make it very layman terms. So they have a higher risk of neuropathy because of the more height than the as compared. Not that we don't have it. The point is we don't look out feet as well. Nobody looks at the feet in the clinic. Many people don't, and many patients don't. So that is one thing which we can teach them to have a look at the food. Now let's go back to the food. How many, last question before I go back to the slides. How many people here love their tea? Anybody tea drinking here? All coffee? I'm in the wrong audience. Okay. So do you do ready-made tea or do you do, you make the tea in the house? You do a ready-made tea, right? So basically that is the difference in Northeast. We make our own tea. We love our tea. Tea comes from there. But there's a lot of dip chai that happens. And if we can get a dip chai, basically Indians are lazy, and we can get a good dip chai, then we don't want a tea to be made ready-made, because we want shortcuts in life. So those are the things I'm going to quickly talk around. I've finished the next 10 minutes. I'm going to cover what we have discussed, and then any questions will come to that. Is that okay? Any questions so far? No, fantastic. Thank you so much. Can you move this from here? Okay, so yeah, so as we said, South Indian, this is working, it's not working. So South Asians are different. We've talked about in nephropathy, there's an increased risk. Retinopathy, there's an increased risk. And trust me, get a retinal camera. So far, so easy to convince a patient to go on an insulin once they've seen that big flashy, things in the eyes, and looks posh also in your clinic to have that there. Cardiovascular, and I think the moment a person becomes diabetic, the artery becomes sticky and becomes like Velcro. So the risk increases probable. And as we have all shared, the diabetes control in India is not very good. As we know, India DAP studies, so less than a quarter of our patients are well controlled. Peripheral neuropathy we have discussed, and peripheral evidence discussed. We have impaired insulin secretion as compared to the Western output. And despite being small, and having a smaller, I would say, different physiology, our rate of diabetes is much higher as compared to that. We have fat more here. We have, and we take pride in the fat being here. We say it's a sign of progression and prosperity. Most people say that. So that is how we are different. Our metabolic profile, our lipid profile is also very different to that are there. And ectopic fat can lead to impaired insulin secretion that can further cause beta cell exhaustion. All Asians, males and females, have lower lean masses as compared to white and black. So just gonna move around all this. See, our nutrition is very different. Exercise, we talk about exercise, we mean gym. And everybody says, was wo nahi hoga. Because it's not an integral part of our life. And I think once you make it a part, every child's ideal is their parent. What you do, your child will think that is the best. I think what my father does is always the best. The same, what we actually bring in our life, what our children will do will be the best. So if you make physical activity a part of your life, that will become a natural part of their life. It is not a forced exercise. Exercise means horrendous thing in India. Exercise karna hoga, time nikalna hoga, gym jana hoga. There are a lot of things you can do at home. Ravi obviously can tell us more later on about it informally, how we can do it at home. There are two types of phenotypes that are there. Most of the Indians have got impaired fasting tolerance and then move to diabetes, or they have impaired glucose tolerance and then move on to diabetes. And these are how the pathophysiology peculiarities in South Asians. So we've done all this, gonna move around. Carb diet, in reality, we would like less carb to take. I do a lot of CGMSs, Kalyan does, I know, and I'm sure Murli and Ravi also does. It's important, I think, to know your patient. And I think that's what helps me decide what is the best treatment for that. And every patient population is different. I have people who go to the office, they have a big bucket load of rice at 10 o'clock. Then they have a very little lunch there, and they come back and they have 5 baje kuch nasta, and then 9 o'clock a meal. Now, we can fight about what we need to do. But what is a better negotiation for them is to cut what they are actually eating. See, if I have never eaten oats in my life, trust me, I will hate oats. And I think it's more easier to change a religion in India than to change their food habit, because that is what we love. Okay, that is, we love our taste. So I think negotiating with the patient to reduce what he's eating and then find alternate ways of and showing with a CGMS graph might generally helps better. And that is how simplicity comes in. We're going to talk about what we're going to do. So definitely we need something with the prandial component of it. Now, just because the next slides are on Ryzodec, I'm not saying it. I was a non-believer on Ryzodec when I started, and it's a true point. But I'm a huge prescriber of Ryzodec today. and it has changed the way I prescribed. It's easier. Sometimes I start with the basal. No, and somebody who's gonna go to office is gonna take a carb meal. I start with once a day with their main meal, and that really helps in getting the prandial component for that. As we know that there was a question why we have premix. Can we actually have 1 day premix and 1 day basal insulin, right? Somebody asked that question, right? So if you're going to answer that question, let's look at what we are trying, what is happening in natural physiology. I'm still not a diabetic. My parents are, so at some point I will be. So we have a trickle of insulin all the time. And whenever we eat, there is a bolus insulin that's happening. And with the basal insulin, you are trying to, mimic the natural physiology by using that basal insulin, but the trickle. And whenever we are eating, we are having bolus. So when you combine a premix and the basal, there's no scientific way you're going to do it. So, either you take Ayurveda or you take homeopathy or you take allopathy. Don't make a cocktail, because we know when it's a cocktail, it goes straight to the head and things go wrong and things are a problem. So use something which is, either you use premix twice a day, or you use Rhizodec twice a day, or you use basal plus and basal bolus. But the wrong cocktail may have a little bit difficult in predicting hypoglycemia for our patients. So that would be my view on that. Now, there's a lot of data that has been there with Rhizodec, but I'm going to come to this study, which is quite useful. This is the ARISE study. This was done, and as you can see, it was not just done on countries. You can see Saudi Arabia, anything is related to Southeast have a big carb component to it. So Southeast Asia, India, and overall worldwide. And they found that if they used Rhizodec, it dropped their HbA1c from baseline from a lot of time, so more than 1%. And even if you look at these patients who were on prior treatment, significant reduction was seen in all groups on which they were on all various kinds of insulin. So it's worth a try. So there was a question before, how we negotiate 4 times, 3 times, 2 times, 1 time. I think you can start with either a basal or a Rhizodec with the main meal of the day. If you're going to do Rhizodec with the main meal of the day and take it from there. I would agree slightly with Kalyan is that I use a little bit of Repaglanide. I use a little bit of acarbose as well, but knowing how much carb is happening with that meal. So if there's a small carb load, then I use that. It works in some patients. It doesn't work in medicine. There's no right and wrong. And there's another CGMS that happens, and we know exactly what's happened. And then we can always rectify what needs to be done. But so here, despite being on oral agents, basal agents, GLP-1, basal bolus, changing them to a Rhizodec really brought the HbA1c down, the fasting down. But what is more important is that there was, if you look at the hypoglycemia, which is a dreaded memory, worry. There's a big meeting on, somebody's doing a talk on hypoglycemia, so I'm not going to talk more about it, but it's a worrying factor. And it's a scaring factor. I've seen, my mother is a diabetic. My father is the most physician in Guwahati. I'm an endocrinologist. But it really shivers me when she had a hypoglycemia. So you really want to use some agents in which the hypoglycemia rate is low. After that, it happens. But you've done what you've done in terms of your pocket or your mind to give the best available thing to them. So the last thing before I sum up at 11 o'clock is there was a concept of price. So when I started my practice, I went to a rural town, and I saw a patient came in. He was wearing a yellow dhoti. He was wearing a shirt. There were some holes in it. And I didn't know what to prescribe to that patient. So I asked him, can I prescribe you this? This is the cost of this. So the relative said, sir, please get out of the clinic. And I also got very startled. Kya bol raha hai boss? So I said, maybe I did something wrong. He's a big gunda or something. He's going to beat me up. So he took me out. He said, look around the whole land. Wherever you see land, that belongs to this guy. So what the physical appearance of the patient may not actually transform to the financial implication of the patient. So it's worth asking that question and worth telling that fact, and you never know, you will get surprised. With that, I would end my presentation. If there are any questions, I'd be happy to. Thank you.
So
appearances can be deceptive. Is that what you're trying to say, Dr. Mithun Bhatia? Yeah. All right. Okay. So question to Dr. Kalyan Gurujada. So he set the scene. Okay. So we need to send the message across as to how people can pick and choose a particular insulin regime for a particular patient. First thing, what are the things that would be in the back of your mind when you start thinking about picking a particular insulin regime for a particular patient?
So insulin, when it comes to insulin, we have a lot of choices. When it comes to the patient, he has very limited choices. So we have to understand what insulin, we'll get a flavor after some time as to which patient requires what insulin. But definitely the first thing to see is how simple is the regime, whether the patient can actually follow it or not. If you can look at the educational background of the patient, you will understand which insulin they might like it. The other thing is the convenience of timings and what is their diet and lifestyle, like how many times a day are they eating and what sort of insulin regime will best suit them. I recently had a patient who wakes up at 11. She has some psychiatric issues. She was brought in by her son. So she wakes up at 11:30, has one meal at 12:30, and then the next meal she has at 7:30, and then she sleeps and gets up again. So that's her regular regime for the last 20 years. I actually did not ask that. I just prescribed my usual TID insulin and then gave it to her. And then next time she came in with hypos in the morning, and the son then said this is her regime. So we really have to ask what is the actual lifestyle of the patient. So every patient, as the doctors in the back mentioned, there are different diet lifestyles every patient has. So diet patterns, the simplicity of the patient, of the regime, the cost factor definitely will play a part. Whether it is human insulin or analog insulin, that also depends on how quickly the postprandial meal is rising, whether they can actually use the pens properly or whether they can use the analog, the human insulins. Some people are just comfortable with even though they can afford the analogs, they are very comfortable with the vial and syringe. So those patients, we should not change it, let them continue with what they are using. So all these factors I will take into consideration before starting.
So simplicity of the insulin regime, the number of injections, or be it the times that you have to inject. 2, patient's preference and patient choices. 3, lifestyle, of which diet is a very important component, but not to forget the other aspects as well. For instance, night shift workers, right? Okay, that's an altogether different topic. And cost, that's very, very important as well. You might be thinking that a particular insulin regime is best for the patient, but what if the patient can't afford? Remember, the patient may be the bread earner and may have to feed the entire family, or maybe living on pension. So you need to take all this into context, and not to forget one very important thing, the comorbidities as well. Okay, for instance, if a person has liver failure, or if a person is planning pregnancy, you need to take all this into context whenever you plan starting an insulin regime on a certain patient. So few case scenarios, fire bang on, short and crisp answers, right? Type 1 diabetic presenting to your clinic for the first time, what would you start?
Okay.
and why? Keep it succinct, message to just go bang on.
Okay, it's type 1 diabetes. First and foremost important thing is education. So I'll have to speak to them at least for half an hour and give all the precautions regarding management of hypoglycemia, storage of insulin, and everything. Once I go through all that, and again I have to educate them how to inject the insulin, basics of insulin, all that. Basal bolus regime is my personal choice. But again, there are patients who are not very well educated, coming from poor backgrounds, from villages and stuff like that. So if I know the basal bolus regime, these people are not going to follow based on their background and how they, and you get a feel after speaking to them for a half an hour. I may actually have to go with the premixed insulin in the interest of safety rather than control.
So ideal insulin regime in type 1 diabetics, come what may, basal bolus by the textbook. Okay, irrespective of the age group. But having said that, if that particular person is not willing to use basal bolus, you don't have a choice but to go for premix insulin. That's what Dr. Murali says. Does anybody disagree in the panel here? Right. I totally agree. I think we need to use basal bolus insulin regime as a gold standard and the most practical insulin regime in type 1 diabetics. Why is that the case?
So type 1 diabetes don't have insulin. We have to mimic what our body normally does, and basal bolus is exactly what it does. But having said that, it is a long process. We have to do DAPNE and carbohydrate counting. We have to make sure that they understand that. I mean, initial days of type 1 diabetes management is not about getting the control. It is about basically making it safe for the patients so that they go into DKA. They don't go into DKA or hypoglycemia, and slowly you get them there for the control.
Right. Dr. Mithun Bhartia. Okay, now you are not in Northeast, you're in Hyderabad. Okay, you got a patient sitting in front of you who has come for sexual problems to you. But you find that there is something which is as important, if not more important than the sexual problems here. Okay, the person has HbA1c of 10%, is a type 2 diabetic for 5 years, age 50 years now, 50, and the person has got all affordable, all money on his side, to spend to you and for his towards the care that you provide. Okay, so money is not an issue at all. But the issue here is HbA1c, which is staring at you at 10%, and the person is on all oral anti-diabetes agents that you can think of. Okay, and no significant comorbidities so far, except a bit of microalbuminuria, except a bit of hypertension, which are taken care of. So what is the ideal insulin regime? And if the person does not accept this ideal insulin regime, is there an alternative? Keep it succinct, Chris.
Succinct. You see, pregnancy, everybody does what you ask them to do. A patient comes for a sexual problem, he will take 8 times an insulin also if you prescribe. Let that message be very, very clear. Okay, I know Ravi doesn't want that answer. The first thing is that because he's motivated, he wants. The moment you say diabetes is a key person, he will do it. I inject the first dose of the insulin before even telling him, because the fear of the insulin is far more than the actual injection. And then I have a conversation with him as to how many times the insulin would be happy to do it. So I inject the first dose right there, a basal there, 10 units straight away. And then we talk about, because then that fear of insulin is gone from his mind and he's ready to talk to me.
So don't say that you promise good directions just with insulin. Never mind. Okay, jokes apart. So what we are speaking is, if a patient comes to you with some problem, and if that can be related to diabetes in one way or the other, then the person might be able to listen to what you're saying. And as Dr. Mithun has rightly pointed, basal insulin is perhaps the best in terms of simplicity and initiating. But do you think really it's going to bring down the A1C to ideal levels? And what is an alternative, and what is perhaps better in terms of its ability to bring down A1C and its simplicity?
So I think basal is, because you insulin naive patient, the worry is there, the negotiation is there.
The person is willing to take any injections, you say, just because he's worried about his erectile dysfunction.
Yeah. Basal bolus is ideal. I use majority basal bolus. Otherwise, Rhizodec twice a day.
No, let's not go with names. Okay, you want to go with co-formulation or premix twice
a day, or I use basal bolus. That's besides it, and patient will engage. And if there's a small meal, I use something like, as I said, a repaglinide or an acarbose. I agree with Ravi. I've had good experience, but presumably the carb load is different in Northeast. So maybe my patient profile are different. But whichever way, you can add, subtract, whatever it is. Ideally, basal bolus mimics natural physiology. There's something that it increases risk of hypoglycemia. Not that if you know what's happening is monitoring his sugar, you can work it out there. And at that point of time, patient engages in sexual medicine. Sexual medicine is a different ball game like pregnancy. They are very much, because marriage is on the big rocks. Huge investment of 20 years. Marriage is very expensive nowadays. Kids are expensive.
So,
Any questions?
We'll just ask some rapid questions here.
Any questions from anybody?
No. Another question. There's a young lady, 25 years. Okay, she has got history of type 2 diabetes because of being obese. BMI is 38. She tried her level best to lose weight. You're hearing it right. 25-year-old young lady, high BMI, type 2 diabetes. You've done all the workup, all the investigations, which we'll discuss later as to how you tease out type 1 and type 2 diabetes. That's a different talk altogether. But you diagnose that it is type 2 diabetes. Somebody referred to you, okay, from one of the rural backgrounds saying, look, this person needs insulin apparently. That's what I heard in ACES, one of the meetings. Now, can you please help us out? Okay, so the patient is sitting in front of you. Okay, patient is already on metformin, sulfonylureas, and also SGLT2 inhibitors. Patient doesn't want GLP-1 receptor agonists, and the A1C is 8.5. Okay, how are you going to address this? Patient is planning for pregnancy. That's the key thing here. Patient wants to become pregnant as soon as possible. The in-laws are after her. Okay.
So we are seeing this scenario quite often recently. Early 20s with huge insulin resistance, almost going into beta cell failure because of obesity, or may not be because of obesity. There are these thin patients who are insulinopenic and who are going into early beta cell failure, who require insulin, and for which your high dose of metformin, pioglitazone are not working. So these patients require early insulin, regardless of whether they want pregnancy or not. Again, I have two choices for them: either to add on a basal insulin to their already existing OAD regime, or to switch to a mixed insulin with some insulin sensitizers on board. So insulin sensitizers are important to continue, especially because of obesity and insulin resistance. Otherwise, your insulin requirement will go up huge. So I would continue with the SGLT2 inhibitors, continue with the metformin, but add in a premix insulin to start with to get at least a decent glycemic control of HbA1c of around 6.5 or less for them to for the lady to start her conception. Again, GLP-1, if they are not willing, that's fine, but that would be a good add-on to it. So a basal to their already existing OAD regime, or a premix insulin with insulin sensitizers is good.
I'm very much concerned about this particular patient getting pregnant. What would you do?
Okay, if
this particular patient came to your OP, she's planning pregnancy and she doesn't want to use any protection. Okay, but you told her, look, 8.5 A1C is not ideal, but she said, doc, it's not in my hands, I may fall pregnant. You told her level best, don't become pregnant till you optimize the sugars. So what are you going to do?
So in that case, the straightforward thing is to switch to a basal bolus regime and continue with the metformin only. SGLT2 inhibitors are not licensed in pregnancy. Even metformin in certain indications is not licensed. But all of our endocrinology, we continue metformin during the pregnancy. So we continue with metformin, put them on basal bolus regime, get the A1C down as quick as about 2 months to about close to 6%, and then she can get pregnant. Or even if she gets pregnant during this time, although the A1C is not down, her glycemic parameters are down, so it will be safe even if she gets pregnant.
Very important and practical point, because there are a lot of patients out there who are in their late 20s, early 30s, who want to become pregnant. Okay, and remember, you can't afford to continue them on ACE inhibitors, ARBs, statins, if they are really planning pregnancy in the next few weeks and months. You ought to adjust these medications. This is a very common scenario. Same with your oral medications as well. Stop all the oral medications except good old metformin. Counsel them, please, and start an insulin regime that they're going to use to bring their blood glucose levels to near normal range, as Dr. Kalyan already said, around 6.3, 6.4, 6.5, and they can conceive happily. Okay, this message has to go across, because there are a lot of patients around who are actually messing around, and unfortunately some of the doctors might be as well, without a lack of insight into it. One question, Dr. Murali. So now you got a patient who's got has got suboptimal control. Let's assume patient is 50 years old again, okay, type 2 diabetic for 2 years, okay, is on all medications, okay. Patient unfortunately is an auto driver, okay, and can't afford all the posh insulins which most of Dr. Mithun's patients can afford, okay, in your place, Vijayawada, okay. I'm just giving a real life scenario. So, and what are you going to do next? Okay, you do have all the posh basal insulins there, you got all the premixes there, you got the co-formulations there, you got all the really nice basal bolus insulin regimes there. What is a realistic answer for this patient? Think about his pocket, think about his family.
Okay, I think auto drivers have a very irregular lifestyle. Even food eating can be really chaotic because it's not really in their hands. Depending upon their HbA1c, I may just get away with just regular insulin whenever they eat. That would be one way of doing it. And also now we have cheaper versions of glargine like Basilog and things. With the syringes, that could be an option. And even mixed insulin once or twice a day when they eat, that would be an answer. So It all depends upon how high the HbA1c is and how aggressive I would like, because I don't want him to have a hypo while he's driving.
Yeah, basal or premix insulin in this case. Speaking about hypos, I know we'll come to it later. I'll bring up this point when we speak about hypos as well. Dr. Mithun, this particular patient is your driver, your car driver, okay? You are busy always, sleeping in the back of the seat because you're tired educating your patients about sexual problems and other problems, okay? Right? You're literally in the back of the car. You want your driver to take you carefully. You are willing to pay this jab, whatever money it's necessary. What is the best thing that you would start on this particular patient with A1C of 9%? What's the best insulin regime? You're thinking about your damn safety here.
So if I'm saying about my mind, so see, I also do diabetes. Ravi is saying I do only sex, but I do diabetes as well. So let that be very clear. So these patients that are going, my driver knows that I'm going to give him a break at very irregular times. So he is going to go on a basal bolus point blank. There is nothing else he can survive working with me, because he will not know when he's going to get a break. So he can do that. And if he's willing to have one less injection, then maybe a mix in the night with 2 boluses in the daytime. That is what he would do.
Kalyan, what's your answer for this? It's your driver now. You're willing to supply the insulin, okay, for your safety and the safety of other people on the road. So what are you going to give to this person? His A1C is 9%, okay, all the oral medications at work. What is the best insulin regime that you would give? And you can name some examples of the basals and the boluses as well. That's the last question for this session.
Yeah. So we come across a lot of these patients who cannot afford all the analog insulins and the pens. So the best insulin for them will be, I agree, a short acting in the morning, a short acting in the afternoon, and a mixed insulin in the night. I personally use a lot of this regime. It works well. I have double checked it with sensors. It really works. So you don't have to have a basal bolus regime, and the patients are happy with the 3 times daily insulin. Now, the other small thing I want to add is that you can, the advantage with the bottle is that you can actually mix both of the insulins, just like what we used to do in the old times, mix a short-acting insulin and the NPH insulin. So I asked the patient to take a little bit of the regular insulin, about 10 units of that, and then 10 units of the mixed insulin. So that will give a slightly higher short-acting component at night, just in case if he needs a little more short. So you have the advantage. So definitely, first thing is in these patients who are poor, bottles are enough. You regular insulin, they will stick to that. If you prescribe them pens, they will not come back to you. They will go to some other doctor. So vials, keep it only 3 times daily, and you have the flexibility of mixing these 2 insulins at night in case they need a higher short-acting component.
Yeah, personally, I would go for basal bolus insulin regime in this particular patient because it's the most physiological, and I'm supplying, and it's my life and that of my family and that of the passengers. I mean, we can always disagree, but that's what I would particularly go for. I would not go for premix at night and 2 boluses and ask them to take a bit of that and a bit of this. See, it's my life at the end of the day. I don't mind spending a bit extra for his safety and my safety. Anyway, it's a different viewpoint. Without any further ado, I think we should go to the next one. We'll take your questions. I haven't forgotten that I haven't involved you guys, but we'll take any questions. We've got plenty of time for questions after this. Insulin dose titration optimization by Dr. Kalyan Chakravarti, please.
Right, thank you. So let's start off with these slides. A simple case scenario: a 52-year-old gentleman working in a hotel, has 10 years of diabetes, who's come in with some paresthesias. He's on once daily premix only. For some reason, he's only on once daily premix. Let's assume that he is already also taking some oral diabetic medicines along with this. So he's about 82 kgs. His HbA1c is 8.5. He's got a higher fastings and higher post-lunch. How will you calculate the insulin dose and how will you do it? So what is the simplest thing for us to do here? Anybody? So let's say he's on some sulfonylurea metformin and he's just taking only some premix in the morning. So what can we do to get his glycemic control down? So where is the higher glycemia? Is it fasting or post-lunch? High. Exactly. So we need to address the fasting first. So how can we do that? How can we treat this? Yes, so that is the first simplest thing to do. He's on morning, somehow, some reason he's only on the morning, you add a premix at night, that will solve the problem. So that is one thing to do it. Any other suggestions?
Before 3 weeks, I can add basal insulin at night, and we can give some oral insulin in the morning.
Sure.
Oral medication.
Oral medication. So we don't know what oral he's on. So I agree. We can give him some DPP-4 inhibitors or acarbose or something to bring down the postprandial hyperglycemia, and we can add a basal at night. So ideally, they should be either a twice daily premix or a basal at night. So the recommended thing to start is a basal dose. You can start anything. You can start either a deglutec, even NPH if the patient is not affordable, glargine, detemir at 10 units. So the recommended starting dose is about 10 units. And this is only if I'm talking about only purely if you are starting a basal unit at night. So you can start at 10 units. These are all guidelines from the West. Our patients, Asian patients, do require a slightly higher dose. So I'm safe to start off with 16 units. A lot of the times, as inpatients, this is one thing I wanted to just highlight here. A lot of inpatients who are not eating properly, we just give them a basal insulin and then you give them that actrapid according to starting scale or something for the first 24 hours. So this basal 16 units works very well for me. 16 units is sort of enough to keep the night sugars down in a lot of the inpatients that come into the hospital. I'm pretty sure that same thing works for our patients also. So the guidelines recommend 10, but I'm pretty safe to start at 16. The recommended target for titration for fasting plasma glucose is about 80 to 130. So we ask the patient to, once we start them on insulin, we ask them to check their sugars every 3-4 days or every week. Check the sugars, predominantly the fasting. As you rightly pointed out, sir, once we address the fasting, the post-lunch automatically comes down. Forget about a scenario where your fasting is 110 or 130 and your post-lunch is 320. That is different. But a 50-60 difference or even 100 difference can bring the fasting down, the post-lunch automatically comes down. So that is the point of checking only the fasting plasma glucose in a patient who you've started on basal dose insulin. Check the fasting, increase the insulin in increments, ensure that the fasting comes down to less than 130. Although it says 80 to 130, I would target only 130. That's all. The newer time in range targets that have come will change the diabetes as we see. As long as the patient is having the time in range is 70 to 180. As long as the patient is having glycemic range in this particular levels, they are fine. They are not prone to have any retinopathy or neuropathy. So it doesn't have to be that the high fasting has to be low, post-lunch has to be. So as long as you bring everything into this range, you're fine. So once the patient hits 120 or 130 after your initiation, that's it. Ask them to stop titrating further. They don't have to come down to 100 or titrate it down, but that's much easier. Just titrate by 2 units every 3-4 days until your fasting comes down to 130. That is a much simpler regime to follow. With the premix also, the guidelines are the same. You recommend to start a premix insulin at 10 units twice daily, once or twice daily, and the rest of the points are all quite same. Even the titration is same. Once daily premix, generally we do not use, so I'll switch to the twice daily premix. So we can start at 6 units twice daily. Again, this is the Western guidelines, so they use much lesser insulins. I start at 25 units in the morning and 20 units in the evening. That is my starting dose. And endocrinologists, we are very aggressive than the rest of the physicians. So we start at a very high dose. We are not worried about hypos. We can take care of them. So 25 units and 20, that's my starting dose. Of course, this is in patients who have OAD failure, who are switching to insulins. If you want to add premix, and there is some evidence that you can do it. So patients already on a full sulfonylureas and metformin, you add a little bit of premix. In those cases, maybe you can start around 12 units in the morning and 8 units in the evening, and then build it up slowly. There is some consensus that you can actually do it as 2 equal doses, or to do it as a 70% or 60% in the morning and 40 in the evening. I personally do give it a slightly higher in the morning because of the evidence from the sensors. Basically, you get the amount of postprandial peaks that we see after meal. We give more insulin in the morning and less in the evening. The target is the same, 130. And you reduce it if there is a hypoglycemia. now to titrate the premix can be a little tricky, I should say, because you don't have only one value to see. If you have a basal insulin, it's simple. You just take the fasting and titrate your sugar insulins accordingly. But in a twice daily preparations, the parameters can be a little tricky. Yes, okay, for the night basal for the night premix to be adjusted, you need to see what the fasting sugar is. That will not take into account what the post-meal sugar is. So the post-meal sugar may be normal or may not be. So the patient might have a low sugar at after dinner. The trick with the twice daily premix is that you have to get it as long as the sugars are less than 180 during the day. I'm fine. That is what I tell the patient, because that newer time in range targets do say that it has to be less than 180. That's all. So as long as your random sugar, maybe 2 hours after meal, if they are less than 180 or 200, that's it. Don't do anything. Just stick to the same. Of course, in gestational diabetes or patients who are trying to conceive, that's a different matter altogether. So roughly, this will be my pre-meal dose adjustments based on your glycemia, how you will switch your insulin. Then comes to the basal plus insulin. You can use it in patients. Again, you have to have really robust evidence of either sensors or continue. There is SMBGs quite frequently, where they have one bolus in the morning and the rest, the bolus will be the basal will be only at night. This works for some patients. I wouldn't say for all patients, but it does work for some patients who do not have some. I have 2-3 patients who I use the regime who somehow do not in the morning. You titrate by about 4 units or 10% of the basal dose, and you titrate the bolus according to what the 2-hour post meal is. So 2-hour post meal you can target at 180. The fasting you target at 130. That's the only thing. If there is a hypoglycemia, you have to reduce it. So again, if you can tell the patient the same thing, just you have to aim for a fasting of 130 and aim for a postprandial of 180. Keep increasing by 2 units until you achieve that. Simple thing to tell the patient. Now, coming to basal bolus insulin regime. The insulin requirement generally, total insulin requirement per day is calculated to be around 0.5 units per kg if the patient does not have much of insulin resistance. So if a 60 kg patient will require around 30 units. Now, technically, ideally speaking, I'm sure you must have all seen none of our 60 kg patients, none of our patient is 60 kgs in the first place. They're all 80 or 90 kgs, and they will definitely require more than 40 units. So their requirement is close to around 1 unit per kg, but it is better to start off with a 1 unit per kg. The reason being that if you start aggressively, the patient, once he has a hypo, he will not come back to you. Simple as that. I have a lot of patients who gone to other doctors just for that reason. So I've learned to be a little less aggressive than what I was previously. So, and one other thing practical point to tell is that when you're switching the patients from sulfonyl, let's say a patient you have diagnosed as OAD failure. The patient that has OAD failure, it means that the HbA1c is 9 on maximum dose sulfonylurea and metformin, which is we commonly see. We stop the sulfonylureas, we start the insulin. This overlap period where the sulfonylureas are washing out and we start the insulin, patient is very prone to get hypoglycemia. I've had 2 or 3 patients who were admitted for the same reason. So simple practical point I want to make from my experience, from my bad experience actually, is that when you stop the sulfonylureas and you're switching them completely to insulin, give a washout period. The sulfonylureas have a washout of almost 48 hours, and it can extend to 70 to 96 hours if there is some amount of CKD. So especially glimepiride. So please give out a washout. I ask the patient, stop the sulfonylureas today. Don't take any tablets. Don't take any insulin today. Start the insulin from tomorrow or tomorrow evening. That's a safe regime. That's the safest thing to do, and that will avoid the hypos. And I've done this for the last 1-2 years. I've not seen any hypos. And it is recommended to start at 0.5 units for the whole. So your whole total insulin daily dose should be around. So if there's an 80 kg patient, assume that he requires 40 units. You split that by 60% as a bolus, and 40% will be the basal. So that means if it's a 40 units he's requiring, you give them about 25 units as split into boluses, and the rest 15% as basal.
Similar titrations, you target your postprandial to less than 180 and your fasting to less than 130. If you're using if anybody of you are using the sensors, it's much easier to do that because you have a graph. You just have to get that graph into the normal range line. That's all. So I always recommend to modify the dose based on the mean value of the last 3 ppg values, not just 1 ppg value. Similar titration. Right. Now coming to how to inject the insulin. We will come to the practical aspects later at some point, but I'm just going to quickly just show you a few things that you have to see. So resuspension. Before the first injection with the new cloudy insulin, what is a cloudy insulin? So that there are 2 types of insulin, the rapid acting or the short acting, which is clear, which is supposed to be absorbed quickly, and therefore it's very clear. The insulins which are cloudy are the NPH insulin and the long acting insulins. Because they are much more thicker in suspension, they are designed in that way so that they are not absorbed very quickly once they are injected. So when you put a premix insulin on the floor for a few days, you will see that the sediment, the longer acting insulin settles on the bottom and the shorter acting will be on the top. So when you directly take the pen and inject, most of the times it will be only the short acting that will go in. So you have to mix the insulin a few times, roll it in your palms or do whatever action. They say not to shake it too vigorously, but just a gentle rolling will regularize your mix, the mixed insulin or the long acting and the short acting properly, so that the amount of injected dose is the same as what is prescribed. Otherwise, they are just injecting the short acting. And we teach this to the nurses in the wards also very regularly, so that they also follow the same thing. Even the vials, they have to shake it a little bit. This is the mixed insulins. The end point should be that the insulin should be clear. There should not be a clear thing on the top and the cloudy thing on the bottom. It should be a mixed cloudy mixture. The good thing is that with the newer insulins like IDEC ASP, this resuspension is not needed because this problem of the sedimentation does not happen with that. With the dialing and injecting, we'll come to that later. Yeah.
You can just touch base.
Yeah. So a lot of the insulins, the one thing I want to make sure is that there is a lock with these Novo pens. There's usually a lock, and sometimes the patient cannot dial it up. And it's just simple to just take the lock off, then dial it up. Make sure that the needle is inserted properly into the stomach, and it should go all the way up to the hilt, where I tell the patient you should touch the plastic. The plastic should touch on your stomach, and then you inject it. Make sure you hold a pinch of the skin. Don't keep the pinch should go when the insulin is injected, because if the pinch continues, then you have a back pressure and the insulin can come out. So once there is a fold of skin that is pinched, you inject the insulin and leave the pinch so that there is no pressure and the insulin can distribute equally. Once the whole insulin goes in, we have to hold the pen for at least 10 seconds, before 6 to 10 seconds. Hold it, make sure that it is, because the whole point is that it's a very small needle. So when you press, it might not go all the way in. And when the patient is coming out, when the patient is putting his pen out, there still might be insulin that is coming out because it is a smaller passage. The insulin syringes that we use have a bigger bore. And wait for 10 seconds and then come out. There might be 1 or 2, just a little drop sometimes that can come out, but that's okay. That as long as the technique is good, this is okay. There can be some blood at times when the patient injects, and that is also fine because they are sometimes touching some capillaries. So this is like an extreme case of lipohypertrophy. We don't see this very often, but if you are continuing to increase the insulin doses and the patient still having sugars of 300 plus, 2 things you have to check. One is, as Dr. Ravi Shankar said, what is the technique? How are they actually injecting? Whether they are injecting the right insulin, whether they're injecting at the right place, there's so many factors that can go wrong. And with this, as we have seen so many things going wrong personally ourselves, and lipohypertrophy. I'll tell you an example of a patient, GDM, gestational diabetes patient. And I used to go to Sangareddy previously, and I used to go there only once a week. Every week I went, I increased the insulin by 10 units, 12 units. The patient still does not have a good control. So I asked her to bring the pen and show me how she used it. I was surprised that this is after education. This is after my personal education. She was not removing this cap. This happened. She was just keeping the cap and then injecting, assuming that she's injecting, and she's saying, oh, that's why the insulin was leaking out to the side. So this does happen. So there's so many things that can happen with you prescribing and the right amount of insulin actually going into the patient's abdomen. Rotation, site rotation is important. So we tell the patient, wherever you have fat, you please inject. There is no point where, except, in the center of the stomach where you can have more capillaries. And that's why we don't allow, suggest the center of the abdomen, but they can have anywhere on the sides of the abdomen, the thighs, the arms, wherever there is fat. And keep rotating the side. So the patient says, yes, sir, I rotate. I put one here, one here. Both of the sides, there is big lumps when they come next time. So that is not changing. Rotating side means you have a clock on one side, on the clock on another side. You keep rotating on one side and the other side also. Whenever you are injecting, you have to come to the first injection point. It will be at least 1 or 2 weeks before you come back to the same injection site. That's the amount of times he has to change. Making the right skin fold. So you should not pinch the skin too much because you may get into the muscle. Just a tiny bit of skin to get the really small needle into your skin fold, and that's the making the skin fold. This is a very good slide that's been used in quite a few of our talks. If you see that the new needle, the needle has to be changed every 3 times. That is what I tell patients, every 3 times. For a basal bolus regime, it means that the short-acting insulin, you change it every day. The basal insulin, you change it every 3 days. If the patient is using a premix insulin, okay, fine, change it every 2 days. The reason being, if you see the new needle is so sharp, and as the needle has been used once, twice, and 6 times, you see the amount of bluntage this needle can get. And what happens is the patient actually has a lot of reaction to it, and the patient can develop lipohypertrophies, bleeding, bruising. All of these things happen with older needles. So very important to change the needle every 3 times. How to store insulin? Very quick point. So this is one of the excuses the patient gives, that, sir, you have to start on, sir, I don't have a fridge, I cannot take insulin. Or, sir, I am traveling, I travel all the time, I don't have fridge in my office. Simple thing. All insulins can be stored below 25 degrees. As long as the temperature is between 8 to 25 degrees, which our climate has, we are fine. Bottles, vials, bottles, pens, everything can be stored at room temperature. Simple as that. The pens we are using, not stored, the ones pen we are using. What we are not using, that has to be stored in the refrigerator. But once we are using, simple room temperature. It's as easy as that. Okay, in summers, it can be a little difficult. Summers, our temperature. Somebody is living in AC rooms, forget about it. You don't need to tell anything. If they are in AC rooms and the house is air conditioned, you forget. You say that's fine, your room temperature. But in summers, if somebody does not have air condition, tell them to store it at temperatures, the mud pots, kundas. So they can store it in that if they don't have a fridge. If they do have some fridge in the neighborhood, they can store that. And if they're taking it to the office, they can happily carry it in their bags. The main thing is to not to put it close to your body, because our temperature is 37 degrees and the insulin will not take that. And it should not be frozen because the insulin can get thawed. So you should avoid storing, and it should not be put in a car also. In a car with closed windows, the temperature can go up much higher. We should avoid that. So that's it, and thank you very much.
Thank you, Kalyan. That was an excellent talk, to say the least. So insulin is stored in the fridge when it is bought and when it's not open for first use, not on the fridge where the stabilizer is. Had few patients, right? Where the insulin was damn not doing anything what it is supposed to do. You check with the patient where it is kept. It's nicely put on the stabilizer or just besides the stabilizer. Have you ever tried to touch the stabilizer? Don't do that. The one, which is supposed to prevent the fridge getting burned out. We'll get a lot of anecdotes, okay? And injection is into that tummy, arms. Arms are not a big favorite because it can directly go into the muscle, especially if you are somebody who gyms, just like our Dr. Mithun Bhartia, who cited it earlier about gyms, and not into the calves, okay? I had 2 patients who presented to me for the first time who had calves bigger than that of Ben Johnson, okay? And it's just because the patient has been injecting all these years into the calf muscles. I don't know. It's a shame on us as medical professionals that we can let something like this ever happen. All right. So make sure that the patient is injecting where it is supposed to. And another anecdote, just so that you don't miss this in your real life practice, just like how Dr. Kalyan told you, injecting without removing the cap, what can happen is even worse, right? They twist it, okay? Put there, twist back, take it out. Somebody who was on 300 odd units, this lady came all the way from another country to get her colon surgery done here. Okay, she needed something like 360 units or something. I can't remember on top of my head. We thought we trained her well. Okay, so again, I blame it on our system, and because I happen to be the care provider, I think I own the mistake, right? Because the nurses haven't trained her well enough. So she was, I've been increasing it to 500, 600 units as outpatient. Sugars were very well controlled as inpatient, but outpatient, I was increasing it to 600. I was like really frustrated. Sugars were 400s, 500s. I was the patient to come and say, how are you injecting? Can you show that to me in front of me? Do that. If in doubt, ask them to get the insulins and ask them to physically demonstrate. This is what she's been doing. So unfortunately, there's a lot that happens between you prescribing and the insulin not going into the system in the doses that they prescribe, that you prescribe. Not to forget that patients think that they can self-manage. I don't blame them. That is the final idea, but they may not be capable enough or empowered enough, and they cut down the doses by themselves. Last but not the least point from the talk of Dr. Kalyan, it's good to be brave, but at times it's good not to be as well, okay? Especially if you're somebody who's starting to learn to train your patients give insulin. So step back, err on the side of caution, as you rightly mentioned, gradually titrate rather than be heroic and give 25 units morning, 20 units in evening in a newly diagnosed diabetic. Okay, if you're an endocrinologist or if you're a senior physician who is confident, comfortable, that's fine. But if not, always step back, start with 8 units. It might take a little longer to achieve what you want to achieve. But if you induce a hypo, remember that patient will be the last one to turn back to insulin, not just to your OPD. Okay. And one very important thing which you mentioned, when you're prescribing insulin for the first time or changing insulin regimes, be cautious about sulfonylureas and the overlap. Somebody who had 4 mg sulfonylurea, something like glimepiride this morning, and you start prescribing insulin from tonight, look, there's a good overlap between the sulfonylurea, and remember, you might be inducing hypo. Same with basal insulin. Somebody is on, say, 36 units basal insulin. You want to change this person to premix insulin twice a day. Make sure you prescribe the insulin and say, start from tomorrow, and tell the patient to start from tomorrow, not today night. What happens if you start today night? See, this 36 probably you might be dividing into 20 in the morning and 20 in the night, and you give 20 units tonight. The patient would have an overlap between the basal insulin and this premix insulin. Patient would have a good going hypo tomorrow in the middle of the night or tomorrow morning. Will never excuse you. May not actually continue to use the insulin regimen that you prescribe. There are a lot of questions. I know we can have an interactive session now. So I asked the Novo team to make sure that 2 tables are merged. Okay, you don't have to physically merge them. The participants in 2 tables are at one place. And we have, in the first table, can we have Dr. Murali Ganguri, please? For the first row. Ma'am, you might want to join the... No, will provide masks. So you will go to the first row. Dr. Mithun will go to the second. Dr. Kalyan will go to the third row. So each row has 2 tables, right? And Dr. Sushil will go to the fourth, and this gentleman will go to the 5th, and I'll be overseeing things. What we're going to discuss is right from how different each device is, the insulin pens. How are we supposed to educate our patients about, just opening it, putting the cartridge in, to every basic, to how to use the needles, how to twist it. You don't have to feel ashamed. I really don't know about any newer devices that come into the market. I take the help of these guys. Okay, we all learn at some point. So I request you to please learn it from scratch. If you're not comfortable, you can ask however silly the doubt is. I ask the Novo team to the sales team or the marketing team to distribute themselves one per each table, as in one per each row. So there are 5 rows here. There'll be one guy for each row. Can you start? One person comes to the first row. Second, keep dividing. And remember, coming to insulin needles, I'm a big fan of changing the insulin needle each time if you really want less painful. But at least after 3 pricks. Okay, so let's start. We got about good 20 minutes. We can reassemble after that, and we can take any questions. Yeah, you got to demos, right? About the Novo guy. So you guys can come in. You guys can come in. You can go back to it. You guys can come over here. So you guys want to come here? You can stand. You can stand. You don't have to sit. You guys, you may come here. Yeah, go now.
They use an introduction. You cannot open this. But other people might. Oh, okay, fine. So I was saying that anybody who you are initiating the insulin on, it's better to use a flex pen rather than the cartridges. The flex pens are use and throw, where the patient can just inject the insulin. Once it is done, throw it off. This contains 300 units of insulin. So if you want to tell the patient how much it will last, it depends on what their dose is. If they are on roughly around 30 units per day, it may last 10 days. Simple as that. What insulin is? I have a diabetic nurse with me. Every patient who I initiate insulin, either I patient or outpatient, I tell the diabetic nurse to go, give them counseling about the injection, how to titrate the insulin, dose the insulin, and hypoglycemia. Every patient who you are starting to see on should call them about hypoglycemia, because they are new. These things don't happen. They go hypoglycemia. So any patient insulin initiation, you should have a hypo management also. So that's the first important thing. Then when you are starting the insulin, when you're telling the patients on how to use this, it's a simple thing. Tell them that first thing, this is a pen. This has about 300 units of insulin. You don't have to store it in the fridge. You can just put it in the room temperature. If you're going to work, take it in your bag, put it in your pocket, room temperature, body temperature, make the insulin not work. This has two things. There will be the needles. So whenever you prescribe in the first place, like when you prescribe to the pharmacy, prescribe the NovoRapid or whatever other insulins you are doing, either Flexpen, so prescription is also important. You have to prescribe NovoRapid cartridges or Acrapid cartridges or something, plus NovoPen, which is NovoPen 4, which is the pen that is used to carry the cartridge. Or you can say, right, Flexpen, NovoRapid Flexpen, Acrapid Flexpen is also there. Other companies also have Flexpen. They're branded. So write either Flexpen or cartridges plus NovoPen or vial. So that will be much more clearer to the pharmacy. Vial, cartridge, Flexpen. That is the way to prescribe. Whenever you prescribe the pen, please also prescribe the syringes or needles. So the ones we have are the BD microfine needles. You can say insulin needles, whatever company they have no fine needles, BD water. So you also prescribe needles along with your pen. So that otherwise the patient will come only with this, the pharmacy won't give this. It will be difficult for us to do. So write Flexpen plus insulin syringes, or you can say needles, microfine needles. So once the patient comes back, this will come in a pack of 10. This will come by itself. Some people give it with, come with a frozen pack of some coolant or something. You can just take the pill. Ask the patient, just take this away, take the needles. Each needle should be used 3 times. The way to attach the insulin is to screw it on to the top of the pen, right? And then take the cap off, and you will see, I tell the patient, this is how small the needle is. I think it's about 0.1 or 0.2 millimeters in the pore. The length is around 1 centimeter. So very, very, very tiny needles. And once I put this on, then the pen is now ready to use. Then you dial the insulin. So if I prescribe you 12 units, you dial it up to 12. Number is here. You dial it up to 12. Clean the surface area with a little swab or something. Clean it. And then inject the insulin perpendicular. It should not be at an angle. It will be perpendicular. A lot of the patients complain that when I inject, there is some blood that comes out or there is swelling. Very painful. The reason the insulin is painful when they inject is because they are injecting it at an angle. So what's happening is they are actually infiltrating a lot of the cutaneous nerves. That's what causes the pain. The adipose tissue is very painful. So if the patient injects the skin, it should be just a one prick point where it crosses the skin and it goes into the subcutaneous. Once it goes into the subcutaneous tissue, then what are you pain? So it has to be perpendicular. Don't worry about the muscle. So they can use a pinch so that if very lean patient, they do not inject the muscle. So if you take a pinch of the skin, it will only be in the subcutaneous tissue. Inject it perpendicular, go all the way up to the hilt. The plastic has to touch the skin. That is the right. You should feel the plastic on it. And a lot of the patients will have this circle when they inject. So when they inject, all the way in, and then press this, automatically all this will. If you want to check, sometimes this is another practical tip. Sometimes the patient says, "Sir, this dial is going back too quickly. If I inject, there should be fluid coming out of that." Sometimes this pen and any other pen can get stuck, and there's a spring that is behind this, which actually pushes it, just like what it has in the pen. And sometimes when you dial it up and inject it, this flow does not come out. So I'll tell you how it feels like. So when let's say the spring is not working properly, and I dial it, you just go very quickly. So the 0 to 12 should come very slowly. Only then the injection is coming. If it goes very quickly like this, the spring is gone. That means it's time to change the pen. So the best way to check whether this will come. Patients will come and tell you, sir, this pen is not working. Unfortunately, the company guys are not there. So the quick way to check that is you dial it up about 4 units, inject it in right? That will now, when the patient injects, you dial after dialing up, you press directly until it comes to 0. Once it comes to 0, wait for about 10 seconds, 6 to 10 seconds, 5 to 10 seconds, 10 seconds before they come out. Because the pressure with which you are pushing will not translate into the pressure that is coming out. The needle is quite small, it will take a longer time for that same amount to come out. So make sure you hold it for 10 seconds and then come out. If there is a little drop, sometimes that's okay. A little drop here and there. Sometimes there might be blood, that's okay. Sometimes there might be a little fluid that will be leaking out, that's okay. If the patient presses the skin and injects the insulin and keeps the pinch like that, comes out, there will be a huge pressure here. The insulin can seep out. So always what we ask them to do is once you inject, take off the pinch, once you and then count for 10 minutes, count for 10 seconds, come out. They can, as you said, sir, they can close this or not. It's up to you. Sometimes yes, it does. It happens to me also a lot of the things. So that's it. Now I'll just quickly show you the cartridges, because these can be tricky to open. So the patient will get the cartridges. This is how he will get it from the pharmacy. This will be the Novopen, this will be the cartridge. You will get this as a cartridge and you will have separately. So you can open it by just twisting it. Same with other companies also. Just twist it, it will open. You can put the cartridge in straight away like this and then close it. This Novopen especially has a lock system. Just to prevent like the children or somebody playing it. So you have a lock. Have to open it lock. So you can try that once you open the lock. If you put the lock in, you see that let's say I put a lock at 8. Can you dial it? Yeah. A few patients have actually come to me with the same problem. Sir, this is not dialing up. And it took me some time to understand. Only if you draw it back, and then, yeah, I think you draw it. Then it will dial up. When you press it, yeah, there's no needle line, but when you put it at 0, push it, and then you try to dial it. Draw it out. That's one. So that is this is especially for the Novopen. I don't think other paints have the same. So that is how you dislodge it. Sometimes these few tips is that these cartridges can break. So you will see a leak of insulin. So when you're actually holding it, you should not see any leak of insulin. So let's say if you have a pen, the patient gives you, sir, there is something wrong with this pen. You open it and you see some insulin, you smell the insulin, that means the cartridge is leaking. And it's better to leave the cartridge. The other thing that can happen is, I told you, the failure of the spring mechanism, where the insulin just comes out. Like that. The lateral abdomen, anywhere. You can go as lateral as left and lateral. If the patient has lipohydration, generally the easiest thing for the patient is to inject the because that's where our easiest point is. Somebody's left-handed. So you see a lot of lipohydration happening. When you ask the patient to change sides, they assume that they will change sides, not sides. So specifically tell them that you can inject, go laterally as much as you can. So 1, 2, 3, 4, 5, 6. They can go laterally, or they can go 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8. When they inject today, if today they have injected on one side, they should come back to that side in 2 weeks. That's how much they should do. They are free to use the high. Pregnant women are comfortable using thighs. They can. The important thing is to just keep it perpendicular wherever the injection site is. Yeah. See, I have not seen much of it. Okay. So in the last slide, what they said is that if you open this needle, there is no link between the outer atmosphere and the gut. The link to that is through this needle. The last This is a closed space system, right? If the cartridges break, yes, that can happen. But mostly it will be through that needle. So that's what the last slide, I did not feel it was important because I have personally not seen much. But the last slide mentioned that you take off the needle, therefore it's an airtight space. You will not see any air. The only place air can get in is through if there is change in the pressure. Yeah, less than storage. Otherwise, normally when you're using okay, fine. Any other questions? I'll answer.
So we'll have a lot more time at the time of lunch, guys. In view of time, I think we should get back to our places. I can really see the zeal, enthusiasm. Not even a single person has bothered to check their mobile phones in the last 25 minutes. And I've been keenly observing this. That itself says for 25 minutes in a day, when people get a recess or any gap, the first thing people do is check their mobile phones. Hats off to you all and the enthusiasm. This would translate into better clinical and patient outcomes. Thank you. We do have a video of how to use a pen.
Prepare NovoPen 4 with a new pen fill cartridge 3 milliliters. First, pull off the pen cap and twist the pen apart. Check the name and color of the cartridge to make sure that it contains the type of insulin you need, and check that it has no cracks or damage. Insert the cartridge into the cartridge holder with the threaded end first. Push the pen back together and twist until you hear or feel a click. Hold the pen horizontally between your palms and roll it back and forth. Move the pen up and down. Repeat until the insulin is uniformly white and cloudy. Right before injection, always attach a new needle. If using Novo Fine, screw the needle straight and tightly onto the pen. To test the insulin flow, pull out the dose button and turn it to select 2 units. Press the dose button all the way in until the dose counter shows 0. And make sure insulin squirts from the tip of the needle. To select a dose, pull out the dose button and turn it to select the number of units you need to inject. Adjust the dose by dialing forward or backward if necessary. To inject the dose, lift a skin fold, insert the needle into your skin, and press the button until the dose counter shows 0. You may then hear or feel a click. Keep the needle in your skin after the dose counter has returned to 0 and count slowly to 6. Always remove and throw away the needle after every injection. Once the needle is covered, carefully push the outer needle cap completely on. Always hold the black cartridge holder when you unscrew the needle. Otherwise, you may twist your pen apart. If this happens, twist the pen together again. Dispose of the needle carefully.
So videos like this can be really useful, especially during COVID times when people didn't have access to their physicians, doctors, and they had to really start insulin on their own. Trust me, it was these videos which came pretty handy educating patients when we were doing telemedicine consultations. When those days, we're speaking about the second wave, when people didn't have access to proper healthcare. So use such videos in your clinics, display them. Patients get a lot of education passively as well. So we need to move on. In view of interest of time, I'm going to talk about barriers to insulin initiation, titration, and strategies for overcoming barriers. So this is a very soft topic, but I would try to make it interactive as much as possible. I know there's not a lot of medicine in it. So this is about a 54-year-old Kamala working in a bank, has a 6-year history of type 2 diabetes, complaining of burning pain and numbness of feet, diagnosed as hypothyroid 3 months back, on sitagliptin, metformin, and gliclazide, twice a day, levothyroxine, BMI 31, A1C 9.6, fasting plasma glucose high 220, postprandial high 310. Weight is 81 kilos. Examination revealed early retinopathy as well on top of neuropathy. Barriers to insulin initiation. We all know there are a lot of barriers when it comes to insulin initiation, be it patient barriers, healthcare provider barriers, barriers in the system as well, to be honest. So let us look at patient-related barriers here. What are the common scenarios that you come across, ma'am, in your clinical practice? What you perceive as patient barriers? What are the things that patient complain whenever you say start insulin? One.
The first one is the
Prick. Okay. So storage. Ma'am? So why? Yeah. Cost. Yeah. Anything, ma'am? Yeah, absolutely. People, have social stigma. Sir, yourself.
They think that once they start insulin, they can't come back.
Yeah, they think that, insulin is for the rest of their life and it's like a death sentence.
And neighbors are on orals.
Yeah, okay. So they think if their neighbors are controlled with orals, why not me? Yeah. Occupation. Because they think that, insulin might actually forbid them doing their work that they're supposed to do. Anything else?
Insulin damages the kidney. That's common fear there.
It's too big a question for you. Anyone else? Fear of hypoglycemia?
If I can swallow, why do I have to take an injection?
Sorry?
If I can swallow, why do I have to take an injection?
Exactly. Anything else? Some even think that insulin is not effective. And fear of hypoglycemia, as I mentioned. And not to forget the fact that it can interfere with their lifestyle. Okay, if they come to a wedding or something like that, how am I supposed to inject? Okay, wearing my sari. No, these are common practical scenarios.
And they'll be target for some wrong propaganda as well.
Exactly.
I mean, many people are naturotherapy, something like that.
It's a taboo, right? It's a taboo and stigma for some, right? So taking insulin means I have failed to manage tablets, diet and tablets. My diabetes has become much worse. These are the sort of perceptions patients have. Insulin injections are painful, right? It's difficult to inject the right amount of insulin correctly at the right time. They think that a nurse has to come to inject an insulin. Many still believe that. So there are many a time when I am questioned, so how can I find a nurse doctor is the next question. The minute I say, look, I'm going to start you on insulin. So then, of course, my answer is a 5-year-old kid can do it himself or herself. Why can't you? Right? We all have answers to all the challenges as well. Insulin injections are painful. Of course they are if you don't change your needle. And demonstrate, sometimes I do demonstrate in front of the patient, of course with a dummy, how painless the insulin injection is. My diabetes has become worse. Of course, it has become worse. So you need to do something about it. to avoid more painful things in life, be it neuropathy, be it coming to hospital daily for dialysis, or losing your eyesight completely. Right? Tell them what is realistic. Don't frighten them, but tell them what is realistic. Taking insulin means I have failed to manage my diabetes with diet and tablets. See, sometimes they might have tried their level best, did the right exercise, eaten the right foods, of course, taken the right medications, kept follow-ups as well. But we need to educate them that diabetes, we're speaking about type 2 diabetes here, is a progressive disease and that things do fail. Not for the fault of theirs, but because of the sheer natural history of the disease. So tell them clearly, categorically, in a lucid manner, in a way and means that they would understand. Taking insulin means life is so less flexible. I do give the example of Wasim Akram. See, countries apart, we all know how ferocious he was as a bowler, how our own Indian batsmen used to really fear him, okay, when he was in the best of forms. But he was an insulin-treated diabetic. If he could those days, without the benefit of insulin pump, could deliver what he could, why can't we? I just pause and give them a second to think about it. So give real life examples. Of course, we do have many others as well. Kamal Hassan, we do have film stars. What's the name of that star? You should answer this, come on. Well, you do have, another, yeah, there you go. Anyone else? There you go, X. Yeah, right. Taking insulins makes me more dependent on doctor. Not really. We are going to empower the patient to take their own insulin. The objective is not for them to come to our OPD daily and take insulins, or we going to their homes and give insulins. They need to inject their own insulins. Taking insulin increases risk of hypoglycemia. It can if you don't know what to do and what not to do. So we would actually educate the patient and we tell them, we say, I'm with you, right? Show that confidence in how you speak with the patient. If you're confident enough, automatically patient would fall in place, maybe after a bit of a longer counseling session. But if you're not confident, certainly the patient wouldn't actually listen to what you're saying. So we need to be empowered with the right knowledge, which we are all doing now. Alleviate the fear of hypoglycemia. Say that hypoglycemia is real. Hypoglycemia can be prevented to a large extent. Hypoglycemia can be treated if you are aware of what hypoglycemia is and if you understand how to treat it on your own. Insulin causes weight gain. Of course it does, but there are ways and means you can mitigate this weight gain. For example, you can work on your diet a bit more. You can do more exercise and say that that's a normal way the insulin acts. It's an anabolic hormone after all. You remember the first slide that we showed to you? What are all the anabolic actions of insulin? And this is through that mechanism. And of course, to a certain extent, possibly even water retention, that it might be causing you weight gain. So tell them that. If they lost all that body mass because of poorly controlled blood glucose levels, of course, they're going to gain some weight, but in a good way. Taking insulin means health will deteriorate. No, it's exactly the opposite. If there is one moment that they want to really capture, it is this moment when they need insulin and when they agree for insulin. This is going to be a game changer in terms of their own health, in terms of the overall benefit for themselves and their families as well. If at all that particular person is a breadwinner. So make sure that this message goes across. Be passionate about it when you speak about it. Overcome stigmas. Tell all the names of the celebrities that you have heard. Tell them, look, if all these people can come out saying that we use insulin, why not you? It's not like you have committed a sin. And say that if they're really that particular about not revealing it, they can still not reveal it and they can still inject their insulins quietly at home. Gone are the days when you had to carry all those needles, pens and all that, and everything comes in the form of a pen, easily carryable. Even if you go to a wedding, you can still inject it. Tell them how analog insulins are really convenient in terms of giving injection immediately after food as well. Say how least interfering these are in terms of the flexibility that they do have with meal timing. because they might have heard about insulins being given 30 minutes before food and all that. Physician-related barriers. This is very important. We can always preach what the patient is supposed to do, but there's a lot that we need to mend from our own end. Lack of hard and soft skills. If we really don't know what insulin dose we need to prescribe or how to titrate, which insulin regime we need to use, how are we going to tell our patients as to how they need to use insulin and how they need to titrate? So we need to be equipped with all the skills as to how patients can actually start insulin and titrate it up. And not to forget the most important aspect, soft skills. Be confident. Use the right body language. Don't be too aggressive, but at the same time, don't be too paternalistic as well. Lack of awareness of benefits of timely insulin initiation. Due to a lot of reasons, sometimes we sit back and we don't start insulin on time. Be it the big long list of patients waiting outside, and you know that if at all you need to start insulin, it might take 20 minutes, 30 minutes. So sometimes this is one of the key reasons, whether we accept or not, as to why patients are not started on insulin on time. So remember, it's the patient's life. It's the patient's vision, it's the patient's kidneys that you're trying to save. So be passionate about it. And lack of understanding of cost effectiveness. We all know that we do have analogs, but we also know that there are cheaper insulins as well, if at all it really comes to cost. So there are options, right from 150 rupees to 1,500 rupees. So there is a big spectrum over there. Regular training and teaching would help. Of course, this is one such. Insulin conversation. Try to show real life examples of patients that you have started. Of course, take their written and verbal consent. Have videos of them, real life cases. You don't have to show posh videos made by Novo Nordisk or Sanofi or Eli Lilly. You can just show real life videos of your own patients after taking their due consent. They feel very comfortable about that. If you have the opportunity of having a little patient club, then make them speak with their fellow patients and let them understand from each other as to how they could change their life for good with insulin when they needed it. Simple conversations really do help. You don't have to make it sound too sophisticated. Just tell them, look, diabetes is a progressive disease. It's not for your fault of that you are having to use insulin now. It's just the way the disease is. And sometimes showing them C-peptide levels, fasting C-peptide levels also helps in some patients who really don't believe. Okay, check the fasting C-peptide levels, show how low they are. And when they see real life values, sometimes, they tend to believe. You don't have to use this in every patient, but there are a lot of ways and means. Give example of a patient who could bring down HbA1c from 11% to 7.5 or 7% now with the aid of insulin. Remember, we all live in a world that is finite. We all live in a world that is full of barriers, and it is up to us to use ways and means to overcome such barriers and use compassion as well. But don't be over compassionate to the extent that they really get fatigued with your compassion. If you yourself can't deal with it, have a team who can do it. Could be your assistant in the clinic, could be a dietitian, could be a psychologist, if at all you have that benefit of having a psychologist, or for that matter, a colleague patient with whom the patient can speak. So all this helps. And you don't have to really force them to start insulin that day itself. Give them some time. Ask them to come back after 3 days, after you tell them how good the insulin is going to be for their diabetes care. Ask them to come back after a few days and tell them, look, think about this. Okay, we'll have a conversation after a few days. That will help the patient come to terms and come back to you. Also, remember, when things are failing, you get to know earlier than the patient. For instance, somebody's A1C is 10%. The patient is still in a phase of denial, doesn't want to start insulin. Give them, make a contract with the patient. I'm going to start the last medication that is available. After this, we don't have any medications. So give it as a warning shot. But after this, you're going to come back to me after a month. If things are still not well controlled, okay, then we don't have a choice but to start insulin. Okay, it's a warning shot. So if you don't have support staff, which most of us are privileged to have. If you don't work in very big centers, if you're working in your own center, you can still have ways and means to address a lack of support staff. For instance, the various audiovisual aids that we do have, the video, for example, which has been demonstrated earlier, how to start insulin. You can make your own videos. If a patient is tech savvy, signpost them to the right portals, which they can watch at the convenience of their home and come back. If a person is not tech savvy, if they are literate, at least you can give some leaflets to read. If they're illiterate, you can always make sure that the family is on board and make sure that the family do understand what you're trying to convey. On that note, I thank you, because we do have a lot of other very practical aspects that we need to deal with. And we're running 5 minutes ahead of time. No, we're running 5 minutes ahead of time. So we do have actually 15 minutes ahead of time. No, just give me 2 seconds. So I know that we skipped your questions in the last 2 sessions because of lack of time. So I think there might be a lot of questions for you, be it about the insulin technique or about insulin start or insulin intensification, so on and so forth. So now the time is all yours. You can ask as many questions as possible, because we've got good 15 minutes for us to go through these questions, because I haven't given you any time earlier.
Sir, as you said just now, we need to give a sort of warning, something like that. By the time next time you come, we have no other choice to start insulin. So at those instances, what patients will be doing is better to shift to other
Switch
doctor.
doctor.
Switch doctor.
Right.
So how to overcome this problem? And other thing is the place, I mean, where I come, patients are bit reluctant to take insulins, as well as they are also phobic, where they are getting habituated for making this, and moreover that they will be having a sort of wrong propaganda. I mean, so how to overcome this problem from physician's point of view? I wanted to ask.
It all depends on the patient's perspective, right? So every patient is different. Some patients really are ignorant about insulin, or for that matter, even diabetes. Okay. They might be having diabetes for 5 years, but they might not be as much aware as you want them to be aware of diabetes, the various complications, and the natural history of disease. So depending on the patient's interest and depending on their knowledge levels, you need to start, right? If somebody is well aware of the various complications, it makes your life easy. So you can say, look, if you really want to avoid all these complications, you are already using 3 or 4 oral medications. There is nothing after this. Show them some evidence. Okay. Say, look, from HbA1c of 10, if you really want to bring down to HbA1c of 7, there isn't any other medication in this entire world that can bring down your A1c except insulin. Be realistic about it. Okay. Even if you go to America, you go to UK, you go to Australia, this is a standard treatment. Okay. See, doctor shopping is real. Whether you like it or not, that's real. Okay. That's real. Let's accept this fact. But irrespective of what the patient wants to do, onus is on us to try to educate the patient as much as possible and accept the reality as it is. There is even a propaganda that is going around, especially, I don't want to name here. There are people who are out there who send WhatsApp messages and talk on television in real time as to how the medical mafia, as they call it, okay, they dare call it, okay, say that is actually promoting insulin, blah, 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 okay. So there are a lot of odds, not just in terms of lack of awareness, but also a lot of negative propaganda out there. It's easy for a patient to believe all this. There are even WhatsApp messages that are going around saying HbA1c 8 and 9 are fine. And apparently it is only these associations which are trying to bring down A1c to targets to less than 7. Look, you can't change the world, but at least you can try to educate your patient. So can I. Okay, tell them realistically as to what their chance of decreasing their risk of developing micro and macrovascular complications, i.e. losing their eyesight, losing their kidneys, having burning sensation and sleeping every night, or not being able to sleep every night. Not to forget, with men, erectile dysfunction risk. They may not listen to anything else, but you tell about erectile dysfunction. Trust you me, I practice the same as well with my patients. Okay, and I see quite a bit of sexual dysfunction in my OPD. Okay, I tell this, they listen because that's real, and nobody wants to lose the invaluable usage of their toys, right? So use the right technique depending on which person you're dealing with. Okay, nobody wants to lose their eyesight. Nobody wants to not sleep daily with burning sensation in the feet. So you need to use your soft skills. Hard skills are what you're trying to learn here. Soft skills are what you learn over a period of time and you practice in your day-to-day life. So use every technique in your armor. And you don't get it right all the time. Neither do I. If anybody does, they're just lying. Trust me.
Can I just add to that? Yeah. So this warning sign I also use very regularly, but I try to play with the psychology of the patient a little bit. So the way I approach is, okay, HbA1c 10, multiple OADs failure. Madam, you need to be starting on insulin. I'm going to start insulin. Patient will say, insulin, oh no, please don't start. Then this argument will go on, okay, insulin, no insulin. Then I say, fine, I'll give you 1 month. So it's same what Dr. Ravi Shankar does, but what I say is like, I give the patient an impression that I'm actually listening to his or her words. So in that case, the patient will come back to you. If the fear is of losing the patient, if you do in the end that, okay, fine, I'm going to listen to your words. I'm going to give you a 1 month chance. Take these oral agents, go and come back after 1 month based on what you are saying, not what I'm saying, based on what you are saying. So then the patient will have a little trust on you saying that, okay, fine, this doctor is actually listening to what I'm saying. So even if he puts me on insulin, there is a chance that he might listen to you. One other thing to fool the patient for his own benefit is to tell the patient, a lot of the patients will ask, sir, this is going to be for life. I'll say, like, let's just use it for a few months and see. It is a false statement by us, but it will give the patient some hope. After that, so after some time, a few months, they'll fall into the trap and you can continue the insulin. So it is just to play around with the psychology of the patient.
Yeah, you need to play according to the psychology of the patient, and it's an art. Okay, remember, medicine is not just science, it's an art. More so in these tricky testing times where we are fighting against the malicious campaign that comes in the form of various forces, right? And one thing I slightly disagree, we all have a different style of doing things, okay? Nothing is right or wrong, but whatever works for you and for your patients, I try not to fool the patient in terms of telling that it's a temporary thing. I say one thing, look, let's see how it goes. I leave it as an open thing. Most patients need lifelong, especially if they have such low fasting C-peptide levels, or if they're unable to control with their oral medications, diet, and exercise alone. That actually sends a strong message to the patient saying you'll need to work on your diet and exercise. If they haven't actually, that might be motivating them for good, which helps for the patient at the end of the day. So use that technique, but I leave it as an open thing. Most patients do really need it for the rest of their life, but let's see how it goes. That's my way of doing it. If you want to do that, try that. There's no right or wrong, okay? It's not written on stone that you need to follow what Ravi Shankar does or what Dr. Mithun does or Dr. Kalyan does. We all have a different style of doing things. And you can develop your own style, Mr. XYZ style.
So I think as Dr. Ravi Shankar is also a politician, as you can see. So he uses politics with his words when he does that. The other thing I do is when the patient comes and says, sir, abhi actually Christmas tha na, New Year tha, घर की शादी थी, इसीलिए गड़बड़ हो गया सर. 1 महीना 2 सब ठीक हो जाएगा. So what I do is that, okay, I agree with you. हो सकता है, everything is possible. I'll put up a CGMS. आपको 14 दिन दिया, जो करना करो, 14 दिन के बाद आ जाओ. Nothing changes, and then he goes on insulin, or very often with that. So I use that as well, and I click a photograph of the retina, and then we have that, very nice discussion when they see that flashy picture of the retina.
Sir, I do a little bit differently. I have a couple of slides regarding the progression of type 2 diabetes. I think we've seen one of them at the beginning of the session. I try to explain to them, I mean, most people who actually can understand that this is a progressive disease, and at the time of their diagnosis, they already lost insulin secreting cells, 50%, and now they are 10, 15 years down the line, probably they have nothing left in their body. So medications wise, if they need to work, they need to have those cells present. And because if they're not there, no amount of medications will help them. And I also try to use this opportunity to reinforce the diet and give them sometimes slowly. I will, okay, I think now you lost weight. Despite losing weight, your sugar is getting worse. This would be an indication to consider insulin seriously. By this time, they will have tried so many things and waited for so many days. They usually listen to me at this stage. That's what I do slightly differently.
Yeah, I hope that answered your question at length. So nothing works for all patients. Okay, there is no magic formula. Had there been a magic formula, we wouldn't be doing all this, would we? We wouldn't be having this discussion in the first instance about how to break all these barriers and have this presentation, right? So barriers are real, so are solutions. Some solutions might be instantaneous, some might take a little longer, some might never work. But you need to try your level best to overcome that barrier, be it your own or that of the patient.
Sir,
somebody wanted to ask another question.
Yeah.
It's all your time. You ask questions, we will try to answer.
Yeah,
try to is the keyword.
We all agree basal bolus is the best regime. But in the practical Indian scenario, mixed will be much better, what we all seeing in the regular day-to-day practice. So what is the additional benefit which we are going to get if we can achieve the same HbA1c which we can get in premix?
Yeah, that's an excellent question. Very practical. You didn't work for Novo Nordisk in the past, did you? Yes, I'm just joking. Right. In general, okay, anything that works, anything that achieves the target A1C, anything that achieves the target A1C without hypoglycemia, anything that works in terms of reducing A1C with minimal hypoglycemia and also being cost effective and also flexible and also cheap, okay? And also making sure that the patient would persevere for the rest of their life works. As simple as that. Whether you want to use basal bolus, whether you want to use basal insulin, premix insulin. So as you rightly said, every insulin regime has its own innate advantages and disadvantages. So basal insulin is just once a day. Premix insulin can also be used as once a day, but it won't achieve what basal insulin can achieve as once a day because you're still leaving away a significant chunk of the day without any insulin. May not. Okay, it depends on which premix again you use. Okay, because some might say Rhizodec, yeah, anyway, it contains good 24 hours to 36 hours of action insulin in it. So why not give it once a day? So I'm just giving an example instead of basal plus, right?
Because Indian, they are not comfortable taking so many injections.
I know, neither am I. If I were to be diabetic, if there is an inhaler or an oral pill, I would prefer that. That's human nature.
Any additional benefit we get by giving basal bolus? If we are achieving the same A1C.
Yeah.
Apart from the pregnancy.
Go back to the basics where we started, what Dr. Murali tried to show. Okay. How many times do you eat your meal? Breakfast?
3 times.
You have it. Lunch? Dinner. We also need some basal insulin to actually keep the fasting glucose at bay. So if you really want to achieve this, we need something which is very physiological, as close to pancreas as possible. Insulin pump is the best thing. But insulin pump is a talk for another day. It is a lot more sophisticated, lot more expensive. So what do you have? Next remotely close one is basal bolus, right? But we understand that basal bolus involves 2 different insulins. We understand that it involves 4 injections. We understand that people may not be keen for this. Okay, but having said that, that's as close to physiology as possible. So whoever needs it, whoever wants it, whoever accepts it, let them use.
Yeah.
Whoever doesn't want to use it, you give other options. See, you want to eat food, guy. Okay, there are many restaurants. You don't have to come to Taj Vivanta. Okay, There is a nice shanbag over there. You got a roadside stall as well. Okay, everything comes with advantages. You get nice hygienic, or at least you're supposed to get. Okay, and some classy food here, but you may get a good tasty food for less price outside. So there are a lot of options, is what I'm trying to say. If anybody says basal bolus should be used for everyone, they're lying. If anybody says premix should be used for everyone, they're lying. That's the whole point of all the discussion that we had so far.
If I could add what you could do with that patient, put a CGMS device. See what it is. If everything is fine, hanky-panky, leave it.
I wish.
If you find that there is hypoglycemia and you think there is variation, you change it. There is no simple rule. And if everything is fine, he's not getting hypoglycemia. If Ravi or the patient profile is less and poor, ask him to monitor 4 times a day by glucometer. If everything is doing fine, then everything is fine. Okay. If it's not fine, then you will change it yourself, and the patient will be happy. You can see it. I think Kalyan was trying.
Just on a lighter vein, CGMS didn't sponsor this talk. Neither is travel. Nor can CGMS treat sexual dysfunction.
Yeah. One more question. Sorry. Most of the times, the patient comes to our clinics. They are being discharged from the hospital with short-acting insulins, because in the hospital they were admitted. They were given short-acting insulins 4 times a day, and they end up in hypoglycemia because once they come home, they may not be given proper diet at home and the proper medication. And
Got it.
How you titrate that into a premix insulin?
That's a very valid point. In India, we see a lot of bolus insulins thrice a day. Okay, even in inpatient, outpatient setup. No offense, I can take names here. Actrabit, because no, not this guys are here. Okay, Actrabit 10 units 3 times a day, 20 units 3 times a day. How should we address this? Is it right or
at
wrong?
Home, how you titrate that into a premix or the dosage adjustment?
Is it right to use such a regime in the first instance?
No, because a lot of these patients who are admitted to the hospital require a certain amount of higher dose of insulin because of either cellulitis, MI, whatever the hospitalization, and just bed rest. They are not moving there. So the requirement in the hospital is much higher than when they go home. Then when they come home, their adrenaline is less, their cortisol levels are less, their diet regime is better, they move around. So a lot of the factors will actually influence in reducing your insulin requirement. I myself take particular care on the last day of the patient, whoever I am following. On the last day of the patient, I ensure that I write what I am, what the insulin regime for the patient should be after discharge. So I might be using short-acting and long-acting insulin during the admission, but I cut down the at least by 50, maybe sometimes if the patient is requiring maybe 75%, also 50 to 75%, I cut down, I add in oral therapies which have not been used during so the ideal thing to do is to switch them to a simple regime like a vildagliptin, metformin combination, plus adding a little bit of insulin either through premix or a basal insulin.
My question was, sir, if the patient is well controlled with a short-acting insulin of 10, something like 30 units of short-acting insulins, when you are sending that patient home, so how you convert that 30 units of insulin into a premix insulin, how you titrate
the
that?
Easiest way is see what the sugars
That's
are.
what everyone will ask. I mean, that's
See what the sugars are. Okay?
The sugars are well controlled with 10,
then
short-acting, then changing it to a mixed insulins.
Yeah. First reassess the patient. Okay. Why did the patient need insulin in the first instance? Is it still necessary? That's the first question you need
necessary.
to ask. Okay. So if at all there is a clinical need for you to continue insulin, the best way to do it is, if things are looking good, okay, change it to premix insulin 3 times a day. That's one way of doing it. I'm not saying the right way or the only way. Again, it boils down to what the patient's choice is. Okay. If you really want to go to only twice a day, for instance, if a patient is needing 30 units 3 times a day, and if patient says, I want only twice premix, okay, 30 units in a day, you need to make sure that you split into morning 15 and evening 15, or there is a different way as well, depending on when the main meal is. Okay, you may want to give more in the morning 20 and 10 in the evening. It all depends on the meal and circumstances. The third way to do it is, if a patient says, look, doctor, you really control my sugars well, okay, which usually is not the case when you give 3 times short acting, trust you me. Okay, So we won't be having this discussion if that were to be the case. You may want to use even basal bolus insulin regime if that's what the patient wants and if that's what you think is right for patient in the particular scenario. So take all this into context. Or if the patient says, doctor, I want only once a day insulin regime, put on once a day, but add on oral medications because the patient hasn't been on oral medications in the hospital stay because it was a hospital stay. And those factors which prevented usage of oral medications are now off. So you can still use oral medications plus basal insulin. So take all this into consideration. I hope that answers.
If I could add just one thing, I don't know about Hyderabad. See,
well,
food in most hospitals are crappy also. Okay, that is different to the home food. So things are going to be a little different with the food as well. Some people may require more when they go by because they've started eating in as well. Your question about specifically 10, 10, 10, what do I do? You see, you react to your wife and to your girlfriend differently. Your sweetness score changes.
This is off record. Yeah. ACE doesn't endorse that statement.
No, let me finish that. So what you can do is generally whatever requirement is there, I reduce that by 10 to 20% and then divide that into say, 10 and 6 or, divide 2/3, 1/3 in a mixture. And then monitor the sugar if you really have to. But as Ravi has said, if the road isn't broken, I don't try to repair it. Is there a need to repair it is the question. You want to know that, and that is more important. In the hospital, they don't eat well. In the house, they eat better. So things may change the other way as well. So it's not the one-way road that is going to happen. So the more important thing is to monitor and then to change. Tell them to monitor, tell them about hypoglycemia.
Last firing shot. Usually sugars are not very well controlled with such an insulin regime. So stay away from such an insulin regime, be it in the in-hospital setting or outpatient setting, unless you're using tiny doses of short-acting insulin. In some instances, you just need to give 3 units 3 times a day or something like 4 units 3 times a day. That's acceptable. But usually a patient needing 10 units 3 times a day ought not to be on that regime because that would not control the basal insulin regimes well. And in fact, might be causing hypoglycemia postprandially. So usually 10 units 3 times a day, my friend, is not a great insulin regime to be used either in the hospital setting or out of hospital setting. Usually such a patient would need basal bolus or at least a premix insulin regime in the hospital setting or outpatient setting. Right? That ends the debate. Next question.
Sir, this is...
Last question before we go for lunch. I'm hungry.
So this is to the esteemed panel, sir, because since morning you've been telling about the CGMS. I struggle, sir, to convince my patients. I mean, my patients are pretty happy to take insulins, all that, they are fine. But I struggle to ask them to get a CGMS monitor fitted. In fact, they go as much as asking the rep, and it's the cost. I practice in an area where it's a mixed population, so they're the very rich to the very poor. So I sort of ask the patients who can afford it. I don't know, something maybe I'm doing it wrong, that I'm not able to, at least for those patients who have got, what we call the brittle diabetes, they do need a CGMS, but they keep on postponing it. They keep checking it.
Yeah, got it. So glucometers and CGMS are like phones, mobile phones. Okay, you can have a phone for $3,000. Okay, you can have a mobile phone for 80,000 or even lakhs. Okay, so and not always do you need a phone which is 80,000 bucks. You can just get away with a 3,000 rupees phone. So it is foolish, stupid, and not fair to ask a patient who is just on metformin or sulfonylureas and really, or for that matter, even basal insulin, and you can just use a glucometer when things are looking good. I'm not speaking about, we shouldn't, full stop. No, I'm coming there. We shouldn't. But there is that particular patient who really looks nice outwardly. A1C looks 7%, but has hypoglycemic episodes in the middle of the night, really big excursions, because there is more data out there. I'm not going into the depth of it because today's talks can't deal with it. It's for the advanced. We're going to do an advanced one as well with the same sort of combination of doctors, hopefully. Okay, so this is a basic essentials, and that will be an advanced one in which we are more than happy to deal all that. So there is all this time in range, time above range, time below range. All these would come into play, right? So it all depends on what radiation you're getting from the mobile phone, okay? It all depends on how visible it is, how sophisticated it looks, okay? And the chance of you using other apps. I'm just trying to draw that analogy. So the advantage of using CGMS is you get all that data. When exactly the patient is having hypos, when exactly. And definitely there are those patients, many in fact, who need CGMS. But then comes the question of paisa. I know Northeast guys seem to be very rich. Okay, I'm not speaking about them. We're not speaking about even Dr. Gurjara's patient. I'm speaking about my humble patients who come and see me in Apollo Hospital, Jubilee Hills. I'm just like you. Okay, we don't have everyone accepting. The Jubilee Hills patients don't necessarily accept such pricey stuff. Only some of them do, even though there is a clinical need. What I'm trying to say is, yes, cost is a barrier. On that note, let's have some food and we'll catch up later. Thank you.
One last question, please.
We'll catch up later. Over lunch. I'm not going to disappear. Right? Guys and ladies who are in the Zoom may also please break for lunch. We'll see you sharp at 13:30 hours. And we're going to speak about hypoglycemia. I bet you wouldn't be by then. And we'll meet on time as ever.
I know he's completely oxygen.
Good afternoon, ladies and gentlemen. I'm glad to see that people are following COVID appropriate norms. I'm also pleased to see Dr. K.D. Modi, sir, here, who is a very senior endocrinologist in Hyderabad. He also happens to be ex-treasurer of Endocrine Society of India and also the lead for Hyderabad Endocrine Society. We already did his introduction slide, but I thought I need to introduce Dr. Modi, sir, because he's here now. So without any further ado, we're going to kickstart our afternoon sessions. We do have hypoglycemia, the prevention and management, which will be dealt by none other than Dr. Murali Krishna. Murali, over to you.
Good afternoon. So now we're going to talk about hypoglycemia and management. So why are we talking about hypoglycemia and the management during the insulin workup class? Simply because that is one of the big hurdles that we need to address even before we start insulin. Because one of those things that you need to tick the boxes, there is something called insulin starting checklist that we would usually follow. When I was student, most of the times insulins were started by diabetes specialist nurses, so hardly we would do those kind of stuff. But then once we started seeing more patients with a lot of hypoglycemias and we don't know what kind of education that they already received, when you start to revisit what they're doing, it's very, very important what needs to be done in the first place. I don't think we have the the extra staff here in many clinics or even in the hospitals for one of your juniors to do those kind of stuff for majority of the doctors, unless you're working in a big corporate or somebody with a lot of junior doctors working under you. So let's get back to the case scenario. A 66-year-old gentleman is rushed to the emergency department by the family members.
Slide is not showing.
Okay. The slides are not being played. Okay. So we have the 66-year-old gentleman is rushed to the emergency department by the family members. Patient is conscious but confused and he's sweating profusely. And his heart rate is 105 beats per minute and BP 146/92. And history of diabetes for 14 years on human premix insulin BD along with metformin and glimepiride. And his RBS was noted to be 50 milligrams. What do you do next? So, first of all, there are various things that went wrong here. Number one, the family did not know what to do in this situation. So they should have done something at home even before he was taken to the emergency department. So they didn't do that. So the fact that they have taken the patient in that stage means leaving him in hypoglycemia for a very prolonged time is not good. It may cause a lot of issues, including fits, seizures, and problems related to seizures. Even some, it's not uncommon to see patients presenting in stroke with hypoglycemia. So it's not good. And also the fact that it took so long, and again, imagine the patient having to go through all this, getting somebody in emergency to a hospital. So it causes a lot of stress. So this will have impact in the long run as well in terms of how aggressive you're going to treat the patient. Even the patient family will be very, very worried about being on insulin and whatnot. So there are a lot of things that went wrong here. So things should have been addressed at home, at least started at home. So hypoglycemia and management. So how do we define the hypoglycemia? I mean, I'm not going to go in details why 70 was so chosen, all that. So we will focus on practical aspects only. So according to practical aspects, so anything less than 70 is defined as hypoglycemia. But also having symptoms is very important. And again, sometimes you have hypoglycemia mimics, so it's very important that you prove it is hypoglycemia sometimes. But that's usually the case when somebody is presenting with hypoglycemia without diabetes. But when somebody is already known diabetes on medicines that cause low glycemia, I think the number should be fine and the symptoms should be fine. So if anything less than 54 is classified as severe, but any hypoglycemia that requires third-party assistance is classified as hypoglycemia. So it's not very uncommon. So you see a lot of hypoglycemias happening in patients who are on insulin, particularly more so in type 1 diabetes when you're trying to achieve very tight control. So the most important thing here is education and empowerment. So even when you start anybody on insulin, you must inform them this risk and also inform them what they need to do when this happens. And then there are various tools that you can use to prevent this happening in the first place, like self-monitoring blood glucose levels and adjusting insulin based on those readings. CGMS could be very useful, but flash trial or live. And pump could be also used in type 1 diabetes patients if they're having life-threatening severe hypoglycemias on regular basis, despite enough support and carbohydrate counting. And we need to offer them professional support. So at least some kind of contact number for them to contact you or your team when that happens and when they don't know what to do. And also we could use flexible insulin regime and use the Daphne principles. How many of you know Daphne? Please raise your hands. Okay, so Daphne is a program that is done in England. It's called dose adjustment for normal eating. So you let the patient eat whatever they want and they should be able to adjust their insulin. It gives a lot of flexibility for them to adjust their insulin. It is usually a 5-day program for the patients to have. A lot of dietitians and endocrinologists will educate them. I don't think we could do that. I think we are hoping to come up with that kind of program in the future under the umbrella of ACE at some point. So that so in technical terms, you can simply say it's a carbohydrate counting. Okay. So it's not moving. Okay. So this one.
Yes, sir.
Okay. So this is a girl who came to me on insulin pump with the DKA and also multiple episodes of hospital admission for hypoglycemias. She was using insulin pump, she was using CGMS, despite which she was having horrible hypoglycemias. You could see her abdomen, cellulitic, multiple places where the pump was stuck, so badly managed pump. And you could see the insulin absorption won't be very linear in this patient. So it will not help in terms of hypoglycemia. So so it's very, very important that you actually examine the places where they're injecting, whether they're injecting in the muscles. Important to look at the needle sizes and where they're injecting and right technique. And also analogs are usually safer, particularly in type 1 diabetes patients. But no insulin is safer unless you actually monitor and adjust the dose. So no insulin is safer. So that is probably the most important thing, the monitoring. And the dawn effect, so it's very important that you are aware, particularly when you're titrating the basal insulin and you try to keep on increasing the basal insulin to the fasting glucose. Some patients do have dawn effect, and if you don't pick the dawn effect and you keep on increasing the insulin in the middle of the night, they may have a hypoglycemia. So it is very, very important when somebody is on basal insulin, ask them to check once in a while, 3 or 4 o'clock insulin, or use CGMS like my colleagues do, right and left. So CGMS could be very, very useful in those patients. So again, insulin administration, as I mentioned earlier, while showing various instruments of insulin administration. So in India, we have this U40 strength and U100 strength. We also have U200 and U300 as well. I think Lilly does rapid acting U200, and Glargine U300 is also there in India. So we need to be aware of this, because sometimes what they do is they take the syringes and take the insulin from the cartridges. So injection site is very important. So you could see here on the left side of the screen, you could see U40 Actrapid. And on the right side, you could see Actrapid U100. You can see the bottle as well as the cartridge. So if they use U40 syringe to use the right side syringes or the cartridges, what would happen? You would give 2.5 times the insulin that you wanted to give in the first place. So that's not going to help in terms of hypoglycemia. So you could see the U40 syringe on the top and U100 syringe at the bottom. So it's very, very important that they are using the right syringes. For example, what I have done in my clinic is that I got rid of U40 syringes altogether. Very, very few patients require it, and I ask them to buy it outside, not in my clinic, and stick to the same syringes. So the problem with U100 syringes is that you cannot give odd number insulin. So you have to increase based on 2 units, 4, 6, 8, 10 like that. So it may be fine for type 2s, but may not be that fine for type 1 diabetes patients. So if you always err on the side of the safety rather than trying to be very aggressive when it comes to hypoglycemia. So you could see that again, this is a flex pen of FIASP, and this is a U100 strength. And sometimes what they do is they take the U40 syringes and they take the insulin from these cartridges and give it to the patient. I've seen it happen. So always tell your staff, particularly in the hospital, to use the right device for the right insulin. If they don't have the device, they should either contact the doctor who could give an alternative insulin, but not to do mistakes of using wrong syringes with the wrong insulin. So management, you always ask them to carry some kind of a hypoglycemia treatment kit that is having chocolate or glucose jelly. Ideally, I think Aries company give glucose tablets, and they could carry that and use a couple of them. That should be enough. So what usually you do is you give 15 grams of glucose, and they're having symptoms. Sometimes they keep on eating a lot because during that symptoms they cannot take it and they kept on eating. And that's not I would recommend them to, simply because you don't want severe hyperglycemia following a hypoglycemia as well. So give 15 grams of glucose, wait for 15 minutes and see what happens. And if the patient is unconscious, do not force things orally because they may aspirate and cause aspirate pneumonia. And IM glucagon 1 milligram injections could be used, particularly if the patient is unconscious. I think you might want to supply that. I think the supply is an issue. I think Novo Nordisk has been kind enough to give me a couple of those syringes. I used it for problematic type 1 severe hypos. And repeat this oral glucose twice, and if no response and still having severe hypoglycemia, I think this is the time you may consider giving intravenous dextrose. And what I usually do is once you treat with an acute episode, I think you need to revisit why the hypo happened in the first place and what steps need to be taken to prevent this happening in the first place. And also it's very, very important to be aware of exercise effect on insulin requirement as well as so usually short bursts can cause severe I wouldn't say severe, a sharp spike of hyperglycemia and then followed by a late hypoglycemia. So particularly what I would recommend patients do is if they're doing any exercise, I would say to take 1 or 2 insulins less if they have planning beforehand. If they have a unplanned exercise or going for a shopping or something, I ask them to carry glucose, and as soon as they realize that their glucose is going down, they need to have a snack. So why hypoglycemia matters? Because it's horrible. Any one of you to undergo hypoglycemic episode will tell you how horrible it is, and it has the patient may lose confidence in you or even in the treatment and may never go back to insulin, which is not going to be very helpful for the patient. So for many patients and families, it's the feared aspect of diabetes treatment and compromised diabetes control, mainly because they may not like to take it. And sometimes there is a lack of understanding. I think it's very important to sometimes to analyze what led to that hypoglycemia, what their lifestyle is, what their job is. Sometimes they have jobs very sensitive for the hypoglycemia, for example, pilots and things like that. So, and also it's important to know where they work. For example, building, some people working in very higher up places. So preventing hypos is extremely important. Otherwise, they may actually kill themselves. So it's important we analyze those kind of social aspects. So it's a major barrier in improving glucose control. Hypoglycemia incidence is more in type 1s than type 2, but it can also happen in type 2s, and because they start behaving like type 1s after some point. So another thing with type 2s is you could also have hypos secondary to the medications. Some of these could be very, very, lasting. For example, glibenclamide. Not so uncommon to see people to be on glibenclamide and having a very prolonged hypoglycemia, even glimepiride for that matter. So levels of hypoglycemia, as we spoke earlier, so 70, 54, anything requiring third-party assistance could be really bad. So I'm not going into pathophysiology of hypoglycemia. I'm sure you all could read in the textbooks and learn from it. I'll focus on the practical aspects. So negative implications of hypoglycemia. So fractures, joint dislocations, though they can have a fall, head injuries can happen. Quality of life could be very high, and because they are so worried about hypoglycemia, they may not actually take insulin, or they underdose it. So during the hypoglycemia, there can be a lot of issues like arrhythmias, myocardial ischemia, infarction, cardiac failure could get worse during the hypoglycemia. And also cognitive impairment, convulsions, coma, paralysis, transient ischemic attacks, and focal lesions can also. It's not uncommon to have a watershed infarction in the brain if they have a very prolonged hypoglycemia. I have seen it happen multiple times. So cost of hypoglycemia, it could be very expensive, both for the healthcare and as well as the patients. And, you have to invest a lot of things to prevent this happening. So it's not very good in terms of money. Tools of capturing hypoglycemia. So this is probably one of the most important slides that you want to. So the tools, how most important thing is history, and also from observers, relatives, daily records, self-monitoring blood glucose records. I don't use validated scoring systems because in research settings they may be useful, but in practical aspects in a busy clinic, it's not going to be very practical. So blood glucose monitoring data, CGMS, is extremely useful in preventing hypoglycemia. Often when you see a patient with HbA1c of 6.1 and 5.9, you need to remember this patient might be having a lot of hypos. You need to reduce the insulin or the medication for those patients, because the patients will be thinking we have fantastic control. Well, they might be having fantastic control. They may develop hypoglycemic unawareness and end up in coma, hypoglycemic coma. So we don't want that happening. So we need to be proactive looking at the HbA1c. So if they're on HbA1c 5.8 or 5.9 on glimepiride, metformin or gliptin or GLP-1 analog, it's fine. They may not be having hypos, but if they are having HbA1c of 5.7, 5.9 while on insulins or sulfonylureas, you must inquire about hypoglycemias. And also important to do a CGMS for those patients to capture whether they're having any hypoglycemias in the night that they were not aware. So that's very important. So you could see in screening for risk of severe hypoglycemia. So low HbA1c, duration being long, history of previous hypos, impaired awareness of glucose, that's very, very dangerous. Recent episodes of severe hypoglycemia. Anybody with insulin dose more than 0.85 units per kilo per day. I'm not too sure about that number, but yes, if somebody who's on massive dose of insulin, you need to be careful. And again, physically being active. So capturing hypoglycemia, SMBG, real time, and also blinded CGM. So prevention is very important. Education, diet and exercise, individualizing. This is probably the most important thing I would recommend any of you do, because I've seen a lot of patients doing FBS and PPBS and keep on changing their drugs. It's not something I would recommend you do. I think you please follow HbA1c done on a right machine like HPLC method, or if you're doing an immunoturbidometry method, try to do something like Roche or Beckman Coulter. Don't accept any HbA1c done on some mediocre machines. So if you're doing immunoturbidometry, ask them to get it done from a good machine, and otherwise just stick to HPLC method. So improved pharmacological treatment, again, glucose and medication monitoring, technological strategies. So you could device based on the patient's affordability, all those things. So education of patients and caregivers and how to recognize and treat hypoglycemia. This is the most important thing that I would recommend you do before you start anybody on insulin, and make sure you document in the notes that you have done so. Because if somebody has a severe hypoglycemia and have some kind of problem, and if they sue you, there is no defense for you to defend yourself, because it's very, very important in terms of medical legal aspects as well. So strategies to prevent hypoglycemia, as I again said, diet and exercise. So most important thing is to take the insulin at the right time. So no point in taking, for example, somebody took fast, which works really fast, and wait for half an hour to have their meal, they're going to have a hypo. So it's important for them to understand how fast their insulin works and take the insulin accordingly. So that's one thing. Carbohydrate counting could be very, very useful in type 1 diabetes patients. Even in type 2 diabetes patients, what I would say is if they take same insulin for 2 idlis and 4 idlis and 1 idli, will it work? The answer is usually they themselves volunteer the answer. The answer is no. So how will you expect the diabetes to be under control and have not hypoglycemia? So stick to 2 idlis. If you're eating 2 idlis every day, just stick to 2 idlis or equivalent amount of carbohydrate of other food. So sometimes speaking about that would be useful, even same with the GDM patients. So eat pre-exercise snacks if blood glucose levels are low. So if somebody is going for a prolonged exercise, ask them to check their glucose readings. If it is around a lowish value like 80, 90 or 100, it's important for them to carry some kind of snack to go for before exercise. So avoid alcohol. I mean, alcohol is another problem. So they can have a very prolonged hypoglycemia, particularly later in the day. They may not have hypo while they're drinking, but after a few hours, they will have a very hypo. The worst bit is they are under the influence of alcohol and they cannot look after themselves. So that can put them at a very bad state. So always adjust the insulin based on the data and ensure the correct dose, ensure the correct technique, and if any add-on to basal insulin is needed, consider to alternative to prandial insulin. If on basal bolus insulin, check glucose before each meal every day. This is very, very important. So you check the reading before the meal. What is the point of taking a reading after 1.5 hours of regular insulin? So the best thing would be to check the reading before the next meal. So that would give an idea how much high you could go. So usually I titrate based on 1 or 2 units up or down. So multiple technological, there's available pumps and CGMS and lots of things. So again, management we've already discussed. General recommendations on hypoglycemia management. Be educated. Important to follow glucose level for at least 24 to 48 hours in patients where hypoglycemia is induced by long-acting sulfonylurea or long-acting insulin, because they may have hypo again. When hypoglycemia becomes a problem, you consider risk factors. Avoid sulfonylureas if possible. If possible, that is important there. So it's not like you must stop it. Hypoglycemia needs to be treated promptly. While it is useful to document the degree of hypoglycemia and should not delay treatment, and general advice is if in doubt, treat it. So if you don't have equipment to find if it is truly hypoglycemia, or they're just in delirium, or they're having a stroke, or they have some kind of expressive dysphagia, just treat as hypo. What are you going to lose? So just treat it if you are in doubt. Thank you. Any questions? I'm very happy to answer. Yeah.
Thank you very much, Murali. You kept all those who had an extra idli today worrying. Never mind. So, first question. Somebody has a HbA1c of 13 and blood sugars are still 140, but they complain of hypoglycemia. Do you want to tell the audience about that, relative hypoglycemia?
So the hypoglycemia could be relative. Somebody who's running around 300 for the past few months, and now suddenly you started treating them. So some people can develop hypoglycemia when they're 130, 140, even 150. They could be having symptoms. So you don't need to treat them, but you just simply advise them that this may happen for a short period of time and they will get over it. And because if you start increasing the glucose because they're having symptoms, they're never going to tolerate the lower levels. So that's what I usually, reassuring them is very, very important. Another thing you mentioned about HbA1c of 13, and what I observed is particularly in type 1 diabetes patients, having recurrent hypoglycemias is one of the reasons why somebody have very bad diabetes control. So because every hypoglycemia is followed by a prolonged hyperglycemia. I'm sure if you do a CGMS a lot, you will understand what I exactly mean. So I think in those patients, just preventing hypoglycemia itself will fix their HbA1c.
So can somebody take this mic too, sir? There is one mic down below. So they're getting the mic for you, sir.
And not only relative hypoglycemia, but true hypoglycemia also is common with high HbA1c. Because if somebody is on insulin, sugar is not controlled, A1c is 8, 9, that does not mean that he will not be getting hypoglycemia. A1c has a poor correlation with hypoglycemia, and that's why the CGMS, flash drive, all this has come.
Hypoglycemic unawareness. Can you please educate the audience about that?
I think that's going to be in my talk. In
No,
Delhi.
it's okay.
Hypoglycemic unawareness. Before that, the first question what Murli answered. You see, when people are used to having the sugar traveling in Mercedes and Benz, you know, it takes time from them to come to Maruti bike and cycle. So I think that's what, you know, slowly if you bring it, gradually if you bring it, the relative hypoglycemia would be slightly lesser than if you do it one bang, you know, nobody wants to be bankrupt in one go. The question was hypoglycemic unawareness. Many people, especially if they are on beta blockers, and they may have blunted hypoglycemic response, so they may not be, because many patients say, sir, हमको पता है कब हमारा sugar कम हो जाता है, हम ले लेते हैं. The important thing is that even if the sugar is high, they may not feel anything, and they may not feel anything when they're low. So the more important thing is to monitor their blood sugar, so you get an idea what it is, and especially patients will give you that information. If you're not feeling well, check your sugar, especially in elderly, which is going to be the next talk. I'm going to come on that. So many people don't have this blunted response, so they don't know. So you have to get it very, very gradually to bring that down.
Extending that question, which is exactly what I wanted to ask. If people have been used to having sugars of 40, they lose their hypoglycemic awareness. And how do you want to bring it up? How do you want to bring it up to normal levels? And how do you want to make them understand that they're having hypos when they have a hypo?
So we do see these patients quite a lot who have hypoglycemia unawareness. The main thing to do is to get them out of the hypos. Tell them first that hyperglycemia is not going to kill you. Hypoglycemia is going to kill you, or at least debilitate you immediately. So first thing is to try and reduce the whatever therapies they are on, whether it may be a long basal insulin, or they might be taking more of a bolus, depends on where they are having the hypos. So first immediate thing to do is to get them out of the hypos, and then you can target the hyperglycemias. Depends on where the hypoglycemia is, so that the therapies will be targeted in that fashion. But the important thing is to get them out of hypoglycemia. Tell them the importance that it is the hypoglycemia which is going to debilitate you, not the hyperglycemia.
Thank you. Utility of analog insulins, and as to how they can be given immediately after food, and how that helps preventing hypoglycemia.
Okay. So if you look at earlier, we had this talk, the regular insulins, when they peak, when the onset of action is. So the problem with regular insulin is, particularly in patients who are trying to achieve very tight control, like pregnant women or type 1 diabetes patients. So analog insulins could be very useful because they peak early and their action is usually finished by 3 or 4 hours. I mean, majority of the action. Some residual action may be there for 4 to 5 hours. So in those patients, particularly in hyperemesis or kids, you don't know how much they're going to eat. You've done the carbohydrate counting, but they eat half and say, I'm not going to eat anything like that. So in those patients, analog insulin can be very, very useful. So even in elderly patients, usually what happens is you're trying to titrate to the post-meal reading with a regular insulin, and it peaks later, and it also stays for a long time. So they may have a hypoglycemia in the middle of the night. That's why usually even when I give mixed insulin, I tend to be a bit less for the dinner, and I tend to be aggressive for the breakfast and lunch. So in those circumstances also, analog insulins can be very, very useful.
Thank you. So don't forget that analog insulins can be given immediately after food, and utilize that to the best of your benefit and that of the patients. So question, if somebody is going to have a big bound of scotch tonight and is on insulin, what would you advise the patient?
See, alcohol is very unpredictable. Okay.
Or those who drink alcohol?
Both sides. You don't know what happens when alcohol is in your body. You can always blame it on the alcohol. So you don't know how you will react to alcohol. And different types of alcohol may differ your response to it. Now, generally, most people, and with exceptions of few, prefer one type of alcohol. There are whiskey people and there are beer people and some vodka people.
My patient wants to drink whiskey.
Yeah, I'm coming to that. So the best thing to know is ask him to check his sugar 2 hours after drinking, because if he has it on regular basis, he will know how alcohol affects his body. More important with alcohol is the chakna that comes with the alcohol. That brings the sugar up, because people like eat bites or starters more with the alcohol, and not to mix Coke or anything with their drink if people want to mix it with whiskey as well. So I think checking and knowing what happens to your body is far more important. It may raise sometimes, typically it will raise the sugar temporarily, and in the night it will fall down. So it is always better to know and check it when you are doing it, to know what pattern that happens in his body.
Anything else you want to add to this question? Because it's a very important and practical point that we do see. Because there are a few other things that I want you to elaborate on that.
Yeah, exactly. So two types of alcohol you mentioned, beer and scotch. Beer has a lot of carbohydrate. It will bring the sugar up. Whiskey generally does not have much of carbs. The other important thing to mention is about the importance of eating something. Dr. Mithun mentioned about eating more, but there are people who drink and do not eat. These are the patients who are on sulfonylureas and on insulin who do not eat. And acute alcohol is known to cause hypoglycemia. Chronic alcoholism will cause hyperglycemia. Acute alcohol will cause hypoglycemia. So it is very important for them to eat. So I always stress the patient, please do eat if you drink alcohol, and stay away from beer. That's what I say.
So eat before you have spirits, okay, and then take your alcohol. That's the mantra that needs to go across. And of course, more frequent monitoring as well. Not to forget the importance of not driving. So on that note, I think we'll move on to the next presentation. Insulins in hyperglycemia management of the elderly. Dr. Mithun.
I have a caller mic. Okay. So while that gets ready, now my talk is on insulin hyperglycemia management of elderly. Now, can we have two mics at the back and moving around both sides? How do we define elderly? What age is elderly? So let's start with the lady at the back. Ma'am, what is elderly? What age is elderly? More than 65.
It is a early elderly, and the late elderly means more than 80 years.
So, okay. Somebody next to him. Ravi is not allowed to answer. So, yes, gentlemen there, sir. What is the definition of elderly? Who do you define elderly?
70, I think.
70 years. Okay. So, the fact is, calling elderly, I think is very difficult. My dad is 75 years old. Trust me, if I call him elderly, I've had it. He does everything. He still has his scotches and he still goes for a run. He still has his facials and he does everything. If I call him elderly, that's the end of the story. So I think calling somebody elderly, the more important is how the person is physiologically, rather than what is the age of the person. How much is functionally been able to work and be able to do, then what is his age is. In England, when we were there, the definition of elderly was 78 or 65 plus comorbidity when we went. But here we have, I'll just come to that. Who's considered elderly? Even societies are differ in what they call elderly. So standard and RSSD, I would say more than 70 years. More importantly is how the person is functionally than what it is, whether he's functionally dependent, is functionally independent, and whether he requires help for everything in life, including giving his medication. I think, and that is where the criteria of defining is. Nobody wants to, I think if you ask a female their age, I think is the worst thing you can do. And nobody wants to be in that age, any age, to say what their age is. So it's important to address how the person is physiologically and what the person can take care of. We all did insulin techniques. More important is, if possible, get the patient to do their own insulin. I tell them,
आपका आपका बहू या आपका बेटा आपको नहलाता नहीं है, आपको खाना नहीं खिलाता है, तो इंसुलिन क्यों देता है? You need to get them to do their own insulin and to make them functionally independent, because then they're not dependent upon others and they will not miss their doses and problems will not happen. So it's important to address that. Let's go back to the case scenario that we have. A 78-year-old gentleman who's been, I would say, a diabetic for a long time on an insulin, on a gliptin, and he develops hypoglycemia in the last 3 months. His HbA1c is 7.2. How will we manage this case? Now, Dr. Murli has already talked about HbA1c. Now, nothing is an absolute science, I feel. If you look at HbA1c, there is a variation of error of 0.3. So 0.9 to 7.5. If you look at the blood sugar of 143, if you look at the ISO 2013 guidelines of glucometer, 15 milligram per is allowed there, and 15% if they're above 100. So there's a variation. It tells me I'm near Taj Begumpet. It doesn't tell me I'm in Taj. So that needs to be kept in mind when we are dealing with our patients, and the therapy needs to be certain in that mind. It's terrifying to see a hypoglycemia. And it is. I mean, I've actually had to give 25% dextrose to my mother in the night. And it makes you as helpless, less like anything. So if we have therapies in which the reduction of hypoglycemia is less, because as much as we want our patients to have glucometers, as much as we would actually every time tell them about hypoglycemia, many patients will not carry glucometers and will not have carbohydrate at hand. Things like this, we have data to say which are relatively safer insulin to given. Just before this, Ravi asked me that question about blunted hypoglycemic response. And I think that's what happens in elderly as well, because they because the friction force is less, while if they have to do it with the allow, because they may have rheumatoid arthritis, they may have osteoarthritis. So it's very important we actually see what the patient can in front of them. What I use in my clinic is that I ask the patient to make a fist. And I think if the patient can make a fist, they can use a pen. Because that actually shows that you can, the grasp of the hand is there and it becomes easier for them to use a pen. And for elderly, that often I use them in the clinic where I have to do. Now, elderly behave differently. They are very different in terms of, because they have neuropathy. When I was in England, they will have one of the problems. They will either have constipation or they will have incontinence. The bowel problems will vary from one end to the other. They'll have visual aid. When I was doing the insulin workshop, I said, you can always ask them to hear the clicks, because even if their eyesight is not good, they can hear the clicks with the insulin pen and be able to ascertain what the dose is. And they may have more frequent fallers. They are there. Their walking mobility is not there. So they are a different, I would say, put in a different place as to a normal population. And we have to take care. We all love our parents. And we have to take care of them, and it's an aging population. People are getting aged. Yeah, the mortality is longer in people than they were many years ago. Also, there are a lot of PK/PD changes that happens with drug absorptions, with motility, as I've talked to you about already. And the blood-brain barrier may be exposed to a higher dose level. Elderly people have more renal problems. There are more hepatic problems. So we need to keep into mind when we are going to address or going to prescribe any insulin to these patients, because we need to understand they are already have been diabetic for a long time. They have micro and macrovascular complications that have been there. They may have vascular complications be there. And we need to ascertain. We just talked about, there was a question Ravi had asked about people not being able to eat. It's sometimes very elderly people find it very difficult to predict how much they're going to eat. And an insulin like Fiasp is very useful when you don't know how much they're going to eat, because you can use it 5 minutes after the meal as well. So you would know actually they have eaten, then they can administer. If the insulin has to be administered by somebody else, a basal insulin is often very good. Or you may do it twice daily when the carer is there and is being able to do it if the patient can't do it. So you need to know who's going to inject, and whether the patient can't inject, then you will have to give them a regimen which is workable for them in their life. No point. We would like basal bolus. I like basal bolus. Kalyan likes basal bolus, but it may not be possible for the elderly population given the subset that you may be having in your clinic. We can screen via various complications. There are various scores that you can do. Any elderly that comes, please look at their feet, because a lot of them don't look at their feet. Definitely spread, I would spread their toes apart and have a look at what's going on, because that's the most ignored part that is there. And often listening to them actually tells you. I find elderly people come to your clinic and very often they come to have a chat, and a lot of things come out when you allow them to speak. And a lot of things that have been there that you're not aware of comes out. So important thing is the functional capacity of the patient to look at. We can look at HbA1c targets, whatever we do. I want HbA1c, I want a narrower glycemic variability. Nobody likes a bumpy ride. I don't want a good HbA1c figure, but my sugar is 250. I would rather want it 140 all the time. So that's what you want for the patient, but we don't want at the expense of hypoglycemia. And we don't want complications. I think that is the mantra where diabetes care has now moved in. It's like you want everything, we as doctors, we have become greedy. We want everything for our patient. We want the best insulin. We want less hypoglycemia. We want them a good quality of life. We want them less complications. It's like a wish list when in a marriage that we want to, when we are looking for a partner. So it's important that if we can get something out of, if there are the newer insulins that are available with that, we can actually, use that for our patients who are a different kettle of fish than are there. Various guidelines may say different target HbA1c, and I would say as close as down as possible without the risk of hypoglycemia. I'm not going to talk about whether we should have 7.5, 8 or whatever. The important factor is as low without hypoglycemia. I think that is the target. If it's getting too close to target, an elderly patient, two things I really check is hemoglobin. Because you see, if the hemoglobin is odd, the HbA1c is going to be odd. And so you may have a very good HbA1c happening, but actually patient is anemic. Iron deficiency anemia may falsely elevate the HbA1c, as we are aware of. So it's important to keep that in perspective, not just look at HbA1c when we are looking at patients. I use CGMS, but we won't talk about CGMSs now anymore. They also have polypharmacy. They have a lot of medications. And sometimes what happens is patients do a lot of doctor shopping. They move around a lot of doctors. They come to a Quattrocchi center like, Dr. Ravi or Dr. Kalyan, and then they go back there, and then they will show that they're using my medication also and Kalyan's medication also. So it's very important to look at, I ask them to bring all their medications to look at what they are actually taking. I have had patients who are taking 3 different forms of gliptin prescribed by 3 different kinds of doctors. So it's very important to know what they are actually doing so that you can make sense of what's happening and then look at it. So there are challenges in elderly. They have visual, auditory, polypharmacy, renal, hepatic, irregular diet. So it's important we address that when we are going to prescribe. If you look at what we are gonna, what insulin is safe for elderly, all insulins are safe for elderly. I don't think there's any insulin you can say is unsafe for elderly across all. I think there is a slide on that. Everything can be used in elderly. All kinds of insulin, premix, analogs, IDEC, aspirin, any kinds of insulin. Insulin is insulin. The only difference between the insulin is when the onset will start and how long the insulin is going to be. So everything is safe that can be used. So it's important to address that based on the patient that is in front of you and having a meaningful dialogue or a meaningful relationship with him as what he's ready to do it. We've already talked about that insulin actually is the one that will improve the HbA1c. Rest all oral agents roughly around a percentage, but this is the one which actually controls the HbA1c much better, and you can get much higher HbA1c control with this that are there. Now, initiating insulin in the elderly, I think I don't use high doses of insulin. I start because there's a lot of worry when it comes to elderly. Patient has its own memory because diabetes is not just a medical condition. It's a psycho-medical familial condition. because they come with the entire family and everybody has their views on it. And yet also the barber who he went to has his views. The shopkeeper he has went to has his views. So he's come with that whole plethora of packages in his mind. So I start, and the more important not is what you start, I would say. The more important is to titrate after you have started. And I think that is far more important, especially in elderly, because there's a lot of worrying for your parents. For my parents, I would get more worried. And I'm sure all of us would get worried about parents. And we are also aging. Maybe a few years, I will get worried about myself as well. Now, they're far more acceptable to use pen than vials because of the dexterity that it involves with. As I said, I would start and move up, get them to monitor weekly, and then you can change. You will know whether they need a bit more prandial or whether they need a little bit more basal, and you can adjust accordingly based on that. There are all the guidelines have said, basically you can initiate everything. I think we can come to what they say, basal plus and basal plus plus, basal bolus, premix, TID. You can do everything. But elderly, find out what is his meal pattern. If they're fixed meal pattern, generally elderly people have fixed meal patterns, and generally they eat the same kind of what Dr. Mullier said, they would have 2 idlis, so they will have 2 idlis only. In those patients, premix insulin can be used because you know what time they're going to eat, what time they're going to not eat. And then you can actually have a good premix insulin on those patients as well. But know your patient. If they're going to have an erratic lifestyle, they're going to have different kinds of food, different times, they're still working, then you might want to have a more flexible regimen as there. As I said, most guidelines have said it. Even I was part of RSSDI guidelines, but you can say everything, but actually you can use everything that is there. Hypoglycemia has to be prevented, and counseling of hypoglycemia is very important. And carrying the glucometer that is there. If he can carry his watch, if he can carry his mobile, he can carry some carbohydrate with him at all time. I think that has to be driven very importantly to the patient, not कि सर glucometer है वो घर में है हम ऑफिस में है कोई फायदा नहीं है ना. So you need to have something with you that you can at least address that. Glucagon is very useful, but the patient should not be malnourished. If they're malnourished, it will not work. You need some storage there for it to actually click in and have it working. So as I said, you can use premix insulin if they have set meal patterns. You can use basal. You can use twice a day or once a day idecasp, and then work it up based on the sugar readings. That's all. With that, I would thank and happy to take any questions.
So dexterity, cost concerns, not to forget the dreaded risk of hypoglycemia. HbA1c, which is perhaps as not tight as you. What else do you want to suggest? In one take-home message sentence.
Take out so use the family and the patient and know the psyche. Everything else will fit in. Everything else will fit in. If female is calling, I call them Amma, then she's more ready to talk to me. Okay. So it depends upon how you relate with the patient, everything falls in place.
Next time we'll have a talk by Dr. Mithun on how to improve your practice. So I'm going to ask Dr. Murali now another question. People like to know the numbers, HbA1c targets that they want to target in somebody who's got an age of, say, 75 years. I mean, I know he intentionally skipped that slide, but people want to know what sort of numbers are we aiming for when we are using insulin. I'm not speaking about somebody on metformin alone, or I'm not speaking about somebody on DB4 inhibitors. Somebody on insulin had diabetes for 15 years. A1C is now 9. What are you realistically aiming for?
So whatever is the lowest value that you could safely achieve. So I don't want to put a number simply because there may be a patient with advanced CKD and very high risk of hypoglycemia, living on his own, who doesn't have many carers to help. I would be a little bit towards around 7.5 to 8. But if they have some family members and he's a little bit proactive and could follow things, so I would be comfortable between 7 to 7.5. But again, if they have coexisting retinopathy and it is impending to bleed or anything like that, then I may have to use other devices like CGM CGMS or something and help the family members to get a little bit more control. So again, it's not a single answer. So because we have a big range of patients with that age group. So depending upon the context really.
Definitely not less than 7. Okay. Agree with that?
Yeah, around 7.
Definitely not less than 7 in somebody who's got longer duration of diabetes on insulin and elderly. At least that's acceptable, right? Okay, good. Specific question. About elderly, they usually have renal impairment. I know sir is going to deal with that. They're going to have renal problems usually, and their creatinine is not necessarily reflecting their real kidney function as well. So how about the safety of insulins? Are you comfortable using all insulins, or do you think, I know that Dr. Mithun also touched based on that, but do you think all insulins are safe in this context, or do you want a bit of carefulness when you prescribe them the insulin doses? For example, when we're speaking about insulin start age, you're giving that roughly start with 8 units, build it up gradually. Will you use the same formula here, or will you actually follow a different rule?
Yeah. You will see that the final doses that these elderly patients will require is much less than what you will see in the younger counterparts. So the starting rule may be same. The initiation, if you're starting low, because all the guidelines suggest you start low and then go up, you can stick to the same routine. We only go aggressive in younger patients who require some form of surgery soon and something. But in elderly patients, you can start the similar sort of an initiation what we prescribed earlier, and then go up slowly. You will see that the peak insulin doses for elderly will be much lower, and definitely we need to be a little more careful in prescribing the insulin doses in elderly patients. In terms of insulin regimes, as long as we are sticking to a HbA1c of 7.5, definitely not less than 7.5. If we aim for that, sugars roughly, I would say less than 200. We are not going to have hypoglycemia, and I think every insulin regime should be
good enough. Yeah. Dr. K.D. Modi, do you want to say something specifically about usage of insulins in the elderly? Anything that we might have missed, or any pearls of wisdom from your vast clinical experience?
Actually, Dr. Mithun was rightly telling that yes, we have to check phase 10. We have to see that yes, whether they will be able to manage insulin pen device or not. But still, many elderly people, we do see that they find it more comfortable with vials and syringe, because unless and until they fill it up, they take it, they don't feel confident. And with pen, many of them, they make a big mess. Why? Because if you see their pen, many times half of the cylinder is full of air. So they'll be simply injecting air without realizing that, yes, they should do priming frequently, they should clear it. And many of them, they don't find it comfortable. And that's why I request all the company, even Novo company also, that they should make a vial, at least for this segment, because they are not comfortable for Tresiba or Isotec. With pen, some of them, they are not comfortable. Other thing is elderly people always actually other definition of aging is relentless progressive weakness. And you cannot solve that problem. Whatever you do, whatever excellent control is there, but still that weakness will not go away. So it is our duty to check nutritional aspect. And even for youngster also, micronutrients are so much deficient in our diet. So elderly people, it is very, very common. So like it was previously, we used to think that why to give B complex? They should take good food, nutritive diet. That is the best for anybody. But now if you see in nutrition, what is left out? See, whatever iron content was there in tomato in 1989, NIN data says that now it is only less than 20%. So if you are giving a food supplement, then also you are justified.
So If a person is comfortable using the good old syringes, let them be, as long as they're using it properly. Okay, don't force them on to use insulin pens, is what sir is saying. Also think about their nutritional status. Could be iron deficiency, could be other micronutrients. Okay, so on that note, I think we'll move on to the next one, which is a steroid-related in-hospital hyperglycemia, setting it right with insulins. Very important need of the hour by Dr. Kalyan Chakravarti.
Okay, so with our recent COVID experience that we all had, and with the recent steroid use or abuse that has been put on to a lot of our patients, so let's discuss how we can set their hyperglycemia right in the steroid scenario. So hopefully COVID is out of the thing now, but we'll see whether the steroid use for any other indications that might be there during in the hospital will benefit from targeted insulin therapy. So let's take the scenario that this is a 59-year-old lady who's admitted with COVID pneumonia. She's previously on glimepiride and metformin. The sugars were high on admission, but still she has had to be started on dexamethasone along with oxygen and supportive medicines as part of COVID therapy. So let's just assume that the physician or the critical physician had good enough reasons to start steroids. Now, how can you gain glycemic control in this patient? There are there's no one answer, but there might be multiple routes through which we can do that. So this talk is primarily designed to see how we can tailor our glycemic treatment based on what steroid the patient is being given, how the steroids are actually working, what are their pharmacokinetics. We'll discuss all that, and we'll also discuss which insulin regime is good for which type of steroid, and so on and so forth. And we'll also see what the guidelines say about all this. So apparently there is a high rate of steroid use in the elderly population, which is about 2.5%, and it's about 0.9% in the general population. Nearly 1/4 of patients may have used corticosteroids for more than 6 months at any given point of time. It is widely prescribed for many reasons: anti-inflammatory, psoriasis, rheumatoid arthritis, you name it. Any inflammatory conditions will require steroids. And in these population of patients who have had steroids, 32% of non-diabetic patients who have developed steroid-induced hyperglycemia. So 32% so that is 1 in 3 patients who receive steroids will get hyperglycemia who have not been diabetic before. And 18% of these non-diabetic who started on steroids develop long-term diabetes. We sometimes tell to the patients that the steroids actually prime your diabetes. You are supposed to you're genetically prone to get diabetes at some point. We give them steroids, it just unmasks your diabetes at an earlier stage, just like your gestational diabetes. Once you have that gestational diabetes, it can carry on similarly with the steroids. There are many risk factors of who may develop steroid-induced diabetes. I personally have, because I work in an oncology center which is associated. They're young boys, 15-year-old boys who've been given 60 mg of prednisolone. The hematology steroid doses are just unbelievable. They give 1 gram of methylpred every day, or 100 mg of prednisolone. Huge steroid doses. And I have seen 15-year-old boys developing diabetes. Of course, it's all temporary, but they have developed diabetes. So although these risk factors it gives us a ballpark figure of who develops diabetes, roughly anyone can get diabetes who you start steroid on. So anyone who has pre-existing diabetes, family history of diabetes, previous GDM, impaired glucose tolerance, PCOD, South Asian groups, and history of previous steroid-induced hyperglycemia. So we all know that these are all risk factors for hyperglycemia. Just like diabetes, you have this risk of hyperglycemia with steroid therapy. Now, steroids, why will they cause hyperglycemia? Because they are catabolic agents. They are the opposite of insulin. Insulin is an anabolic hormone. Steroid is a catabolic hormone. They are stress hormones. They are designed to give us glucose. They have designed to get us glucose from areas where there is storage to the areas where it's actually needed, because you need glucose for every cell of the function of the body to act, and especially at stress times where you have you need more metabolism and therefore you need more glucose. So they break down the glucose from every available source in the body, which is your fat, which is your protein, your glycogen. Wherever there is stored, it breaks down, and it is all given up to the areas where it needs. And obviously the glucose uptake, the peripheral glucose uptake is also inhibited. All this will lead to hyperglycemia. If it was a healthy individual, all of these sugars, if it's just been carried from one compartment, it will be stored in, or it will be used up by the another compartment with the help of insulin. Insulin is required to actually drive that glucose into the cell. However, if in patients who have insulin resistance or some existing pathophysiology related to type 2 diabetes, all this glucose which is mobilized from elsewhere is just get blocked in the blood, and therefore the patient will have hyperglycemia. So different types of steroids. The three common, let's just focus on the three common steroids. There are multiple steroids, but the three most common steroids that we use is hydrocortisone, prednisolone or methylprednisolone, and dexamethasone. We always calculate the steroids with an equivalent dose. So let's say you take dexamethasone 0.75 as your measured or your checkpoint, and you measure your other steroids based on this. So dexamethasone 0.75 milligrams is equal to 4 milligrams of methylprednisolone or 5 milligrams of prednisolone and 20 milligrams of hydrocortisone. The higher the dose is, the less potent the steroid is. Please remember this. Hydrocortisone is the least potent of all these steroids. It is not actually used as an anti-inflammatory agent, which is given hydrocortisone. Hydrocortisone is only prescribed in Addison's disease or any other cortisol deficiencies. So we only use it as a replacement steroid. So there are two types of steroid, replacement and doses of steroid. One is a replacement dose, one is replacement or physiological dose, one is the pathological dose. The replacement is designed to give us the natural natural steroid pattern that we already have in the system. The supraphysiological or the treatment dose steroids is what we use, like the prednisolone 40 milligrams, methylpred. This is an anti-inflammatory dose of steroid, which is way more supraphysiological than what our normal steroid levels are. And dexamethasone, of course, is more potent, and the other thing is not just the potency, it is the duration of these steroids. If you look at the hydrocortisone, the duration of action is only about 8 to 12 hours, and actually most of it is gone by about 6 hours. So in Addison's patients or in hypocortisolism patients, we give a hydrocortisone in the morning and we ask them to repeat the dose at about 12 p.m. or 2 p.m. Why? Because the morning dose gets washed away by afternoon. We have to repeat the dose again. Similarly, prednisolone has about a half-life of about 12 hours, and it tends to last for about 36 hours. But generally, its whole action finishes by about 12 to 18 hours. Dexamethasone has the longest half-life. It can last for about 36 to 72 hours. That's why we do this dexamethasone suppression test. We don't do a prednisolone suppression test. We do a dexamethasone because we want the steroid to suppress fully, or the ACTH access to suppress fully if you are suspecting a Cushing syndrome. So let's look at these steroids one by one. I'm not going to focus on hydrocortisone much because we're not going to use it a lot. It has a short peak. It has a peak at about 3 hours, and the whole steroid the doses resolve by about 6 hours. If you give the twice daily regime about 8 a.m. and not 8 p.m. generally, we give it at 2 p.m. You can have two separate peaks. But forget about the hydrocortisone. Even if we give the hydrocortisone, it is unlikely to cause diabetes because that is the natural response of the body. If we look at prednisolone or methylprednisolone, this is the most commonly used in COVID pneumonias or any other inflammatory conditions you see. So the profile tends to be like this. This is the glucose profile. The steroid also, the pharmacokinetics of the steroid also work in the similar way. The glucose also works very similar to what the level of the steroid is there in the system. So the onset is about 4 hours, peak is about 8 hours. The resolution is on 12 to 16 hours. So you only need to target, if there's somebody is on prednisolone, you only need to target the daytime, which is between 8 a.m. to 8 p.m. Even the methylpred, similarly, there's no difference. And so if sometimes the prednisolone is given as a dual dose, some in the morning and some in the evening. Technically, there is really no need to do that, but a lot of the physicians, they do it twice daily. Our job is to just support the physicians by adjusting the insulin regime. So we stick to what steroids they give, but we adjust the insulins based on how we think the glycemic profile has to be. Dexamethasone is very long acting. It lasts for about 36 hours. So it has a peak which is variable, but generally it has a flat peak. It just has a high level throughout the day, and it has an onset of action which is 8 hours. I'm not sure about that. Yeah. 16 to 20. No, the onset of action, it says 8 hours. Yeah, 8 hours. Okay. Right. So with this background of methylprednisolone, we'll only focus on methylprednisolone and dexamethasone. We'll go into which insulins are to be used in steroid-induced hyperglycemia and when. Now, if we look at the oral agents, the problem with the oral agents is the efficacy is limited. The steroids can tend to be varied. So some patients be on 40 milligrams and by 2-3 days they are on 20 milligrams, and they if the disease progression is increased, the dose might change again. So this rapid variation in the doses of the steroid, you cannot keep up with the oral agents, because the oral agents actually take some time to actually achieve a steady state concentration. They have a very slow onset of action. Therefore, you cannot keep up the pace with the changing dose of the steroid. And it will also be beneficial if you actually, when the steroids are being tapered off, you can actually do it better with the insulin rather than with the oral agents, because oral agents, we cannot determine how much of the hyperglycemia can be managed with the oral agent. Whereas insulin, you can titrate according to what you want, and then titrate it according to what you feel is necessary for the patient. That's what. So immediate onset of action with insulin, easy titration, unlimited efficacy, greater flexibility, rapid ability to target postprandial hyperglycemia, and dose can be modified related to the patient oral intake. So this is just an algorithm. It is not designed to, you don't have to follow this exactly, but it just gives a rough idea of what to do with each sort of the glucose profiles that you see with different type of steroids, which insulin to start and how to adjust the insulins. So let's look at this one by one. So if you have a glycemic profile which is a short acting, like hydrocortisone, let's say somebody is being given hydrocortisone IV, 100 milligrams IV for some reason, you have to use a rapid acting insulin starting at around 0.1 units per kg, which is roughly around 6 to 8 units. And if you can increase it as and when as the sugars are high, you can increase it by about with more of short acting, like 70% short acting and 30% long. But as I said, this glycemic profile is very unlikely to be seen unless we use like a hydrocortisone 100 mg once daily. Now let's look at this profile, which is most commonly what we see. This is, let's say somebody is given a prednisolone of 40 milligrams at 8 a.m. This person, you can have multiple different options. There's no one option which is right. NPH insulin you can use, which will work for 12 hours. This NPH insulin will be better if the patient is actually not eating much, because you're only targeting the steroid-induced hyperglycemia. Whereas if you want to address the postprandial peaks that are associated with the steroid-induced hyperglycemia, it is better to give some short-acting insulin also. I wouldn't consider insulin glargine or other longer-acting insulins here, because they're generally 24. This is a patient who's not diabetic, who's just had steroid-induced diabetes now. The steroids will be out of the system by about 10 p.m. Your insulin glargine will last until next day. So I would avoid glargine, but you can give them NPH insulin, or you can give them a short acting with the breakfast, with the lunch, with a background of NPH insulin in the morning. Just one point to add here is I would always start metformin in all these patients, because steroid-induced diabetes is just, as I told you, is just it's like a glucose tolerance test for patients. You are just giving them a higher glucose concentration in the blood and testing whether they're able to clear the glucose or not. It just unmasks the insulin resistance that these patients have. So a lot of these patients, the primary problem is insulin resistance. That's why the steroid-induced hyperglycemia is not. So please start metformin. It is a very valuable drug. It works very well in all these young patients that I have seen who are using 60, 80 milligrams of steroid. They've worked wonders with just 500 milligrams of metformin that did not require insulin also. So please start metformin. Metformin will take some time to work. In the meanwhile, you can start off with all of these insulins. You can titrate if the sugars are like more than, this is 200 milligram per deciliter, you can add 2 units. If it is more than 250 or 300, you can add 4 units. Increase it as needed. If the patient is on twice daily steroid, you can consider the NPH insulin twice daily, or then you can use the basal insulin once, and you can go for the basal bolus insulins twice daily. One practical point I would want to mention here is that the steroid absorption is not equal. This prednisolone absorption is not equal in all patients. Some patients have a hyperglycemic response after breakfast, and some patients have a hyperglycemic response after lunch. In those prednisolone. With dexamethasone, it's very simple. They have hyperglycemia throughout. Once you start them on dexamethasone, the sugar just shoots up in susceptible patients, and the sugar just tends to be high throughout the day. There is no variation. It's just 300, 400 plus. You can just bombard these patients with a lot of insulin. You can use twice daily premixed insulin, which I use personally with this, because twice daily premix works very well with the hyperglycemia pattern that we see in dexamethasone. And you can also use ultra long acting insulins with an additional bolus, depending on how the patient is eating or not. You can again titrate them as your sugars are high. If there is more than 200, increase by 2 units. If there's more than 250 or 300, you increase by about 4 units. And you can always add in rapid acting insulins if the sugars are not controlled. So when tapering the steroids, so we've now looked at what are the types of insulins that are to be added when the steroids are added on. But what are how do we do it when they're actually tapering off the steroids? Once again, there is no hard and fast rule for this. We have just picked up some few guidelines from the recent publications, I think. And when the steroids are tapered by 50%, your insulin dose needs to be reduced by 25%, because steroid-induced hyperglycemia unmasks diabetes, and it tends to actually fade off in a very slow fashion. If you stop the steroid today, it doesn't mean that your hyperglycemia will reduce by tomorrow. In some patients, it will reduce by very quickly, but in susceptible patients, they can develop type 2 diabetes, or it may take a week or 2 for them to actually come back to a normal glycemic state. So for these patients, we have to, that's why this lag, you don't reduce, if 50% steroids are reduced, you don't reduce by 50%. So that's why this lag is there. Reduce a little by little. How will you monitor these patients? Ideally, everybody will require about 3 TID GRBS checks, but it just gives a rough algorithm of how to check the sugars. If it says that once the glucocorticoid therapy is started, you check the sugars once prior to lunch or evening. And if the subsequent levels are normal, you just stop checking or just check once daily. If the subsequent levels are high, you increase it to 4 times daily. So essentially what this means is that there is a steroid response which is transient. I'm sure some of us physicians have seen this. where you start the patient on steroid for 48 hours, the sugars are high, and then the patient goes back to normal. This does happen to a lot of patients. There's a transient diabetes which just settles by itself. So not all steroid patients will go into hyperglycemia. Just watch them for about 48 hours. They may not require anything at all. If the patient is normoglycemic, like after 96 hours or 4 to 5 days, then you can assume that the steroid may not cause hyperglycemia. But if the sugar is high in 48 hours, you recheck it again in 3 to 4 days. It's possible that it may come down to normal by itself. And because it's important for the diagnosis of the patient also. When any patient who comes in with hyperglycemia, you have to know whether it's actually a pre-existing diabetes or it is just a steroid-induced hyperglycemia. So if the HbA1c is less than 6.5, it is unlikely that the patient has a pre-existing diabetes. If it is more than 6.5, there is definitely a diabetes beforehand. According to the guidelines, you can give all forms of insulin. I wouldn't recommend non-insulin therapies. You can either give a basal human insulin, a basal analog insulin. Depends on what type of insulin you are using. Generally, for the prednisolone, you can give either a NPH insulin or a premixed insulin once daily in the morning. For a long-acting steroid, you give ultra-long-acting insulins or a basal analog with a short-acting insulins. That will be the ideal regime. So glucocorticoid type and duration must be considered according to ADA. It depends on what steroid you give. You consider what type of insulin that you will be putting them on. So with that, I conclude. Any questions? You are ready to take. Thank you.
Thanks for that fantastic talk as ever. Any burning questions, guys and ladies? Yeah. GKI regime still holds good for what? Steroid-induced diabetes or in general?
To management of blood sugars.
In general, okay.
Yeah.
If somebody is nil by mouth and is on insulin before the surgery, I know you're an anesthetist when you introduce yourself. So his question is GKI regime still appropriate? Of course it is. But better than GKI regime is perhaps sliding scale IV insulin regime. Okay. The reason being, you can really quickly titrate the doses according to the hourly blood glucose levels. Yes, GKI regime is good enough though. It works and it helps, no doubt about it. Okay. But coming to steroid-induced diabetes, which is the half raised hand there? No. Right. Okay. Fair enough. Sir, you want to say something?
Thank you. And it was a very informative presentation, and he is very correct that always it is not that once you start glucocorticoid, sugar will increase, and this happens very frequently in pregnant ladies. Like generally in last trimester, obstetrician, they gave betamethasone, and before starting betamethasone, they send each and every patient to us that whether you want to increase insulin or not. I always tell, no, you start and we'll see afterward. And in many of these patients, almost 70 to 70% of patients, nothing happens. So we have to, as you said, we should wait for 48 hours and then only should react. And other problem comes is in COVID patients when they give methylprednisolone infusion, especially in pulmonologist, in many other conditions, it becomes very difficult to control. Some patient, it is a nightmare to control their blood glucose. So I think basal bolus only we are practicing, and or sometimes if it is continuously very high, then we give insulin infusion, not glucose, insulin, potassium drip, but simple saline and insulin infusion they may require.
Yeah, you can broadly classify these into the type of steroid-induced hyperglycemia, depending on which steroid you're using, be it hydrocortisone, prednisolones, methylprides, or the dexamethasones or betnazole, or sometimes even defzilocort, which is being used quite often. Or you can classify that based on the scenario in which it is being used. COVID scenario is completely different in that patients are extremely insulin resistant just because of COVID. Okay, remember it's a stressful state in itself, and COVID in itself can cause problems pertaining to pancreas, damage of beta cells, so on and so forth. So COVID is a special scenario in itself. So is pregnancy. Remember, pregnant women are generally insulin resistant. They might be having gestational diabetes already, or for that matter, even diabetes mellitus, and became pregnant. And you have a slightly different scenario wherein a person has asthma or COPD and temporarily started on a small dose of corticosteroids. And you have a completely different scenario wherein endocrinologists do start, or ophthalmologists do start, pulse methylprednisolone for eye disease related to Graves' orbitopathy. Or there are scenarios wherein they use very high dose of corticosteroids. For instance, when they think that there is severe optic neuritis that needs to be salvaged. Sometimes ophthalmologists do that, especially when they're not happy with endocrinologists. That's a joke. So these things do happen. So have a dialogue with your fellow care provider, be it a pulmonologist or be it the obstetrician. Usually obstetricians are kind enough because they do it for 2 days. You know what they're going to give, be it betnazole, or these days they're actually giving dexamethasone. As people might have noticed. So usually that's straightforward. But what is not quite straightforward is your pulmonologist or your ophthalmologist giving a regime of their choice. So have a dialogue with them. Actively follow for any tapering of steroids, as Dr. Kalyan has mentioned. Because if you miss that, you're asking for good-going hypoglycemic episodes, because you would be giving very high doses of insulin to combat the insulin resistance, along with metformin in specialized scenarios only, of course, monitoring the renal function, so on and so forth. So be very cautious. Steroid-induced hyperglycemia is pretty challenging. I'm sure many of you would have seen a lot of cases needing hundreds of insulin units per day, even to the extent of 440, 460. Those numbers are still fresh in my mind during the previous second wave. Hope we don't need such doses now. And to just remind you, premix insulin twice a day at breakfast and lunch alone, without giving it in the evenings, does really help very well control blood glucose levels in patients who are on prednisolone alone at breakfast times. Only prednisolone, 30 or 40 milligrams, you're fine with either insulatard, as Dr. Kalyan mentioned, or premix insulin morning and lunch only. Don't give it at dinner time. Be cautious, because that can cause really bad hypoglycemic episodes in the middle of the night. Okay, unless you want to use basal bolus, which is anyway the box standard. You can use your basal insulin, but very less doses. Okay, remember that, because you don't want any hypos at night. Okay. Very small doses of basal. You don't usually follow that 50-50 rule when it comes to basal bolus insulin regime in a steroid setting. You go for very less dose of basal, something like 30% at max, okay? And give a lot of bolus at breakfast and at lunchtime, depending on how the absorption is. Again, he pinpointed that very lucidly, that you need to see what the trend of the increment is, and make sure that the steroid timing is also fixed. Don't let them change one day at nighttime and one day at morning time. Creates havoc when it comes to blood glucose readings. These are the practical points. And coming to dexamethasone, life is a lot more easy, unless our neurosurgeons decide to use it something like 32 milligrams per day for neurosurgical problems, be it your spinal injuries or other problems. So again, that's another different scenario, but it's a lot more predictable, unlike your prednisolone. And hydrocortisone is also reasonably predictable, as alluded. So I suppose that's the crux of it. Anything else you want to add? Dr. K.D. Modi sir wants to add something.
And my one last request was there, that in forum like this is where we talk of endocrinology, we should be selective in using terminology. Like we should try to use a glucocorticoid rather than steroid, because in that way, testosterone is also a steroid. Estrogen is also a steroid. So when we discuss a specific issue like this in a forum like this, it is glucocorticoid-induced hyperglycemia. Thank you.
So we're not speaking about testosterone. I know the guy has left for good. He will be back anytime soon. So anything else you want to add? You're done. Right. So I think it's time for Dr. K.D. Modi sir's talk on insulin usage in other special population. He's going to deal with really complex scenarios, be it renal impairment, hepatic impairment, a bit about pregnancy, a bit about children as well. Because remember, these are individual talks in themselves. Okay, each one would ideally take half an hour at least in themselves. But Dr. K.D. Modi sir is going to keep to the basics and try to touch base on everything so that you have something to take home about each of these scenarios, following which we'll have a short tea break. Over to you, sir. So slides are ready, sir.
Yes. So I thank Dr. Ravi Shankar and all of you and Novo Company for organizing this informative CMEs on a very important aspect of diabetes. And frequently, like our previous speaker talked about hypoglycemia and other aspect of diabetes. Still, I had a few things in mind for hypoglycemia. And it is such a miserable condition, so difficult. And when we were discussing about reversible hypoglycemic unawareness, we should always remember that this condition of hypoglycemic unawareness is a reversible condition. It takes 15 days for normal state to come. Only thing is, in this 15 days period, he should not get repeat episode of hypoglycemia. So those who have hypoglycemic unawareness, you try to keep their target little bit up, try to keep fasting sugar more than 100 and wait for 15 to 20 days, they will start getting symptoms. So again, now coming back to important topic, these are very important topics: CKD, liver disease patient, type 1 diabetes, and gestational diabetes. In 10 minutes, 5 to 10 minutes, I'll try to finish important aspect of insulin therapy in this subgroups. So first only, thank you, Kim. So starting again with a case scenario, like this is a 11 years duration type 2 diabetic patient, 62 years age, and he comes for follow-up after 1 year. And most of the time when follow-up is not regular, I always insist that diabetic patient, they should come for follow-up at least once in 3 months. If they come after that, then something always goes wrong. So we should insist that they come for follow-up at least once in 3 months so that you can check. So this patient is on metformin 2000 mg, sitagliptin 100 milligram per day, empagliflozin 25 milligram per day, and he has come with severe weakness, tiredness, weight loss. Obviously, this all can be attributed to hyperglycemia, and he must be very poor in monitoring. His weight is 65. He lost weight, as I said, and his A1C is 8.5. Random blood glucose was 185, and his EGFR is 28. That comes to CKD stage 4. And his creatinine, serum creatinine is not given here, but it must be around 3 to 4. And previously it was a 55 EGFR 1 year back. So there is a rapid decline in EGFR. So what we will do? So first, I think that since his EGFR is less than 30, first thing is we'll stop metformin therapy. Metformin therapy is not advisable when EGFR is less than 30. Second thing, he is on sitagliptin, and that too 100 milligram per day. Sitagliptin without modifying dosage cannot be given in a CKD patient. And whether this 100 from 100 milligram, if I make it 25 or 50, will it work? to control his hyperglycemia? I don't know. So that also I will think of stopping it. And third is empagliflozin 25 milligram per day. Even though credence data is there that it can be given, empagliflozin can be given when all SGLT2 inhibitors can be given when EGFR is more than 25. But when we are trying to use it to control blood glucose, I doubt and I will not be comfortable in continuing empagliflozin in this patient. Afterward, I may think after stabilizing his blood glucose only for renal benefit, if I check everything and it is a diabetic kidney disease, and if somebody wants to argue that yes, for other benefit, pleiotropic effect, you can continue SGLT2 inhibitor, that is a different thing. But at this moment, I will stop it. So only solution is that to change over to insulin. So CKD patient, definition of CKD is it's a structural or functional kidney abnormality that persists for more than 3 months. And to mind well that CKD, even EGFR can be normal also. That is the initial stage of CKD, where only thing that can prove CKD is renal biopsy. But with normal EGFR also CKD can exist. And world over it is observed that overall prevalence of CKD is around 45 to 50%. So does it mean that every alternate patient is CKD patient? See this. In day-to-day practice, we don't see like this. But this definition includes each and every patient who has some component of CKD, like microalbuminuria. And we all know that in type 2 diabetes, all patients with microalbuminuria, they don't progress to end-stage renal disease. Only 20% of them, they progress to end-stage renal disease. But it has different implication. If somebody has a persistent microalbuminuria, then he is very high target group because his future cardiovascular risk is very, very high. So what this graph shows is that around 45% of patients in their course of diabetes will have some evidence of CKD. So we can take it like that. And these are different stages, we all know. And as I said, that initially it is a hyperfiltration stage, and this stage can be seen only in type 1 diabetic patient, where you will see on ultrasound big size kidney. Generally, we don't see this stage in type 2 diabetes. And once my high screening risk group is hypertensive patient. And in any type 2 diabetic patient, if hypertension is refractory, if it is not coming down with more than 2 or more than 3 antihypertensive, first thing is to rule out CKD, and then only we should think of other secondary causes of hypertension. But first and most important thing is diabetic nephropathy. And these are different mechanism, polyol pathway, advanced glycated product, pro-inflammatory cytokines, but that we can go through any time. And this is the newer way of classifying CKD. One is like stage 1, stage 2. Stage 3 has 2 components, 3A, 3B. And then stage 4 and stage 5. And on the other side, we should try to mention whether it is A1, A2 or A3. A1 is microalbuminuria less than 30. A2 is 30 to 300. And A3 is more than 300 milligram per gram of creatinine. The implication of CKD is very, very important. Not only that CKD leads to progressive renal disease, but it also interferes in diabetes management because of high tendency for hypoglycemia. And in initial stage where creatinine is maintained, only proteinuria is there, many of them, they develop a severe insulin resistance. Whatsoever insulin you give, 100 unit, 120 unit, 140 unit, their sugar will not come down. And many times we keep this type of patient on CGMS and then decide how to adjust insulin therapy. But by and large, around 70 to 80% of patients, their insulin requirement comes down and they start getting hypoglycemia. And many of them, they don't require anything, no insulin or any other medicine to control blood sugar once their CKD progresses. CKD patients also have a very high risk of cardiovascular disease all throughout, right from stage of proteinuria to CKD stage 3, 4, and 5. And it is said that most of them, they die of cardiovascular event rather than renal cause. CKD also is very high risk for foot ulcer. CKD is also very high risk for retinopathy. And as CKD progresses, as eGFR declines, then their cardiovascular risk increases. So mortality also increases very much once CKD progresses. And glycemic targets are generally in advanced stage, moderate to severe chronic kidney disease. We try to keep A1C between 7 to 8. And we don't try to keep blood sugar under tight control because their deciding factor for progress of disease are different. That is hypertension, urine infection control rather than glycemic control. And depending on this factor, whether it is a comorbidity, how much is the future life expectancy, what is the severity of CKD, and what is the status of his vascular system. So based on that, we can decide the target. And most of the patient of moderate to severe CKD, they require insulin. The permitted agents are like GLP-1 receptor agonist and DPP-4 inhibitor, where linagliptin, you don't need to adjust the dosage. Teneligliptin also, without modifying dosage, you can use, but others. And sulfonylurea, always we are very careful. And alpha glucosidase inhibitor data is there for acarbose, where they say that though direct side effect is not there, but therapeutic range, it crosses once CKD progresses. So in stage 2 beyond, even acarbose is also not permitted. Voglibose is relatively safe, but it is very difficult to control their diabetes only with voglibose. And this is very important slide. And that shows a difference in insulin metabolism or insulin excretion in endogenous versus exogenous insulin. And exogenous insulin mainly depends on kidney for clearance. Endogenous insulin, it is around 30% clearance is in liver and rest in kidney. So that's why this is the main reason why their hypoglycemia tendency increases. And these are other reasons why their insulin metabolism changes. There is increased insulin resistance, but on the other side, because of poor appetite and poor glucose, even kidney is also very important part of neoglucogenesis. So that also suffers in a CKD patient, and insulin requirement comes down and overall tendency for hypoglycemia increases. And this is a practical experience, and we all know that most of the CKD patient, they are managed with insulin only. Yes, in early stages, in early stage 4 or stage 3, we give them modern sulfonylurea. They say that modified release glycoside or low dosage of glimepiride or drug like linagliptin can be used, but by and large most of the patients are managed with insulin, and this is very important slide that shows the utility of different agent in different stages of CKD, and we can make out that metformin and DPP-4 inhibitor, they have limited usage, and except a few DPP-4 inhibitor, they can be given up to like linagliptin, teneligliptin, it can be given up to stage 4. But insulin can be given right from stage 2 to stage 5. So that's why most of the patients, they are managed with insulin. Even GLP-1 receptor agonist also, except they are not recommended in hemodialysis patient, but otherwise in all other stages you can use it. But problem for GLP-1 receptor agonist is like daily injection and cost of the therapy, where Novo company will try to solve this problem of daily injection by launching a oral agent in coming month. So overall, we can say that more than 50% of CKD patients, they are managed on insulin, and we should initiate insulin with a small dosage. And again, here also, we should try to select the agent which gives less glycemic variability. So short-acting insulin analog and long-acting basal analogs can be preferred where fluctuations are less, glycemic variability is less, and overall hypoglycemic tendency is less based on their glycemic profile. So if somebody can be managed only with short-acting analog, then yes, that can be considered. If somebody has a consistently high blood glucose profile, then if you want to consider a long-acting agent, then better to use second generation basal insulin analog. So after that, we will come to next topic of chronic liver disease. The problem is chronic liver disease, by the time they come to you, most of them, they are in advanced stage. So if somebody comes with ultrasound report of esophageal varices, then already it is advanced stage. So many of them, they come with advanced stage of liver disease, where hepatic glucose reserve is very poor. The capacity of liver to cause this neoglucogenesis is also compromised. Albumin synthesis is also compromised. So those are oral drugs or injections, insulin, which are albumin bound, they also will have like their effect and their this pharmacokinetic profile will change. So many issues are there, and typical chronic liver disease patient, they pose a problem of fasting hypoglycemia and postprandial hyperglycemia. This is a very typical problem or liver disease patient will have. So it is characterized by so many metabolic alteration, and if they have increased liver enzyme, reduced liver, reduced plasma protein, then viability of drug will be a big question, especially the drug which are metabolized by cytochrome P450 enzyme system, which we all know that is localized only to liver. So that's why our target again in this patient, HbA1c, many times it gives a false low value in chronic liver disease patient. Fasting blood glucose typically comes low in chronic liver disease patient. And again, glycated albumin, those things we don't use in our practice, but even for HbA1c also, you can get false low reading. And there are not so many guidelines how to manage these patients, and information are available about, on various agents like metformin. They say that it has very good safety profile, and people have also reported that it also reduces hepatic cell carcinoma risk by 50%, and it is cardioprotective in liver disease patients. So metformin in moderate to severe liver disease, you can use it. Only thing is that if they have hepatorenal syndrome, if creatinine is high, then possibility of lactic acidosis will be there. Pioglitazone is one agent that is approved in NASH, and it has a favorable profile in chronic liver disease patient. But again, CK as a chronic liver disease patient, they have problem of ascites, anasarca, which can get aggravated with pioglitazone. Alpha glucosidase inhibitor, they reduce postprandial hyperglycemia, and that is a main problem. They are also known to cause favorable intestinal bacterial flora. Because it does not exert any hepatotoxic effect. Risk of hypoglycemia is always there in decompensated chronic liver disease. So we should be careful in initiating, in titrating, and in adjusting insulin dosage and selecting the preparation of insulin therapy. Then third topic I will try to cover is type 1 diabetes. And it is said that type 1 diabetes, even in India, is increasing. And we can see this, number of new incident cases in India is equally high, 15.9. United States, it is 14.7. In UK, in all other country, it is around 2 to 5%. So overall, we can say that incidence of type 1 diabetes is increasing. And prevalence is also high, except in some of the European country, it is like a Scandinavian country, it is very high. But even in other country, type 1 diabetes is increasing. And generally, we need not go for the staging because by the time they come to us, all the patients, they are symptomatic, they are in stage 3. But other issue is how to prevent it. And there is research going on, so many studies, but not a concrete solution how to prevent type 1 diabetes and how to screen the high risk patient. So most important is to taking family into confidence, because type 1 diabetes, I think that cannot be managed alone. So unless and until family support is there, unless and until clinician support is there, you also have to support them regularly on a day and night basis whenever they have a problem. Otherwise, it cannot be managed. And these are the glycemic target we always try to keep. And it is easy to say, like most of the type 1 diabetic patient, we find them with A1C between 7 to 9. And most of the patient, few lucky patients and those who afford insulin pump, they'll be near to 7%. And target again is same only, pre-meal sugar between 70 to 130. Post-meal less than 180, and A1C less than 7%. And previously, like many patients were managed of type 1 diabetes were managed on premix insulin, but now I think the trend has changed, and I don't remember any patient type 1 diabetes. Like I must be having minimum 300 to 350 type 1 diabetes in follow-up. All of them, they are on basal bolus therapy. So because premix insulin has limited flexibility, with premix insulin, nobody's A1C will come down to expected level. So that's why basal bolus is the norm. And only problem our patient face is that bolus insulin, yes, they are using a regular insulin. Basal insulin, many of them, they are finding it difficult to purchase, but still they are managing. Basal insulins are, and many of these type 1 diabetic patients, they are from very poor socio-economic group. And even though they are from lower socio-economic group, still they are managing, they are daily checking blood sugar, they are using basal insulin. See how nice, compliant our patients are. And at same economic level, can you dream that any Western patient following this insulin therapy and monitoring? You won't find. So our patients are very nice, very compliant, but problem is of disease. That disease is very difficult to treat. So basal bolus therapy is the norm, and generally if patient can afford, we give short-acting, ultra-short-acting analog. And ultra-short-acting analog Fiasp insulin has one more benefit. Many children of type 1 diabetes, they are very naughty. Their diet, like in elderly people, even for type 1 diabetes children, you cannot predict how much he will eat. Mother always complains that sometimes he will eat very little, sometimes he will eat a full meal. So I don't know how to judge his insulin dosage. So for them, this Fiasp insulin is very good because it can be given after food. So I tell them that yes, you wait, you give after food. And for this type of patient, we change the insulin. And long-acting analog, generally we use either Glargine insulin or Degludec insulin. And in some patient, U300 Glargine insulin. So that is about insulin therapy in type 1 diabetic patient. And lastly, in GDM. GDM, actually, the definition like what we were taught, any type of glucose intolerance found during pregnancy is a GDM, gestational diabetes. But true gestational diabetes is like diabetes detected in second or third trimester. Why second or third trimester? Because it is pregnancy induced. Whatever happens in first trimester, generally it is not pregnancy induced, and outcome is also different. Management is also different. So true gestational diabetes, we can consider the diabetes detected in second or third trimester of pregnancy that was not clearly overt diabetes prior to gestation. And overall prevalence world over, it is seen that it is around 13 to 15%. If type 2 diabetes prevalence in urban area is 9 to 12%, then GDM prevalence is around 13 to 15%. And consequences of GDM are also risk factors for GDM. Yes, those who give like obese, it now because India country itself is very high risk group. So any pregnant lady comes, we generally screen them for GDM. But these are very high risk group, obese ladies, past history of PCOD, past history of repeated miscarriage, or past history of macrosomia. And in gestational diabetes, mainly it is placenta-induced hormones, mainly human placental lactogen that acts like growth hormone, and that causes insulin resistance. So insulin resistance is a major contributor to hyperglycemia, but even impaired insulin secretion is also plays a vital role to cause hyperglycemia. And in gestational diabetes, if it is neglected, then consequences are like macrosomia, then increase risk of jaundice, premature jaundice, preterm delivery. And one more thing that is not mentioned is sudden fetal death. That is also, and that's why most of the obstetricians, they don't take chance. Once a lady reaches up to 35, 36 weeks, they take a lady for cesarean section because of high risk of sudden fetal death, especially when blood glucose is uncontrolled. And there is increased risk of stillbirth. It is mentioned, shoulder dystocia. And most of them, they are subjected for cesarean section rather than normal delivery. That I think it is not a correct practice. Some patients should be given chance, especially those who have A1C less than 6.5% with a very good glycemic profile. They should be given chance for normal delivery. And target for control is also like fasting blood glucose. We always tell that they should keep less than 92 or less than 95. It is mentioned here. We generally tell them to monitor 1 hour post-meal blood glucose, and that should be less than 140. Why this 1 hour post-meal blood glucose? Because most of the studies related to GDM and outcome in offspring, they have taken 1 hour reading, and that is a starting point of meal from there 1 hour, and it should be less than 140. If you are following 2 hours reading, then it should be less than 120. And generally, yes, all pregnant lady, they are explained lifestyle modification and diet therapy. Few of them, those who have a very marginal hyperglycemia, they are managed with metformin. And metformin, even though it crosses placenta, but nobody has reported any teratogenicity with metformin. And that's why metformin usage is permitted. But problem is that most of the GDM patients, they cannot be managed only with metformin. So if somebody has a persistent fasting blood glucose of more than 100 or post-meal blood glucose more than 130, insulin therapy should be considered. But one more thing is that even on insulin, you can add metformin. Sometimes with insulin, if sugar is not up to the mark, and if you increase, patient is getting hypoglycemia, especially post-meal sugars are coming 140, but fasting is all right. In such patient, we do add metformin along with insulin therapy. And when to initiate, now this audience, everybody knows because everybody is managing. So when somebody has a persistent fasting blood glucose of more than 90, or 1 hour reading, post-meal reading is 140, 2 hour reading more than 120. Generally, overall trend is to start early insulin therapy. Insulin is also considered as a eutrophic hormone. So it also, some people, they claim that it prevents miscarriage, abortion, like that. So which insulin to use? So these are the category where these insulins are classified: regular insulin and aspart insulin, as well as lispro insulin. They come under B category, and glulysin insulin comes under C category. Detamir basal insulin, that comes under B category. Degludec and glargine insulin under C category. NPH is B category. So most of the patients we manage with regular insulin or aspart insulin. Some patients, they do require basal bolus therapy, and generally we don't use glargine or degludec, but in some patients, when blood sugar control is very difficult, we do use it. So with this, I will stop here. It was a very exhaustive, but because 4 topics were there, even 10 minutes also, it will take 40 minutes.
Thank you very much, sir.
Thank you.
Really appreciate trying to cover such an exhaustive, so many exhaustive topics in a span of half an hour to 40 minutes. I really appreciate that. Thank you, sir. So any questions for Dr. Modi?
What is the maximum dose of metformin to give in pregnant women?
So please be seated.
If she tolerates, then 2000 mg.
Yes, sir.
If she tolerates. But many of them, they don't tolerate. So generally we give up to 1000 mg, sometimes 1500.
Sir, you don't give glargine, sir, for the pregnant woman?
Less.
Because it's NPH, you go for NPH.
Yeah, you do.
Many times we do give like pre-breakfast aspart insulin, pre-lunch aspart insulin, and pre-dinner premix insulin.
Okay.
That also we do.
Yeah, I mean, it depends on which class drug it is. You're more than comfortable using B class drugs, but C class drugs you try to avoid. If somebody is already on insulin glargine, you can continue that. Don't stop away and cause big havoc.
But sometimes we have to use it when sugar is totally haywire. That time basal bolus therapy is the only way out in some cases.
I use detamir a lot because it's a class B. Okay. That's the reason why I use it. And class C is insulin glargine. But somebody, if they were to be on glargine, I would not discontinue that, if you know what I'm saying. That's all based on IGF levels and all that, insulin growth factor receptors. And coming to metformin, as Sir rightly said, most people may not tolerate your 1 gram twice a day. So build it up at 500 mg twice a day and maximum 1 at 1.5. But if somebody is tolerating nothing, not harm, as long as there is no IUGR. Okay, just keep a watchful eye on that. The only thing which I keep a watchful eye on is if the patient is tolerating 1, 2, what is happening to the growth scans. You don't want to use metformin in somebody who's having this problem. And of course, do document that you have discussed thoroughly with the patient all the options that are available. There was a time, sir might remember, I'm speaking about 10 years, 11 years back when I initially stepped into this country. people were completely away from using metformin. I was probably one of the loner using metformin then. So I had to document, discuss various options, including metformin, and patient is willing to start metformin, blah, blah, blah. I still remember that. And see, it all depends on what you're comfortable. I came from a place where metformin is a standard treatment of choice. Okay, unless you worked in UK as well, so you know it. So, but here the people were still taking their time to accept. I think Dr. Modi, if I'm right, is one of the very initial doctors to start using metformin, because we had, you remember?
Your advice.
No. Yeah, I take it if I could prompt you. But I do remember in one of the ESIs 9 years ago when I gave, when I made comments about metformin pregnancy, people frowned. I'm not joking. It's not that we have done a lot of research. It's just something that we're comfortable. People really frown. Okay.
Even now I get, when I start metformin, I do have...
Even now, there are some endocrinologists in the city.
That's why...
you remember 2 years back when you held that endocrine society meeting in Hyderabad. Dr. Modi was batting for metformin. I still remember. I was batting for metformin. Dr. Prasoon was not. You remember that? Yeah, that's what I'm trying to say. So, yes, really, when I started and when I gave a talk like this, there was about 50 people who were flocked me after that talk 10 years back in ESI. If I remember, it was in Kolkata.
Because even now, when I start them on metformin, I do get a few questions from the gynecologist telling the patient, go back to your doctor and ask why he is on metformin. So there's a doubt in the patient's mind now. So then what I do is, okay.
It's just something that you are comfortable using. Yeah. My bosses were pretty comfortable using in UK. That's how I got comfortable. And there is evidence, obviously. Remember, in medicine, I think Mithun was quoting this. It's never black and white. It will never ever be. Anything for that matter, be it metformin, be it insulin, or be it anything. So we all practice based on whatever evidence we do have and whatever we are also comfortable using. Okay. Somebody who's never used Levemia tomorrow might be a bit uncomfortable, but after a few usages, they might be more comfortable. Same with metformin. Yes, trust me, mark these words. There are 50 people who flocked me as if I'm speaking something different way back 9 years back in one of the conferences or 10 years back. Okay, in one of the national conferences. And we are speaking about really esteemed endocrinologists. Okay? When you start saying, look, we have been using it, and this is the standard practice in UK, people really frown upon you if you say, look, I don't use metformin in UK, right? So it all depends on the comfortable levels.
Thank you, sir. Thank you, sir.
Yes.
As well as Dr. Ravishankar and myself, we both train under Rudy Pillas. Some of you know who is Rudy Pillas. He's a professor who wrote the nice document on pregnancy and diabetes. And in the same document, he mentioned that NPH insulin is the basal insulin of choice. And he also mentioned if somebody is already on glargine, not to stop it. At the same time, when it comes to practice, where we actually did the clinics with him every week, by default, we gave glargine, if I'm wrong.
So he is one of the big heads.
He's the one who wrote the document.
So he writes nice guidelines. We had the luxury to work under him, train under him. So we were always comfortable using metformin. We used to have pregnancy clinic every Monday. Okay. Monday is the biggest clinic, and it's exclusively seeing pregnant patients. Now you have 20, 25 of them in a queue, and you're treating them. Metformin is your standard medication. So it all depends on how comfortable you are as well. And now when I write, I don't get any questions from obstetricians, but there were times when I was really called as well. I'm speaking about 10 years ago, saying, "Doc, are you sure you know what you're doing?" kind of thing. Then you kind of try to educate them about it. They quote the MIG trial, blah, blah, blah. But yeah, that's all. Even now, I dare say this officially on record, there are endocrinologists who are not comfortable. And that's their choice. Even within the city. And there's no right or wrong. They have their own side of the argument. Some might argue, look, if suddenly delivery happens tomorrow, the patient might go into lactic acidosis. There are some who argue that. But how many times does it happen? It doesn't mean that you have to deplete a person of an invaluable medication with low side effects. And remember, does insulin not cause hypoglycemia? Is hypoglycemia not a serious side effect? So why should you deplete somebody from the benefit of metformin and embrace something which causes hypoglycemia and which is an injectable? So it's all about balancing and you being comfortable.
And also, if you look at the requirement of insulin in the first trimester and second and third trimester, if you are not on metformin, your insulin requirement would be so high in some patients, you can't even physically give them with the pens and syringes. You may have to stick them into a pump. So by just adding metformin, if you can bring down the insulin requirement by say 30-40%, that itself is
and the weight gain. You go back to what he was mentioning, Dr. Kalyan. When insulin resistance is the problem, like your steroid-induced diabetes, you don't routinely use metformin in inpatient scenarios. But there are times when we are using 300, 400 units, when you know that patient is stable enough, when you know heart of hearts, metformin would do more good than harm, you tend to tweak the rules. Rules are there for the benefit of the patient. As long as you can take responsibility and you can stand on your feet, if you were to stand in front of the judge and really justify as to why you used a certain medication, I think you have every ground to use it.
And in audience, anybody has seen metformin-induced lactic acidosis?
I did. I mean, yeah, many a time.
In my beginning of career, I had seen that time fenformin was also there. And it was a patient, he was taking both fenformin, metformin, and lactic acidosis we had documented. That is 27 years back.
Well, I think most of them were born, okay, at least. Okay. See, the problem is metformin along with renal impairment, metformin with AKI, metformin with heart failure. These are bad combinations. Metformin with sepsis. So alone metformin by itself causing lactic acidosis is not something that I have seen. As Sir has mentioned, you need to take everything into context and make sure that the benefits outweigh the risks, just like anything else in life. Right. Any burning questions otherwise? Or can we move on for a quick tea break? I think we're dying for it. We're almost running late. So let's go and grab some tea and back in 5 minutes. Okay? 5 minutes.
Thank you, sir. That was very difficult to cover 4 topics.
of invaluable help for us so that we can improvise on things. We can also understand what went well and what could go well in the future. And last but not the least is there's a questionnaire as well that you filled up at the beginning. If you want to fill it up now, that will be great again. So for the sake of the Zoom audience, we do have some questions that have come up. Most of them have been covered, to be honest. Most of the questions that have come up, or they are out of the remit of today's meeting. Either they are related to oral medications or other stuff, but most of the stuff have been covered, which means that, yeah, I think we seem to have covered most of the important bits at least. So it would be useful if everybody can come in so that we can kickstart. So we do have some questions. If the faculty can please come up, we'll quickly fire these questions if anything is not covered. Insulin, is it safe during pregnancy? I think we covered it, but one-line answers.
Yes.
Yes, it is.
One word.
One word. Good. Can we start with Ryzodec rather than going to basal bolus insulin at dinner as in our part of Kashmir Valley?
Yes. If it's the main meal, yes.
Yes, but we discussed this at length. I don't want to dwell on it again and again. So choose the right insulin in the right person. How to titrate glargine in pregnant women?
The same as how you do with any other patient, that you make sure that they don't have hypo and make sure you hit the fasting target.
Right. How to convert insulin to oral tablets and vice versa?
Insulin to oral tablets, difficult, but you can say probably, if you want to use sulfonylureas, I would use roughly 1 milligram of glimepiride for every 10 to 15 units reduction in insulin. So if you want to convert from insulin to oral during discharge of a patient, that's the rough thing I would use. 1 milligram to reduce is equal to around 10 to 15 units of insulin.
Roughly, yeah. It all depends on the patient's duration of diabetes, what sort of reasons the patient started insulin. If the patient was on inotropes and you're sending on orals, then all this comes into context. How to calculate based on inotropes or steroids? Again, that's important as well.
How to based on?
How to calculate the discharge dose of oral medications or insulin if the person were to be using inotropes and steroids till discharge?
Okay. So basically, if you're on inotropes, you can't be discharged. That's the end of the story. If you are being on steroids, Dr. Kalyan has done a very extensive work.
Very good answer.
So I suppose that woke up many audience here. So are they creditors? Creditors officially no. Unofficially, I hope you got some credit for attending this. So unofficially, yes. But officially, do you get any certificates and points? We are giving certificate out there, but I don't think there are any creditors. From next time, we'll ensure that you get what you want, which is credit points. So I would like to join. Is it free registration? Of course it is. Hyper and hypoinsulin management in children, whatever that means. Management of hypoglycemia and hyperglycemia in children. That's what somebody asked. So,
I mean, if it is type 1 diabetes, I think carbohydrate counting is the answer.
Daphne training or carbohydrate counting or having the ability to adjust insulin doses according to the carbohydrate content that they take. And of course, if things are not helping, insulin pump and CGMS. Sorry, Dr. Mithun, we haven't forgot.
ALP would also be an option.
Yeah, not a bad idea. Not a bad idea at all. But 2 injections, unless you do have the oral SIMA, which is going to come soon. Sir?
Now taken away injection available.
Which ones?
PSP or analog.
Yeah, of course. The biggest problem I find with that is titration. That's the pain. So next case, Mr. Ajit, 45-year-old engineer, 6 years diabetes, type 2, 9.2 A1C, BMI 27, fasting plasma glucose 210, postprandial 250, previous history of hypoglycemia, yes, unfortunately, blood pressure slightly up, cholesterol, dyslipidemia, LDL pretty bad, 174, urine ACR is also up, family history of diabetes, yes, alcohol intake 2 drinks per week, not bad, smoking, non-smoker, exercise irregular, medical history to some mate, type 2 diabetic for 6 years, hypertension for 7 years, dyslipidemia, which is pretty bad and uncontrolled. Coming to medications, just on metformin, glimepiride, empagliflozin. I repeat, metformin, glimepiride, empagliflozin. So primary challenges, 1, uncontrolled hyperglycemia, we all agree. Let's look at the A1C there. A1C is 9.2. Subject has a hectic work life and fears insulin initiation, just like many of our patients. He thinks that would affect work-life balance due to hypoglycemia risk. Travels often and unsure about taking insulin at fixed times daily. So patient is really not sure. So what would you do? Next. Any volunteers from delegates? Delegates, you're not a delegate as yet. Ma'am, you're about to say something. Our patient, yeah, does. You would like to go for weekly once GLP? Yeah, not a bad idea. Yeah. Probably not much. 0.1 benefit of A1C or 0.2 max if you're lucky. Well, that keeps them happy. Yeah, definitely an option. But would it bring down to 7 A1C? I don't know. It probably would bring to 7.7. That's it, if you go by statistics. Ma'am?
Not unless I had also there.
You need something. You need insulin. Let's accept that. Okay. So imagine you have added semaglutide or once weekly Dula. Okay. So imagine, sir, and A1C is still 7.7. What would you do next? Sema, you are on pretty maximal dosage, ma'am. Dula, you are on pretty maximum dose. Yeah, you don't have a choice but to embrace insulin at some point for this person pretty soon. You can always negotiate with the patient. 1 month later, come back and see me with your glucometer readings, as we discussed earlier this morning. That's a negotiation point. Okay, that's an unwritten contract. Document that. So to come back after 1 month and let's see how it goes. Anything you want to say, Dr. Modi? Agreed or?
Many times, if baseline is high, then reduction also will be more.
Yeah, exactly.
So it may come down to 7.
So it comes to 7, sir, then you can add 7 or 7.2 with the dulaglutide. So why to go for insulin and add the OB or whatever you got other agents?
You got 5 agents, you mean? Well.
There is this study of landmark trial which suggested that after adding 3 agents, if you add a 4th agent, it's not really going to bring that down.
Multiple agents may not. So.
But they are not optimal. They are not full doses. The metformin are only on 500 ppm.
Yeah, so maybe 0.2% better A1C. Okay, I give you credit to all your metformin dose titrations. Anything else you want to? No. And remember, he says, he's not going to exercise. He's categorical about it. No negotiation line there. Right. So I think we're done with the 2 CVDs, unless there are any burning questions out there. I would be really thankful if you guys can fill up the questionnaires there and the feedback. That would really help us improvise things. I really appreciate that. And may I request Dr. Mithun, the secretary, to kindly give vote of thanks.
I think on behalf of ACE, I would thank Novo Nordisk for arranging this. And I would thank all the faculty members, Dr. Modi, Dr. Murli, Dr. Kalyan, and myself and Ravi for this. But more importantly, I would thank people to come and spend time. We learned a lot from each other, and I think that is how we grow as better doctors. With that, on behalf of ACE, I thank you very much. Thank you.
Special thanks and really, I mean it, to Dr. Modi sir for coming out on a Sunday afternoon. And I can't help but thank Dr. Kalyan, who chipped in the last minute. And of course, Novo for all the hard work that they have done, especially during this testing. Thank you very much. Neil. Yeah, I mean, without the audio-visual help, nothing would happen. Okay, RX events have done a fantastic job, and do not forget the hotel guys as well, who are ever so cooperating. You want to say something? You said you were going to say it more. Yeah, we're soon going to have advanced version of this as well. It's going to be the next level one, be it insulin pumps, CGMS that we discussed, to keep Dr. Mithun Bhartia happy. And Kalyan happy with the insulin pumps. Okay, and of course, pregnant women and Dr. Modi can always, give out his heart on only one topic. We won't actually follow him with four in one or 5 in 1 next time. He's done a fantastic job despite putting all 4 in 1. But next time we'll make sure that we have only one be pregnant. So each would be individualized. Pregnant women, gestational diabetes, okay. Peds. Okay, we'll also have teenagers. We'll also have other topics such as pregnancy, such as kidney problems, liver problems on their own. So we'll have a full proper house at the next level. So do see you soon. And we're going to roll out this to other cities as well. What has happened here? It will happen physically in other parts of it. Thank you very much. Once again. Thank you. Sir, quick group photo if that's okay. All the delegates can come over. Please. Yeah. So we can remove the cups. Let me do that.